आप टाइम पर है, बिल्कुल समय पर है आप एकदम।
थैंक यू गॉड ब्लेस यू।
Ma'am, shall we start, because Basanta ma'am will take in between, she will join, ma'am.
Okay.
Okay. All the best to the presenters. So Sasmita ma'am, you can start your presentation.
Good morning, everybody. I am Sasmita Panigrahi. First of all, I am very much thankful to the organizer and the jury member to give me once more chance to present today. Because of yesterday, some connectivity issue, I was unable to present. And I'm going to present my paper on psychological state and its related factor during COVID-19 outbreak. A cross-sectional study was conducted in Odisha. In last 2 decades, several infectious diseases have shaken the human civilization due to viral outbreak like SARS, H1N1, MERS, and now COVID-19. This deadly outbreak was emerged from China in December 2019 and became pandemic within 3 months. And we everybody know that India is the most affected country with more than 6.2 million cases and near about 97,000 deaths till now. Outbreak of infectious disease not only cause the physical problem, but it also causes psychological problems like panic disorder, depression, anxiety, and many more. The psychological problems are not only due to the mortality and morbidity associated with the COVID-19, but because of fast spreading of the disease, continuous flushing of the COVID-related update, loss of job, closure of the educational institution, and closure of the international travel and all. The finding of the study will have a great practical significance to understand the psychological state of the general population and to identify factors influencing during this COVID-19 outbreak. And based on the finding, guideline can be formulated for the intervention, and the study finding for the preparedness and to plan any particular measure against these infectious diseases in future also. The main objective of the study are to assess the psychological distress of people during COVID-19 outbreak, to determine factor influencing the psychological distress during this COVID-19 outbreak as a whole. The methodology was quantitative research approach was adopted. Research design was descriptive survey research design. Setting is all over the Odisha. Population was general people of Odisha who are above the age of 16 and able to answer the questionnaire digitally. Any Odia people who are residing in the Odisha and understand English and able to answer by the digital platform at the sample size was 382. By using the OpenAP software, it was calculated, and by following the previous study 1/Airtel to 2020 with confidence limit of 5%, population 1 million was considered as per the guideline of the OpenAP software, and incidence was 53.8%. Sampling technique was followed, convenient sampling technique. Any participant who are not willing to participate in this study and unable to read, write, and understand English, unable to answer through digital platform are excluded to participate in the study. In the tool which was used to assess the psychological distress was having 3 sections. Section 1 is demographic profile, which mainly include the age, gender, education, occupation, marital status, whether healthcare provider or not, contact with the COVID-19 patient, and comorbid disease condition. Section 2 was questionnaire to assess the psychological distress during this COVID-19 outbreak, and it was a modified like scale of Kessler-10 scale. And the content was validated by giving to concerned field of experts, and in reliability also calculated, and permission also obtained from the author. Contributing factors for the psychological distress mainly include lockdown, social stigma, domestic violence, online education of the child, then loss of job, facing problem to get the food and all, whether they are satisfied with the government preventive protocols or not, And these all nearby 15 factors are there, which was included in the section 3. In the section 2, actually this is a rating scale ranging from 0 to 4. Total 12 parameters are there. Total score was 48. Higher the score indicated more degree of psychological distress. Score less than 12 indicates no psychological distress. 13 to 24 mild degree, 25 to 36 moderate degree, and more than 36 was severe degree of psychological distress. Data was collected. The questionnaire was developed in the Google form, and link was shared in social platforms, specifically in Facebook and WhatsApp, to reach the people of Odisha. Ethical approval was obtained from the Institutional Ethical Committee of AIIMS Bhubaneswar. Data was analyzed by using SPSS version 20 software, and sample was collected from 12th May 2020 to 20th June 2020. After analysis, we found in the general characteristic of the study population, out of 611 respondents, 50.7 were male, and same percentage were belong to the age group of 16 to 30 years. 42.4 were graduate, 31.6 were unemployed. 51% of the study participants found less than 13,160 rupees per month income. 60.4% belong to the urban area. 97.5% does not came in contact with the COVID-19 positive patients. Still, we'll see in the letter stress level is high. And 18.7 were the healthcare providers. 14.4 respondents are having the comorbid disease condition like thyroid, cholesterol, hypertension, diabetes, asthma, and all. If we see the degree of psychological distress, highest 61.7% were not having psychological distress, 32.7 are mild, 4.7 are moderate, and only 1.2% had severe degree of psychological distress. Actually, as the data was collected from 12th May to 20th June, so actually all country lockdown was there up to 31st May. So we have divided the total response into two categories, during lockdown and post-lockdown. The response we got up to 31st May was during lockdown, and from 1st to 20th June was post-lockdown period. And it was shown, see, in during the lockdown period, the stress score was significantly high, 11.7 for mean score with standard deviation of 8.77, which was quite low during the post-lockdown period. And to see the association t-test was calculated, it was 2.613, which was less than 0.5% level of significance. It shows that lockdown is significantly associated with the psychological distress. To identify the contributing factor, first we have calculated the chi-square for the demographic profile and the contributing factor, and it was shown education, occupation, habitation, and healthcare worker, comorbid disease condition, fear of getting COVID-19, feeling stressed due to lockdown, worried because of continuous wear of mask and frequent hand washing, stress due to continuous COVID-related news flashing in the mass media and the news channel, worried due to non-availability of the treatment, and compromise in financial security. It was found statistically significant, that is P less than 0.5 in the chi-square. After that, to identify the actual factor which is creating the psychological distress, we have calculated the binary logistic regression. This is the odds ratio and confidence interval of 95% is confidence interval, and it was found comorbid disease condition was those individuals who are having the comorbid disease condition are more likely to develop 1.62 times of psychological distress than those who are not having. Similarly, lockdown is also increases 3.017 times stress, psychological distress during this outbreak, and this continuous watching or flashing of the COVID-related update increases 1.752 times psychological distress. That is the odds ratio in binary logistic regression. So in the study, let's move to the discussion part. In the study, we found 38.5% were having the psychological distress and 61% are not having the psychological distress. Similar finding was obtained in another study, that is Wang Wai et al., which revealed near about similar percentage, 53.8 percentage, but a contradictory statement we got in a study by Jun Jen et al, where it was found 18.5% was having the psychological distress. Similar study was conducted in India, where it was found 77.2, which is similar to our findings, are not having the psychological distress. Only 20.2 are having the mild, and 2.7 are having severe psychological distress. Yesterday also many had presented some study, like they found the psychological distress are more among the healthcare provider, and also another study which was conducted in Turkey. It was found 54.5% of the nurse and midwife having the psychological distress, and 42.6 wanted to psychological support, and 11.8% has alienated from their profession. But in our study we found a contradictory statement, that is psychological distress was a bit low among the healthcare provider, maybe because of the underrepresentation of the sample. In our study sample, only 18% are belongs to healthcare provider. Maybe because of low sample, we may got the less finding. And in Wang Wai et al study, it was found education, occupation, habitation, comorbidity are significantly associated with the psychological distress. Similar finding also obtained in our study. So main limitation of our study was mainly the individual who are able to access the digital platform, or who are able to understand the English and all, they only can participate in the study. This is one of the most limitation of our study. Recommendation of this type of study can be conducted throughout the India or in any other setting, or can be evaluated. The psychological distress also can be evaluated by giving some kind of intervention. The effectiveness also we can evaluate. So at the end, I would like to conclude, out of 601 participants, 38.5% were having the psychological distress, which was improved after release of the lockdown, but not that much satisfactorily. This finding can be used by the state authority of Odisha to formulate psychological intervention for improving the mental health status of vulnerable section of the society during this COVID-19 pandemic situation, so that any kind of psychological ill health or suicide or any kind of psychological morbidities we can avoid. These are the reference I have. These are the papers mainly I have referred for preparing this study. At the end, thank you all. If anybody is having any question, please ask.
Sashmita, stop sharing your PPT, your screen.
Yes, ma'am.
Please mute yourself. Some sounds are coming from the background. Sushmita, it was a very good presentation, and very nicely you have explained the full methodology and the significance and your findings. And in the discussion, you have related the previous studies also. It was really very good one study and very useful one. Only I have few questions. Like you said, in the significance, India was most affected, you said, or not most affected?
Most affected, second position.
But if you see, you could have given the data, India was affected due to higher population. If you see percentage wise, the number of deaths were very less. It was mild cases mainly. So you cannot say most affected. Okay, you have to then give the prevalence or the incidence of all the countries, then you should compare. If you see, as per the population, India was not affected that much. And we had a different type of slums, resettlement colonies, villages, urban areas, and density population we had. In that way, it was not affected so much. So when you give this type of statement, you have to be very careful. And you have to statistically write, if you are saying, because death rate was very good, recovery rate was very, death rate was very less, and recovery rate was very good in India. And India had mostly mild cases. what was the how many patients were admitted in ICU? Mostly the ICUs hardly had patients. Only in the peak time there were few ICUs that were filled with the patients with the COVID. So you should see all the scenarios. Okay, you cannot give any statement like that. And the second thing was, you said your sample was 382 when you calculated, but you have received 611 replies. So I could not understand this. Why so?
Yeah, I had the same question. Yes.
Yeah. So you have to explain this. Then second thing is, have you in your population, you said the people 61% has no psychological distress, 38.5% has. Have you seen their income group? In which government sector they were working or a private sector they were working? What was their income? How many members in the family were having the income source? How many have lost the job during this time? So I am afraid this 61% no psychological distress. See, in our studies, what we do, we only statistically we prove everything. But
Yes.
what is the actual situation at the ground level? What are the underlying factors altogether missing in your study? Okay. So that is very important. Just proving it statistically significant and non-significant is not enough. If you actually want to do study, you should know the underlying causes. You should know the details. There are thousands of people who have lost the job during this COVID time, lockdown period. There are so many people who are working from home in the private sector and they have so much of psychological distress because when they were going to their office, they had a fixed timing of working. But sitting at the home, they were working for more hours.
24 hours, yeah,
They have
24
to
hours.
look af- yeah, they have to look after the household work also. So these are the issues which I found are missing. That's what I wanted to tell you. Thank you so much.
Same thing I would also like to say. Even I too felt, I like to know better ki how did you collect this sample? Matlab, how did you choose this sample? On what basis? Because digital questionnaire, it's okay. But what was the criteria of selecting this sample? As madam said, those groups should have come in between and you could have found in your questionnaire also demographic data, all those things. So can you share your?
Ma'am, can I tell now? Can I say
Yeah,
the
yeah.
justification?
Yes,
Surely,
yes.
surely.
Yes, ma'am. First, I'll like to explain regarding the sample size. Sample size was calculated 382, but actually in the digital platform, what happened? Like some may answer reply twice, or some miss wrong findings or incomplete response may be there. In the
How
sample
do
size
they,
is
how, sorry, excuse me. I want to know how they came to know you are doing a study and they were in your contact.
Ma'am,
Yeah.
That's what
one
I'm
by
asking.
ma'am, I'm explaining one by one. Ma'am, regarding first, I'll tell the sample size, then I'll move to the how I have selected sample size.
Don't go detail, just one word. Just one
Okay.
word. Don't, we have no time.
The tool which was developed, it was filled in the imported to the Google form. Then the link was shared in the WhatsApp and Messenger, Facebook, in the social media I have sent. Then
So your own people have joined with you, है ना?
sorry, ma'am.
People whom you knew, you have spread this message.
Initially, I spread them, then sent to their known, like their known people, their relatives, and all, like
I
that.
got the idea. That's why you could not contact other people.
Yes, ma'am. Then in sample size 382 was calculated, means this is the minimum. So actually, maybe there may be some wrong or incomplete responses. That's why we have some extra time we have given. So after scaling all the thing, it was found to be 611. That's why we have considered that one. Then next thing is that regarding the education and occupation, we have calculated. I am just sharing the PPT now again. In the
Vinu sir?
No need
Oh,
to. No need
my
to
picture
share.
is not there, no, because
Ma'am,
my
you
video
can
is not
say-
coming, I
you can
No
suppose.
need to
I'm able to see
share.
her. I'm seeing everything, but I am not able to come into the scene. I think there is some issue with my camera.
Please, no need to share. No need to share. We don't want this. What we are asking is,
Oh,
Ma'am,
can
in
you
the
do one thing?
occupation-
Shall I leave it and come again?
Ma'am, in the occupation, it was found the
No,
psychology.
I'm able to see everybody, sir. I'm able to see. No, I'm able to see. I'm seeing. I have seen Sachmitas.
Ma'am, actually, the sample after collecting the data, when we have we find out the risk factor during that time, we have converted to dichotomous, like no distress and having distress, and it was found those who are having unskilled laborer and having income less than 10,000, they are having more stress, madam.
no, you have to go in the depth. I don't
Okay, ma'am.
agree with this. See, even people who are educated, working in universities, working in multinational companies, they had distress. They were more distressed. So this has to go in depth actually. Just statistically proving is not enough in these type of studies.
Okay, ma'am.
Unless you find the underlying causes, how you, and see, you are sending electronically your tool. How many people have understood your technical terms? You don't know.
Yes, ma'am.
Sometimes people just tick mark for the sake of giving you the data. What is the authenticity of this data? Do they understand what is psychological distress? Have you defined to them? Have you given them a definition? So those things are very important. Okay.
Okay, ma'am.
Smita, I have one question. How did you manage the ethical aspect when you are doing this digitally?
Ma'am,
Ethical consideration, how you're done?
Ma'am, initially we have obtained the ethical approval from the institute, and in the first section of the Google form, it was mentioned regarding the study. If anybody is willing to, regarding the study, its purpose, everything we have mentioned. If anybody is interested, if not, then they will not.
Have they given you informed consent?
Their response is considered consent.
No, no. It is not like that. You cannot consider
No,
their
ma'am. Informed
response
consent
as a
actually
consent. But you
regarding the
have to,
study.
you have to have a
Regarding the-
proper consent. No, see, you should know the proper procedure. What madam is asking is a correct. First, you should have a consent. Then you should send your question in.
The form beta. It is like that, Sashmita. First you get a consent, and then if it is attached, they think it is part of it. Just they will tick, tick, tick and go. But first is the consent, and then the study will start.
Ma'am, in the section 1, ma'am, in the first page of the Google form regarding the study, its purpose is the total consent of our
Have they
institute.
given you? Have they given
Yes,
you their, just one
Yes,
minute?
ma'am.
Have they given you their signature and details?
No, ma'am. They have to click the I agree.
No,
I agree,
no,
then next.
no, no. This is wrong.
Okay, ma'am. Okay.
This is wrong. See, what you have done as a researcher, you have taken the advantage of the situation, just giving I agree option. You have not given them the option to sign the consent form. They do not know as a lay person that they have to give a consent. But as a researcher, it is your duty first to take consent. Then you could have shared your questionnaire only with those participants who are willing to participate. This is not the way of taking a consent.
Okay, ma'am.
Okay, Sashmita, but the topic was very good, and you were very confident and
Yes,
very
yeah.
fluent. I agree with you. Your PPT was also very clear and concise. But certain things which Madam Nirja and Madam Maya and others, Vasanta Madam and myself, we have brought out, that has to be, you have to critically think about that as a researcher. Okay?
Okay, ma'am. Thank you, ma'am.
It was very good. Thank you so much.
Thank you, ma'am.
Thank you, ma'am. Thank you so much. And Dr. Rita, ma'am, please be ready and for that presentation.
Yeah, I'm ready, sir. Can I share my screen,
Yeah.
please?
Jury members, Rita, ma'am, can you start the presentation?
Yeah, sure.
Yes.
Yes.
Yeah, please, ma'am, proceed.
Yeah. Good morning to the honorable judges and the viewers. I am from this vibrant city, Mumbai. I'm from this vibrant city, Mumbai, and my warm greetings to each one of you.
Thank you so much.
Before I could start, may I ask, is my screen visible? And may I also ask if I'm audible? Yes.
Yeah, you are audible and you are visible as well.
Thank you so much. So what I propose to do in the next 10 minutes is I would present my research title. I would talk about the purpose of the study, the literature behind it, the methodology that I have used, the major findings of the study, the limitations, the future implications, and of course, I need to acknowledge my people who have supported me in this study. So my title of the study, it is Clinical Validation of Defining Characteristics, Excess Fluid Volume in Patients on Hemodialysis Diagnosed with CKD using Ferring's CDV model in a selected hospital in Mumbai, India. A nursing diagnosis is defined as a clinical judgment about individual, family, or community responses to actual or potential health problems or life processes, which provides the basis for selection of nursing interventions and to achieve outcomes for which only the nurse is accountable. Validation of the defining characteristics of a diagnosis is frequently cited theme, especially by Nanda, as it strengthens clinical practice and nurse-sensitive outcomes. And certainly, it's a strong base for understanding the validity of our standardized nursing language, because I'm sure all of us know that the nursing diagnosis is considered to be the standardized nursing language for nurses. Nursing diagnosis, therefore, must have a consistent theoretical argument based on the literature, and it should be confirmed in the clinical setting. The current structure of Nanda's nursing diagnosis is referred to as a taxonomy 2 and has got 3 levels: the 13 domains, the 47 classes, and 237 diagnoses. And I've taken one of those diagnoses. Before I actually enter into my diagnosis, I would just like to have a quick review about the components, the 3-part components of the Nanda nursing diagnosis. We know that we have a diagnostic label, which is having a related to factor, which is an etiology, and then this etiology, this diagnosis is evidenced by signs and symptoms or the defining features. So for example, if I have a patient who's coming to me with acute coronary syndrome, I have the diagnosis acute pain, which is related to tissue ischemia, and it is evidenced by pain rating of 8 to 10, grimacing, guarding behavior, so on and so forth. So excess fluid volume is a diagnosis that I have picked up, and it is a frequent nursing diagnosis in chronic kidney disease patients who are on hemodialysis. Cecilia Maria has said in her research that 99.4% of her patients presented with excess fluid volume, and Povita Vanessa and Maria Isabel, both in their studies, have reported 84% of their patients presented with excess fluid volume. This diagnosis is included in the safety protection domain of Nanda nursing diagnosis. When I did a review of this related to this diagnosis, I found there was one literature review, which was a cross-sectional study done on 32 heart failure patients by Martins, Quinney et al. In 2011. She's concluded that the DCs, that is the defining characteristics with high reliability index for R, whether R was above 0.8 for dyspnea, orthopnea, edema, positive hepatojugular reflex, paroxysmal nocturnal dyspnea, pulmonary congestion, and elevated CVP. And the secondary DCs, where the R was equal to 0.5 to 0.79, were weight gain, hepatomegaly, raised JVP, jugular venous pressure, crackles, oliguria, decreased hematocrit, and hemoglobin. The second literature review that I got, which was very closely related to my research, and in fact, this research and my pilot study has come out during the same time in the year 2015. My pilot study is in the Virginia Henderson repository, and this particular study, which was done by Maria Isabel, it was a cross-sectional study on 100 patients on the same diagnosis with hemodialysis patient. So she has said the more accurate defining characteristics considered valid for the diagnostic inference of excess fluid volume in patients undergoing hemodialysis were edema, pulmonary congestion, adventitious breath sounds, and restlessness. So I felt that there's a definite gap, a gap that's evidence regarding clinical validation studies for Nanda diagnosis fluid volume excess, especially in CKD patients. Thus, it stands as one amongst the other which is invited for validation by Nanda. So diagnostic studies are always generally incipient, and it is being very clearly reported by Mendes. And it will be important for all of us to note that we do not have a single study in Indian context. So the aim of my study was to validate the defining characteristics of the nursing diagnosis excess fluid volume using a selected sample of patients diagnosed with CKD in their pre-hemodialysis period. That is, I wanted to know which clinic DCs, which DCs the nurses consider as primary and secondary. So my specific objectives were, the first was I wanted to validate the developed observation tool with the DCs that were operationally defined for the nursing diagnosis excessive fluid volume in the time period prior to hemodialysis. The second was I wanted to analyze which DCs the clinical nurses assessed as primary and as secondary in the nursing diagnosis excessive fluid volume in the time period prior to hemodialysis. And finally, I wanted to correlate the validated diagnosis with that of Nanda 1 nomenclature. So the hypothesis that I went with, which was based upon my pilot study, was Nanda nursing diagnosis excessive fluid volume will not be valid in the time period prior to hemodialysis in patients with CKD. And I took the confidence level at 0.95%. So my research methodology, my design, it's a cross-case series comparative clinical validation study. It was done in a setting of a daycare hemodialysis unit at a JCI accredited hospital. I took 200 patients which were conveniently recruited in the study. The tools that I had was one very important tool, as I've said in my objective. It was an observation scale, which was a Likert scale, a 2-point forced choice, whether the DC was present in the patient or was absent in the patient. The sample that I recruited, the inclusion criteria were to present CKD and be undergoing hemodialysis treatment and to be aged above 18 years or over. The exclusion criteria were having impaired physical and mental conditions that prevented the collection of all items of the instrument. So this is how I designed my study. I had my first stage. In my first stage, I identified 32 defining characteristics, which were found. 27 were as stated by Nanda and 5 are out of my literature review. Then the operational definitions were selected for each disease. Once the operational definitions were defined for each disease, I invited 11 experts from the region of Mumbai. I wanted them to agree or disagree on the disease and its definitions. Since I could not collect all the experts at one point of time, I had to do it over 4 rounds, and the content validity index that I got was 1. So this is my process validation workflow. I have used the Pharynx content diagnostic validity model. One of my experts was having an experience of 4 years in the critical care nursing and working in the hemodialysis unit for the past 2 years. And she also had an experience of 2 years, teaching experience for 2 years. She has used nursing care plan, and in this unit, in this hospital where we were working, nursing care plan is mandatory, being JCI accredited. The second expert was me. I had then 19 years of teaching experience and 3 years of clinical experience, teaching and checking nursing care plan, and I had published researches related to nursing care plan in context to its validity. So based upon the Pharynx CTV model, the DCs that had a reliability equal to or above 8 were considered to be primary or major DCs, and those that had a reliability of 0.5 to 0.779 were considered secondary or minor, and others have to be discarded as per Pharynx CTV model. I'm sure we all will agree that every research is a tentative step until the results have been confirmed with repeated studies or with a generalizable study. So even if I propose to present this and send it across to Nanda, they would keep it in the repository to ensure that some more researchers come this way and they confirm the findings to be generalizable. My weighted inter-rater reliability ratio for each defining characteristic was based upon reliability. I did an ethical clearance both at the college level and at the hospital level, and I ensured that the consent form was in place, and the consent form was signed by each and every patient in front of both of the experts. The data collection was done during the period February 2018 to November 2018. The major findings of my study: 92% of the respondents belong to the age group 45 to 75 years. The mean age was 58.1. 82% of the respondents were male, unlike most other studies where it has been found that almost 50 to 60, 54 to 60% of the patients are male and the others are females. Here I got a lot of lead on male patients. So 82% of the respondents were males. Majority of the respondents in the present study were married, educated up to 10th standard, belonged to high middle socioeconomic status, living a sedentary lifestyle with no erections. 85% of them had this diagnosis for less than 5 years of duration. And amongst these patients, I had 92% of the patients who had CKD and 8% of the patients who had end-stage renal disease. The other comorbidities that were present in the patient is 37% of the patients had hypertension. Another 37% of the patient had both diabetes and hypertension. 13% of the patient had only diabetes. And when you look at the blue color, the other comorbidities that I found, they were major ischemic heart disease and thyroid problem. 100% of my patients presented with excess fluid volume, unlike what Maria has got. Maria got only 82% of the patients who presented with excess fluid volume. I found that patients find it very difficult to follow recommended water restrictions, and this is what proved in the literature also. Now, these are the defining characteristics that I present in front of you. So my defining characteristics with a reliability index of 1 to up to 0.8 are the first 10. That is variation in serum electrolytes, azotemia, intake exceeding output, weight gain, oliguria, decreased hematocrit, decreased hemoglobin, edema may progress to anasarca, alterations in blood pressure, and fatigue. The ones that I have star marked are the ones that are not there in the Nanda nomenclature, and they have been included through review of literature. Minor DCs were alterations in respiratory pattern, adventitious breath sounds, lack of appetite, activity intolerance. The discarded DCs were anxiety. This is as per the CDP model. Where there is anything less than 0.5, I need to discard it. So the discarded one, anxiety, cough, bounding pulse. Cough and bounding pulse I had got through review of literature. Orthopnea, PNT, increased CVP, jugular vein distension, positive hepatojugular reflex, ascites, restlessness, seizure, pulmonary congestion, alterations in pulmonary artery pressure, pleural effusion, presence of S3 sounds, palpitations, hepatomegaly, alterations in mental status. Regarding the diagnostic accuracy of the defining characteristics of the excess fluid volume diagnosis, the characteristic with greater sensitivity in my research was edema, 100%, weight gain, 100%, and alterations in BP, which I found in 93% of the patients. Although the characteristics decreased hematocrit, anxiety, azotemia presented sensitivities, they did not present statistically significant likelihood diagnostic odds ratio. Therefore, they were not considered important characteristics to identify of the diagnostic study, which was even stated by Maria in her study in 2015. So the conclusion is, the more accurate defining characteristics considered valid for the diagnostic inference of excess fluid volume in patients undergoing hemodialysis for edema, weight gain, alteration in respiration, adventitious breath sounds, fatigue, and activity intolerance. Thus, in the presence of these, the nurse may safely assume the presence of the diagnosis that is being studied. The important limitation of my study is the development of the study was the fact the study was carried out with a specific population of CKD patients undergoing hemodialysis, limiting the generalization of the results to similar populations only. Thus, diagnostic accuracy studies should be encouraged for other populations, considering that research on this topic will increase the scientific nursing knowledge and assist in clinical practice. So my final absolute conclusion is, since the research has validated 3 of the DCs, activity intolerance, fatigue, and lack of appetite, taken from review of literature as clinically relevant to validate this diagnosis, therefore their inclusion into the current DCs in Nanda 2 nomenclature is suggested. And the novelty of this study is the first research to do the content and clinical validation in the content context. I humbly acknowledge all my patients who contributed to the study. First, I had 60 patients, then I have moved on to 200 patients, which I'm moving on and making a target of 500 as required by NAMDA. And of course, acknowledge my first success and many more others, and including the Nurse Association was allowed me to present the study. These sentences. Thank you. I keep my presentation open. Any questions, I would be happy to.
Yeah, Maya madam and Vasanta, you can start.
Good morning, madam. Good morning to all. I'm sorry, again, network issues in Ethiopia. We are suffering. Thank you for the patience, madam. I think I can ask my mother to start, then the child will do.
Ma'am, Maya ma'am, unmute.
Maya ma'am, not able to hear you. Maya ma'am.
Rita madam, you have presented very nicely, organized way, and everything was very nice.
Thank you so much, ma'am. Thank you.
Only one thing I like to know, that after doing such a good study in hemodialysis patient and all, 100 patient you could get easily, madam?
I got 200 patients because every day in my unit, I have about 20 patients coming for hemodialysis. So I could select quite a lot of study, and I've done my period for a long period of time. So I can take
Same
200.
hospital you got the whole patient?
Yes, ma'am. Same hospital I've got all the patients.
So how your study will be helpful for the patients that problem to be solved? Matlab, you have only found out the complications and other thing because of excessive fluid.
Yes, ma'am.
What is exactly you wanted? Matlab, that your objective, if you could have brought that nurses, how they can help something?
And what I feel is nurses, when they're working in the clinical area, they need to diagnose. Nursing diagnosis is very important.
Okay.
So if they diagnose correctly, they'll be able to give the appropriate care. So it is very important, if the diagnosis is correct, the patients will get the right kind of care. Many times we have seen in the clinical area that the nurses don't diagnose and the care is not appropriate.
So you have only found out how they are diagnosis, matlab doing diagnosis.
I wouldn't say that I have found out how the nurses are diagnosing. I wanted to look at the taxonomy. The taxonomy has given us total diagnosis of 27, the defining features. I wanted to see, are these defining features applicable in CKD patients? So I wanted to strengthen my standardized nursing language, which is proposed by NAMDA taxonomy.
So you could have trained them and take 1 week and then see whether there is change or not, nothing like that.
Oh, nothing.
In my area where I did this
because
research,
you have said from February to November, you have taken such a long period. So there was enough time for that. I think so. I don't know. Madam Suri will share that.
I appreciate the thought that Mani you have said. This is not a part of my study, but in our area, we have continuous development of nursing care plan and understanding given to our patients. So from this study, I was not able to identify what were the problems in the nurses. I have just tried to see the content validity of the taxonomy. So if the taxonomy that we have is strong, I wanted to see that the nurse, I wanted to ensure that the nurses are able to diagnose it correctly.
Vasanta, you can.
Thank you, madam. Thank you so much. And Rita, madam, I think this is the third time I'm seeing you. Nice meeting you. And it was a very good presentation, because we couldn't. I'm also a reviewer of many journals, and I'm not able to find out very good journals. And these type of studies are mainly done by the foreign people. Most of the time, this type of studies are not taken, because this type of risk is not taken by the Indian authors, I suppose. I think for that I have to give you a lot of applause, ma'am. And you're taken into Nanda too, as Maya madam was telling. But if you have done the implementation, if you have done something where you have just found out because it's like you're told it's going to be entered into the taxonomy, where you're using the Pharynx CDV model, which is mainly to validate the nursing diagnosis. I can understand the topic is mainly for the validation. But if you have made the nurses to identify this, and if you have brought out, I think this would have been the scope of the particular diagnosis problem what you have selected. I think it would have increased more. That's what we are trying to help you, ma'am. Who were the experts for you, ma'am? Who gave the validation for you, ma'am?
I had 11 medical surgical people, Of them, 2 were people who were doctors who were working in the renal department. Of the medical surgical people, I did not have anyone who had specialization in urology and nephrology. So I had general medical surgical nurses. I preferred to pick up critical care nurses. So I managed to get 6 of the critical care nurses. Others were with other specialization.
Any foreign, anybody, international persons you have selected, ma'am?
Ma'am, international person, can I name her?
No need to name, ma'am, but you have taken international.
Yes, I have taken one person, but she was not physically present. She was there online to support us when we were doing this. So she came on the last session to confirm it.
Okay.
I had
Thank
4
you, ma'am.
rounds.
Okay. Thank you. No more questions, ma'am. Thank you so much, ma'am.
Thank you so much.
Okay, Neeraja Vada will be there to give a lot of inputs.
My
Support
blessings.
us.
Absolutely.
Hi Rita, how are you? It's nice to meet you, and it was a very different study and good study. And I agree with Maya madam and Vasanta. You have chosen a very different area. But yes, I do also agree if the actually how nurses diagnose would have been implemented actually, this would have given the really a good you can say recommendations and the implications for the future in nursing. But again, my question is, you have taken the hospital, it is your own hospitals where you have done?
Yes, ma'am.
Okay, and you have collected yourself the data because you have administrative duties or responsibilities also, or you have taken the help of someone?
It is the previous organization that I was working, not the current organization, because our present organization is just NABH credited. My previous organization was JCI accredited.
So you have gone there, or you have
yes.
taken the help of someone to collect it?
I have done it personally myself. So my second expert was a person who was working in the clinical area, and I was the second expert.
Okay. So one thing more, actually, if you see, these are few hospitals, maybe the big hospitals who are accredited. I don't know how much freedom is given to nurses to actually diagnose. And there may be limited hospitals who are actually making a nursing care plan and using a nursing process. Mostly in the government institution, even the nurses' records are taken away when they send the case sheet to the MRD department. So that is a big question. If your study can, because you have taken only CKD, if you take some general disease.
Yes, I agree. That's a limitation of my study, which I've acknowledged.
Yes. So then maybe then you train the nurses and see the impact. Right. I think then it will be much more useful, because nursing, I don't think so how it may be 0.5 or the 1% of hospitals in all over India may be considering the nursing diagnosis. And actually nurses are making nursing care plan. It is not their fault because there is a workload. If a nurse is having 1:50 or 1:100 or 1:200 patient in evening and night duty, it is impossible. Yeah. So what will be the use, except taxonomy part? I agree, it is an excellent contribution. But actually in the practical practice area, what will be the use of this study? I think if you widen your study in the second phase, it will be very useful.
Yes, yes.
That is this thing. And mainly, I think that's what I wanted to say. Any conflict of interest you have in this?
No, ma'am, no conflict. I'm sorry I didn't mention that.
Yeah, so that is important, because in these type of studies, it is very important to mention any conflict of interest.
True.
Thank you so much. And Bharti madam, if she can.
Yeah. You obtain consent from the service users, Rita?
Yes, ma'am. Yes.
No, my question is that mostly the CKD patients have altered sensorium, and you have also mentioned that their mental status is altered. So, how means it was justifiable that you could get proper consent from them?
I want to take you to those hemodialysis unit where patients come for hemodialysis. When they're coming for hemodialysis 3 times in a week, they don't have all these problems. And I have further ensured in my exclusion criteria, if the patients have these kind of things, I've excluded them from the study.
Okay. That's fine. That's fine. But one thing is that it's a different study. And another important thing I want to acknowledge, your PPT was very good.
Yes.
You have taken a lot of effort to make the PPT, and that was really very good, very impressive.
Thank you so much.
Congratulations for that. But as others have said, if you can extend the study and you can include some nursing personnel and they see their impact, how they are going to diagnose and those things, that would have been much better. And I hope in future you will think about it.
Yes, yes, sure.
And
All
we
the
can
best.
take some common diagnosis where nurses
Yeah,
will be
yes,
in the future allowed to do the practice also,
Okay.
especially in the MCH area, primary health area, because your nurse practitioner is going to come. So
Right,
it will be a
right.
good contribution for the nurse practitioner.
Right, right.
yeah,
Thank you so much.
Thank you.
Thanks
yeah.
for the suggestions. Because I'm continuing with the study, so thank you so much.
Right.
Shrita ma'am, on all the respective jury members.
Any questions from the participants? You can see if there is any.
No, ma'am.
Okay.
I think madam has done her job very nicely. So no QA questions arisen over here. Thank you all the jury members for your respected and valuable comments. Thank you so much, ma'am, for a wonderful presentation.
Thank you so
Next,
much.
I would like to request Shilpa ma'am to get her presentation ready.
Good morning, ma'am. Good morning. Good morning.
Good morning.
Ma'am, am I audible and my screen you're able to see?
Please open your PPT.
It's
Yeah.
open, madam.
No, we are not able to see.
No,
your
we are not able to see. We are
Now?
not.
No, no screen.
No, no. Only your folder is visible.
You have to open it.
You have to open, click, and
It's open,
put on
madam.
slideshow.
You can reshare again. You go, stop sharing, then again reshare.
1 minute, ma'am. I'll just. Now?
Yeah, it is there. Slideshow. You can do slideshow.
I'll do it.
Yeah, yeah.
Ma'am, now it is visible?
Yeah, it is visible.
Yeah.
Thank
Good morning, judges. And thank you for giving me a chance to present over here on this topic. My study statement is, it is a descriptive survey to assess level of stress-related behavior, factors causing stress, and the coping strategies practiced by BSc nursing students to manage stress while working in isolation unit of COVID-19 in selected metropolitan city. So objectives of the study is to assess the level of stress among the nursing students, to assess the stress-related behavior among students, to assess factors causing stress, assess coping strategies practiced by nursing students, find out the correlation of coping strategies practiced by students with to manage the stress, and to find out the association with selected demographic variables. Background of the study is, like, at present the scenario of COVID-19 and nursing education, like we all are completely away from clinical field. Whereas when if you see, there is a shortage of manpower in nursing, where ultimately everybody is looking forward towards the nursing colleges and the nursing students to be placed into the COVID-19 area, specializing the nursing colleges, and there is a direct order for placing the students in COVID areas. There is no clear guidelines given by the regulatory bodies for placing the students in the COVID areas, except that INC has given one statement where nursing students, like second year students, can be placed into the regular isolation unit, third year and the fourth years in isolation with the tertiary care facilities and the ICU with the MSc and this. But there is no guidelines where specifically given for what is the ratio, how many hours they can work, what are the number of off leave can be granted for them, what is the pre-placement, like what orientation program needs to be developed. Nothing were given clearly by the regulatory bodies or the like university. Nothing is mentioned by even our nursing bodies. Resistance, fear, and objection from the parents and students to work in the pandemic. There is a lack of guidelines, inadequate skills and knowledge to work with a different scenario. Like there, we have already teaching them like what is isolation guidelines and all. But when it has come to the practical in pandemic, there is a requirement of certain skills and knowledge which students are lacking at the time when we place. The students are in a dual mind, want to complete their course. They want to come out, they want to be, complete their course in time and be a earning member of family, where for that, many of the students, they are choosing that, oh, okay, madam, we will go and work in a clinical area or pre-apprenticeship. These are the whatever the things are right now going on into the clinical with the many of the nursing colleges when it has come for the background of this study, where I would really like to share that I am working with the COVID isolation unit since March 29 till today. I have placed my second year, third year BSc nursing, second year A&M, and my alumni in a COVID, and I myself work in a COVID area, even though I'm a principal for a college. Hypothesis for the study is there will be no correlation between level of stress among the nursing students working in isolation unit of COVID-19 and the coping strategies practiced by them. Assumption is there is a high level of stress while working in leading to adopt a negative coping strategies in a students, as well as there is a high level of stress is leading to poor performance in the clinical field is observed in the students. The review of literature, what I have collected is being as this is a novel coronavirus, very few literature is available related to nursing students. But there are studies and articles which is available on a net, studies and articles related to stress among the nursing students, studies about the stress related to behavior, causes of stress and the stress in nursing profession and the health impact of it. Studies related to various coping strategies which I have referred also here. Then conceptual framework I have used is a health belief model. Health belief model is an asset to that when the nursing student believes that he or she is susceptible to the health problem with severe consequences, she will be more likely to conclude that the benefits outweigh the barriers associated with the changing ones to prevent changing one's behavior to prevent the health problems and improve the quality of life. That is the conceptual framework I have used. Methodology like quantitative research approach and the non-experimental descriptive survey design, where sample is the nursing students who has experience of working in the COVID-19 isolation unit. I have taken 120 students are selected and purposive sampling technique. Variables are stress, behavior of students, factors, and the coping strategies developed due to the working into the isolation unit. Techniques and tool what I have used is demographic variables, then stress related behavior, where 20 various observable behavior is divided into low, moderate, and high levels of stress causing stress. Then in section 3, there is a perceived stress score or perceived stress point scale I have developed, where 10 points statements I have dotted, where scores ranging from 0 to 13 is a low stress, and 14 to 26 is moderate stress, and 27 to 40 is a high, considered as a high level of score. Each student has to mark total all the points, and we can see the range in this. That is what is a perceived stress score I have taken. And the factors causing stress is a 5-point rating scale, where 34 items are divided into social media, personal protection and safety, support, financial support, as well as like insurance and all, then academic and the financial stress. Then nursing role and the responsibility, knowledge and skill deficits. These are the various stress causing areas I have selected, and whatever statements are rated according to these areas. And the last is an coping strategies, which I have taken into 46 statements in adaptive, emotional, confrontive, optimistic, and the evasive types of coping strategies I have used. The validity of the tool, I have taken a validity from the various experts, the teachers, those who have already placed their students into the COVID areas, and they have come across the problem, what problem they are facing, them who I have given for a validation. Reliability of the tool is done with chronic branch alpha, and reliability coefficient for the PSS scale is 0.7, and for coping strategy it is a 0.8, which is highly reliable. Data gathering is data is collected by using social media, Google app with email, as well as the data analysis is done by frequency percentage, mean percentage, Spearman correlation for correlation of stress with the coping strategies, and the Kruskal values for the association. Findings what I have got is like in the demographic data, maximum students we have received the nursing students female, and they have received training, no training. Then the prophylaxis and medical facilities everywhere. Then the assessment of stress related behavior and science. You can see the graph here, where the graph is showing low stress related behavior is regularly checked with the students is a 60%, 60 frequency, with a moderate stress and followed by high stress related behavior, which is 12.5%. Then the assessment of perceived stress score, which is where moderate perceived stress is 65, is 52.2% is observed. Then the factors causing stress. The factors causing stress, where the mean percentage, students have developed 32% maximum stress score on social media, followed by knowledge and skill, and personal protection, and the nursing responsibility. Being, I have observed that even in a 6 months, when the students are working, they are alone in a isolation unit without any trained nursing supports. And because of that, when I have interacted with the students, they feel that if something goes wrong because of us and a patient dies, so that fear they have when we place students. So knowledge and skills we have to really take care when we are placing students in the clinical area. Then assessment of coping strategies, where maximum coping strategies is an adaptive coping with 47 mean percentage, followed by the 44.8 with the confrontive coping, and then optimistic coping, and then evasive. That is what is the what percentage I have got it in a coping strategies what students have done. There is a no statistical correlation between level of stress and the coping strategies among the nursing students. The scatter plot is depicting it is there is a no correlation between this. Then the association of demographic variable with the stress is independent of demographic variable. Nursing course here, whether training is given, the stress is associated, and the dependent on the demographic, it is depends on demographic variable, that is age, nursing course, whether prophylaxis treatment is given, and whether medical facilities, all four, where the demographic variable is associated with the stress. There is no association with the coping strategies with any of my demographic variable I have seen. Recommendations here, I would really like to say that in present scenario of life where the life is COVID, so virtual nursing for nursing student is not a solution. We have to place a students. A similar comparative study can be done by including the satisfaction along with the attitude and practices of students with innovative practices and techniques needs to be used by nursing teachers to settle these students in a isolation units of COVID. There should be advanced skill training program, and its effectiveness towards the practice of students can be seen. And the COVID-19 outbreak is facing immense pressure on the hospitals and the students, nurses, in the frontline workers also. So we have to really need to develop here with a psychological support system for them, as well as for all the healthcare providers, and coping strategies how to adapt to the situation. We need to train them and we can see the effect of that in future. Here, I would like to conclude that moderate perceived stress related to social media, knowledge, skill deficiency, and responsibility, and the personal protection and safety. Where students and the parents counseling, proper orientation, training program, and provision of personal safety protection will definitely help to reduce the stress. Further research is needed for reducing the level of stress by using innovative supervision techniques and the practices. Proper mentoring of the students and development of standard operating procedures for student safety, legal clearance, financial safety, and the medical facility with appreciation will definitely help for student satisfaction techniques and helps to adopt the positive and performance for coping with the isolation area in clinical posting area. These are references which I have received. Thank you. Thank you, madam. Thank you, ma'am.
Unshare your screen.
Yes, ma'am. Yes. Ma'am, this is a research what I have done since last March 29. I have placed my students in the COVID area. I have started posting my fourth year batch, then third year. Everywhere when I used to place, as the batch has come to the down, like second year, more and more problem what I observe with the students. There is a parents are too much reluctant to place the students in a clinical. So if you see, there are like guidelines are given by the government for a nursing cadre or the health workers, but the students are completely ignored by the government. They want a help by the nursing colleges.
No, just 1 minute. I would like to disagree with this. Government has given very clear guidelines, Government of India, for this how to place the students even.
If nursing, there is no guidelines given by our regulatory.
Regulatory has no role, madam, in this. First of all, I would like to clear this was a international pandemic, international problem. Government has taken full due care. They have given proper guidelines to all the states. States were supposed to give to all the institutions. They were uploaded on the Ministry of Health and Family Welfare website also. They have clearly written which year student will be posted in which area and with whom they will be posted. It is a fault of our system, nursing system. They are not adopting and they do not know, even they are not aware of that these guidelines are there and they have not followed. Just 1 minute, let me complete, okay? No regulatory body, even the medical regulator, MCI has not given to them. Everything was available on the Ministry of Health and Family Welfare website. So government has given instructions to every institution to go through that. If they were not going through that, that is, and how it was implemented, it was a problem of the institution. And what you were saying, that training has not been given. See, when this type of pandemic is there, it was every hospital was supposed to have a nodal committee with medical and the nursing people. If your hospital has not made a nodal committee, it is their guidelines are at default. That nodal committee with College of Nursing, Medical College have decided where to post the students, how many students they require, how many, what type of training will be given, who will give the training. Everything guidelines were the prerogative of the nodal committee of that particular hospital. So we cannot blame only regulatory bodies and the government. During these times, one should be aware of what type of guidelines are being given by your ministry. And those guidelines need to be followed by every institution. First point is this, I wanted to clarify. Second point is, you said the sample you have shared in the social media, your tool. How you have taken informed consent from these students, and how you have taken the how you have taken the ethical clearance from your hospital for this study?
Madam, for ethical clearance, I have put it my college clear committee.
That is an ethical committee?
Yeah, ethical committee approved by our college academic sections, UGC.
Okay.
And my consent I have taken a Zoom meeting with the batches, and I have forwarded my consent form on a mail on WhatsApp, and they have signed it and they have forwarded it, scan and forwarded it to me.
What were the components of your informed consent? What all?
Madam, I have taken it like tool I have written. I have explained them what study I am doing, statement, my purpose of doing, objectives, what I'm going to do it, and then my complete part of it, like how they are supposed to mark it. And if they agree, then they can send. So I have posted around 100 and
have you written to them how you will maintain the confidentiality of their data and their own identity?
I have written it as
let me ask you, then you can answer. How you have given the statement that this confidential data will be preserved by you with confidentiality, and they will not have any precaution in the future. Second thing is, in case they do not want to participate, see, when you do on your own students, this is the biggest conflict of interest. You have not told what is your conflict of interest. When you do your study in your own hospital with your own students, you have conflict of interest because it was easy for you to approach. You were teaching them. They are under obligation, under the teacher. Okay, yes. Please remember, these are the psychological aspects, and every ethical committee should ask these questions. That is very important. This is the biggest conflict of interest you have in your study.
Yes. So can I answer, ma'am, a little bit?
Yeah, please.
Ma'am, regarding whatever you have said, that there is a Ministry of Health and Family Welfare has given a clear guidelines. So in that guidelines, the guidelines is having a reference of Indian Nursing Council, where only which students to be placed in which area is mentioned. But it is not at all mentioned with the ratio. Supervisors,
no, ratio, they will not give. Ministry do not give ratios. I'm sorry
so
to
these,
say.
These are the lackings of that circular.
Madam, these are not lacunae. Why you are having nursing superintendent, DNS and College of Nursing principal? They have to sit together. Do you know how doctors have planned in the hospital? Every unit head in the medical unit, surgical unit, they have sit together. They had made a plan. How many CMOs will be there? How many SR will be there? How many JR will be there? How many medical students will be there? Same way, nursing people also had to sit and made a plan. Government will not give you everything on a platter. You have to work for something. Okay.
Yes, ma'am. And this study has come up with the lacunae, or in between there is some gap.
This is not a lacunae. This is a drawback in your implementation and taking decision by the nurses.
So that is why I have selected this topic.
Administration is weak. Your nursing administration is weak.
And that is why I have selected this topic for the study.
Your argument is not correct. That's what I'm trying to make you understand. What argument you are giving is not correct.
Yes. And second thing is like a clinical clearance. I have already explained all my points, what you have said, in my ethical consent form, and it is same submitted to my ethical committee.
Okay. And the last thing I wanted to ask is, you have written something in recommendation, legal clearance. What is legal clearance? I am not able to understand.
Ma'am, when you have said that it is written in the, they have declared a policy for health policy, where they have sanctioned the insurance for the COVID warriors. So when it has come to the students' placement, and if we have asked the ministry or the municipal corporation to give us a document that what type of clearance they will going to give if the students are infected. So there is no separate guidelines or separate documents is available for the student nurses, which they are unable to give.
See, that is not a legal clearance. You should use proper terms. First of all, I would like to say, when any policy, government make any policy, if you are not clear, many institutions, you have many alternatives. You could have asked under RTI from a specific department. If it was not clear, you could have asked the authority who in your state authority at a state level. If district was not replying to you, you could have asked the state authority. If state authority is also not replying, you have a grievance cell in the state level and the government level at the CM level. You have to use all the channels, and this is not a legal clearance. Please modify this term. Thank you so much.
Any other questions, ma'am?
No, I don't have Madam Nirja. Madam Nirja has asked, I was about to ask about that consent only because you're done through social media. So that Madam has dealt in depth. Others, Madam Basanta, and they can ask questions too.
I just like to ask, as you said, Beta, that you are worried for students that they should get all facility and all. So your study, did it help them to, because our concerned leader is doing this study, so they must be looking at you some future good.
Ma'am, I have developed here by when I place, like Madam has said, there are so many things, but there is errors in implementing at the grassroots level. And the same thing has happened with us being we were forced. So I have developed my own orientation module for the student, and I have started developing with my own innovative practices before placement, and which I see that even in 6 months, out of the 5 batches, my and 147 students, 1 student got infected. Rest all like I am serving, and there is no. Students are like highly satisfied with the facilities provided by the unit and the college while working in the isolation unit, and they are ready even for the further placements.
I want to support Madam Suits that word, that you should have a good meeting with that nodal committee and all, and introduce all those things so that in future also such problem comes, it can be solved easily.
Okay, definitely. I'll prepare one module and I'll try to publish it.
See, Government of
Just
India,
go ahead, God bless you.
And one thing more, Government of India has clear guidelines. If you read all the guidelines very carefully, nodal committee has to cooperate, had to collaborate with your infection control committee. This is the role of an infection control committee of every hospital, because it is mandatory to have an infection control committee, and there is one nurse who is responsible for infection control. So all this coordination during this emergencies and pandemic is important. No one will work in isolation, and our nursing institutions and the hospital has to come together during this pandemic. That is very important thing.
Ma'am, Nirja ma'am, can I tell you one thing?
Yeah.
You are talking about the hospital. What about the project which is developed under ICMR or with the grant, where the hospital is developed in a dome areas, in the grounds where there is nothing is available?
Yeah, so
we have started with that, and I have developed the committee. I have developed the committee of infection control of my college. All the committees I have developed, being I was placed alone with my student. No teaching staff, no trained staff.
That is your administrative problem. Don't blame anyone. That means your administration is not good. Please see that. That factors what you are coming in is altogether different. Your administration is not supporting, then you cannot blame the whole system. Try to understand this. Somewhere there is something wrong with the implementation. That means their coordination is not there, teamwork is not there. That is a drawback in the system of working. You should understand.
I agree. I agree with you.
And nursing is not independent. Please remember, nursing is not independent of anything.
Yes, ma'am. I agree with you.
When we started, argue and no, please stop.
Yes, definitely.
Yeah.
Talk of argument, and definitely I will take it positively. Whatever you are saying.
I am also taking. I am just giving my because you should understand it is a system where we work.
Yeah, it is a teamwork in which everybody is involved.
Yeah.
And everyone comes together to fight with this pandemic.
God bless you. All the best.
Thank you.
Yeah.
Thank you, madam.
You have something?
Yes, ma'am. I wanted to supplement. Actually, as Neeraja madam told, initially when the background came itself, I was thinking because the guidelines and policies, it was not framed. No, it is being framed. So you have to, it is your responsibility, I think so, Shilpa madam, because you are taking up the dual role where you are in the institution and the hospital. So I think you should frame the committee and you have to give the recommendation to your institution now, because this study, now you have to recommend not to the government. Your recommendation should go to the your hospital and your authority, telling these things should be done for the safety of the students. And I just wanted to know whether the informed consent when you got, though they are more than 18 years, there is no need to take it from the parents, but still this situation, have you taken any informed consent from the parents?
Yes, that is why
Have you
actually
spoken to
I have taken a Zoom meeting with parents and students. I have explained
Friends.
the consent and form I have put in the group and through email.
Okay.
That I have taken.
Okay, then one more concern, why? Because when you told about the stress behavior, 80% they are low and moderate in perceived stress scale, I think PSS scale, it is a lot like moderate. So there is little bit of conflict. And also one more question is knowledge and skill deficiency. I think that is 30%.
Yeah.
I don't know why the knowledge skill deficiency, because you are heading the team, your students, when they're entering into the isolation unit, you should have given them the knowledge and skill. Why? That means you that the problem is in you. That's what I don't know. I don't want to blame you, but I just wanted to ask this question.
When I placed first batch, that time it was like I received the order and placed. Then after that I started developing the module. As I said, I developed the module, and after that then the first batch has a problem. Later on the batches were trained properly and then placed, where I have never faced any problem. So because of that, that issue has come. Because see, even working in an isolation unit in regular wards, and when we are posting in a COVID, students are little afraid, and the knowledge wise when they start doing that, I mean, they were literally like when I find there were mistakes done by the students while working in the COVID area.
First of all, your hospital has done a mistake. Nowhere government is given with whom they should be posted. Nowhere government has told nurse students should be posted alone. Like you have said, there were some units where no staff was there. So it is the fault of the implementation of policies. And second thing I would like to say, all the training modules were available on NCDC website, ICMR and Government of India. If our nursing institutions are vigilant enough,
yes, I have the same models.
There was no this thing material which was not available. Even training materials, everything was available. It was a question of only
preparing and training. Okay. I have used same material, and I have framed it into my format for implementation.
Yeah, it's okay.
Same.
Thank you.
Thank you.
Thank you so much.
Okay, thank you, ma'am. And next, madam, please be ready. Sunena, madam.
Good morning, juries. Is my screen visible?
Yes, you can continue.
Yes.
Good morning, juries and all. I, Sunana, MSc Nursing second year, College of Nursing, Pandit B.D. Sharma, UHS, PGIMS, Rohtak. Title of my study is Nurse Conducted Brief Psychoeducation on Self-Stigma Among Clients with Schizophrenia and Affective Disorder, a randomized control trial with Solomon 4 group design. Background. One of the major barriers that prevent the mentally ill person to seek treatment is a stigma. Self-stigmatization adversely affects the mental health, and more often people hesitate to avail treatment in order to avoid the negative consequences associated with stigma. Need for the study. Evidence of nurse-conducted brief psychoeducation in reducing the internalized stigma level of treatment-seeking clients with schizophrenia and mood disorder is limited. This prompts the investigator to explore this area. Review of literature. There are some reviews, quasi and pre-experimental studies on brief psychoeducational intervention that shows that there was a significant reduction in stigma in intervention group as compared to control group during follow-up. Objectives. Objective of my study is to investigate the effectiveness of nurse-led brief psychoeducation in reducing internalized stigma among clients in the remittent stage of schizophrenia and affective disorder at 1 month follow-up period. Operational definition. Self-stigma is an internalization of stigmatizing views such as negative consequences, negative feelings, or anticipation of negative social reactions based on their mental illness. The present study used internalized stigma of mental illness scale for assessing internalized stigma. Nurse-led brief psychoeducation. Nurse-led brief psychoeducation is a structured educational intervention containing one individual session of short duration, that is of 30 minutes, offered with an aim to help a person to reduce the internalized stigma associated with mental illness. Hypothesis testing. Null hypothesis is that there is no significant effect, and alternative hypothesis is that there is a significant effect of nurse-led brief psychoeducation in reducing internalized stigma. The Imogen King's goal attainment theory is used as conceptual framework for our study. Methods. Research design. Randomized control trial with Solomon 4 group design is used as research design. Setting was psychiatric unit of PGIMS Rohtak. Population was treatment seeking clients of schizophrenia and affective disorder in remittent stage. Sampling was consecutive sampling and sample size was 80. Inclusion and exclusion criteria. Inclusion criteria. Clients who are undergoing treatment on outpatient basis with a clinical diagnosis of schizophrenia and affective disorders as per the ICD-10 criteria established by a psychiatrist. Those who were in the remittent stage of the mental illness and consecutively stable over 6 months were included. Exclusion criteria. Clients in the acute stage of their illness, not able to read and write the Hindi language and not willing to participate, were excluded. Research tools used in our study is the socio-demographic profile record, and for outcome measure, we used internalized stigma of mental illness scale in Hindi version. Sample size calculation. According to Based on pilot study findings, alpha and beta value were kept at 5 and 80% respectively. And finally, we assuming the final sample size was 80. Randomization and allocation concealment. Block randomization was used for ensuring equal distribution of participants as per the diagnosis and the treatment condition. Considering the estimated sample size of 80, a total of 5 blocks with a block size of 10 was determined. The number of blocks was stratified as per the diagnosis, that is 4 blocks for each schizophrenia and affective disorder, and thus block size were equally created as per the treatment status, that is 5 for intervention and 5 for the control group. A sequentially numbered sealed envelope technique was used for allocation concealment. Method of data collection. Participants were treatment-seeking clients from the psychiatric outpatient department. The pre-test assessment with the ISMI Hindi scale was limited to subjects in the affective disorder group. However, all the subjects, irrespective of their diagnosis and treatment status, were filled the self-administered paper version of the ISMI Hindi scale during 1 month follow-up. This was the concert we used for our study. Ethical clearance. Ethical approval for the study was obtained from Institutional Ethical Committee, Pandit B.D. Sharma PGIMS UHS Rohtak. An informed consent was obtained from all the study participants and confidentiality was maintained throughout the study. Data analysis. For data analysis, we used MS Excel and SPSS package. Tests used were Pearson chi-square test, independent sample t-test, and ANOVA for the continuous variables, and general linear model for determining the strength of outcome variables. Demographic characteristics. If we talk about demographic characteristics, both the groups were comparable as per socio-demographic profile. Same as in clinical characteristics, both the groups were comparable as per clinical profile. Stigma experienced by the clients. There were no statistically significant difference between the intervention and the control group as per the total and subdomain of ISMI. Effect of intervention. In the intervention group, as compared to control group, the stigma score was significantly reduced in the alienation, stereotype endorsement, social withdrawal domains, with the exception of discrimination experience domain and stigma resistance domains of ISMI scale at 1 month follow-up over time. Effect of treatment. There was a significant reduction on total ISMI score in the intervention group as compared to control group during follow-up. The interaction of pre-testing with treatment using GLM. No interaction effect was found between the status of the treatment and pre-test except the social withdrawal domain as per the GLM model. Discussion. Results of similar published studies suggest that the self-stigma reduction program has potential to increase self-esteem among the self-stigmatized individual with mental illness. Implications for nursing practice. The findings of study have important policy implications. For the preparation, nurses as brief psychoeducation therapists in a broad range of settings, such as primary health care and hospital care settings. Limitations. The result of the outcome measure are based on self-reported measure. The short-term outcome of a single session was evaluated and long-term effect of the brief psychological intervention was not assessed due to the COVID-19 related lockdown in India. Strength. To the best of our knowledge, this is the first randomized controlled trial from India to evaluate the effectiveness of nurse-conducted brief psychological intervention for reducing internalized stigma in clients with schizophrenia and affective disorder. Conclusion. The nurse-conducted brief psychoeducation may be an effective strategy in reducing internalized stigma in treatment-seeking individuals with schizophrenia and affective disorder in this setting. Take-home message. Don't give in to stigma. A diagnosis does not determine who you are or what you can do. Thank you.
I just want to know from you that what was the content of your psychoeducation for this?
Please unshare your screen.
Yes, ma'am. Yes, ma'am. Just a minute.
Yeah.
Sunaina, what
Yes,
was
ma'am.
the
Yes, ma'am.
content of your psychoeducation?
Ma'am, it is firstly we ask about the diagnosis. First, we ask about for client that what they know about their diagnosis or what they know about their illness, their treatment. Then we decide according to their knowledge. Then what we should give education according to this basis. And second one is about internalized stigma. We ask client about what they know about internalized stigma and how they feel personally or if they have experienced it or what they know about internalized stigma. Then
No,
we plan.
that you did through your scale, na? Which the scale which you have used. In that, these questions must be there. What was your content of teaching psychoeducation, and whether it is standardized or you have made on your own?
We have made it our own, but we validate it by 5 specialists. One is social psychiatry worker and 2 psychiatrists, and one is from nursing department, and that's all.
Yeah, that is what I want. Content, what you have exactly said to them. Like these are the questions that do you know about this and that about your that has come in your questionnaire. But what you exactly delivered to them so that their stigma is reduced. That is what is my question to you.
We tried to figure out, then we deliver about the facts and their जो उनके जो स्टिग्मा से रिलेट देन
आप हिंदी में भी बोल सकते हैं. आप हिंदी में कंफर्टेबल है? हिंदी में बोलिए.
यस मैम थैंक यू.
तो आपने उनको क्या पढ़ाया? यानी मेरा ये कहना कि आपके पढ़ाने का कंटेंट क्या था बस, क्योंकि बाकी चीजें तो आपने ऑलरेडी सोशियो डेमोग्राफिक वेरिएबल में ले ली है. आपने क्वेश्चनर में सब पूछ लिया, लेकिन आपने उनको क्या ऐसा पढ़ाया कि उनको बात समझ में आ गई, स्टिग्मा
मैम
वाली बात
सिंपल,
उनको समझ।
हाँ जी, सिंपल साइको एजुकेशन थी मैम कि जो मेंटल इलनेस है वो किसी को भी हो सकती है, दैट एंड जो नेगेटिव जो कंसिक्वेंसेस और जो नेगेटिव थॉट्स उनके माइंड में आते हैं उनको पॉजिटिव करने की आप ट्राई करें। और जो मेंटल इलनेस है वो लाइक फिजिकल इलनेस है, जैसे वो फिजिकल इलनेस किसी को भी अफेक्ट कर सकती है, वैसे ही मेंटल इलनेस किसी को भी अफेक्ट कर सकती है। वो हम उसको किस तरीके से लेते हैं, कैसे हम उसको हैंडल करते हैं, कैसे बाकी लोग उसको टैकल करते हैं, वो चीज़ें हमने उनको बताई हैं।
अच्छा, आपने खुद का बनाने के पहले WHO के साइट
यस
पे
मैम, यस मैम,
या
देखा था
निमैंस के
मैंने।
साइट पे इसके ऊपर कुछ आपने देखा कि उनके पास रेडीमेड मटेरियल है क्या,
मैम वो बहुत
जो
ब्रॉड था।
नेशनल लेवल
हाँ
के
जी
मेंटल
मैम,
हेल्थ इंस्टीट्यूट से?
हमने मैम उसी में
हाँ।
से लिया है। एक सिजोफ्रेनिया बेस्ड साइको एजुकेशन मॉड्यूल मिला था मुझे, वो बहुत ज़्यादा ब्रॉड था, हमने उसे कंसाइज किया, फिर हमने उसे वैलिडेशन के लिए सेंड किया था।
ओके, तो वो आपको मेंशन करना है।
ठीक है मैम।
वो आपको मेंशन करना है कि आपने किसी का मटेरियल लेके उसको मॉडिफाई किया, क्योंकि ये नेशनल लेवल की जो मेंटल हेल्थ इंस्टीट्यूट से उनके पास ये मटेरियल अवेलेबल है जो वैलिडेटेड है, ठीक है। उसमें WHO के एक्सपर्ट्स भी हैं, तो जब भी हम किसी की चीज लेते हैं तो वो हमको उसमें उनका नाम लिखना जरूरी है। इसलिए मैंने आपसे पूछा कि ये साइको एजुकेशन मटेरियल आपने खुद बनाया या कहीं से
बनाया
लिया।
तो मैम, बनाया तो खुद से है, लेकिन आइडिया तो मैम कहीं से लेना ही पड़ता है ना,
हाँ,
तो
नहीं नहीं,
पर
किसी
गो
का
थ्रू
भी
हम उसके
कंटेंट
हुए
यूज
हैं।
करना, किसी का भी कंटेंट यूज करना, अगर नहीं एक्नॉलेज करते तो फिर वो चोरी वाली बात हो
यस
जाती है,
मैम, यस मैम, श्योर
इसलिए
मैम।
वो नहीं कर सकते आप। एक बात, दूसरी बात, आपने बोला कि आपने स्केल को हिंदी में कन्वर्ट किया, तो कैसे किया आपने?
मैम ऑलरेडी है,
स्टेप से
डॉक्टर
किया
संदीप
आपने?
मैम, डॉक्टर संदीप ग्रोवर ने ऑलरेडी हिंदी में बनाया हुआ है ये टूल, तो हमने उनसे परमिशन लेके वो यूज किया था।
अच्छा
डॉक्टर
ठीक है,
संदीप
तो
ग्रोवर हैं।
उन्होंने बैक ट्रांसलेशन करके फिर किया हुआ था, ये आपने इंश्योर किया?
यस मैम।
यानी कोई भी हम जब लैंग्वेज को करते तो वापस उसको फिर इंग्लिश में करने का, और फिर वो हिंदी में करते और फिर वापस इंग्लिश में किसी से करवाने का, तब हम समझते हैं कि वो टूल हमारा बराबर हो गया है, ठीक है। आपने एक टर्मिनोलॉजी यूज की, ब्लॉक रैंडमाइजेशन। अभी
यस
यहाँ
मैम।
पे कई सारे बच्चे हैं जो ये पढ़ रहे हैं और रिसर्च का ये देख रहे हैं यूट्यूब पे, तो आप उनको ये क्लियर करिए कि कैसे आपने ब्लॉक रैंडमाइजेशन की स्टेप फॉलो की, और कैसे आपको उसमें कोई कंफ्यूजन नहीं हुआ, क्योंकि ये मेंटल हेल्थ से रिलेटेड स्टडी है और इसमें पेशेंट इतने आसानी से नहीं सुनते हैं, तो आपको भी पता है, ठीक है। तो आपने
मैम
कैसे किया
हमने
ये ब्लॉक?
हमने रेमिटेंट स्टेज में लिए थे पेशेंट्स।
हाँ, वो तो ठीक है, लेकिन देखो ये आपको भी पता, मुझे भी, कि स्किज़ोफ्रेनिया वगैरह दे आर क्रॉनिक इलनेस,
यस
okay?
मैम।
Patient recover and they again go back to the same stage in no time if they leave their medication, okay? तो अगर वो रेमिटेंट स्टेज में है भी तो कुछ ना कुछ रेसिडुअल इफेक्ट उनका होता है, ठीक है। तो वो है, लेकिन आपने ये ब्लॉक रैंडमाइजेशन की प्रोसेस कैसे की, ये मुझे भी जानना है, और जितने लोग आपको यूट्यूब पे सुन रहे हैं नर्सिंग फैकल्टी के और नर्सिंग स्कूल के, तो उनको भी जरा बताइए कैसे आपने किया।
मैम हमारे 2 ग्रुप्स थे, अफेक्टिव एंड सिजोफ्रेनिया। उसके
हाँ।
लिए हमने एनवेलप लिए, सील्ड एनवेलप लिए। हमने पेपर जो हमारे जो क्वेश्चनेयर थे, जो पेपर्स थे, उसके अंदर भी हमने 5 एनवेलप बनाए। एक मेन एनवेलप में 5 एनवेलप बनाए, ऐसे ही 2 में 5 एनवेलप हो गए। तो हमने जो क्वेश्चनेयर थे वो हमने उनमें हर एक में क्वेश्चनेयर रखे। 8 ग्रुप्स, हमने टोटल 8 ग्रुप्स बनाए थे, और हर में 5 जो थे एनवेलप थे। और फिर वो हमने बिना, जो ग्रुप्स बन गए मैम, उसके बाद जब पेशेंट आते हैं पहले हमने उनको कंसेंट फॉर्म दिया, अगर वो विलिंग है पार्टिसिपेट करने के लिए तो हमने उसके बाद ही एनवेलप से एक परफॉर्मा निकाला और पेशेंट को दिया। वो हमने ऑलरेडी ट्रीटमेंट और जो था कंट्रोल था वो सब मेंशन करके उस पे टेप लगा के सील्ड करके उसमें रखा हुआ था, तो वो हमने दे दिया। जैसे पेशेंट ने भर के दिया, हमने बाद में उसको देखा है कि वो कंट्रोल है या ट्रीटमेंट है, जो भी है।
ये 2 ग्रुप के लिए आपने किया। अफेक्टिव डिसऑर्डर में आपको मेजर कौन मिले, मेजॉरिटी ऑफ पेशेंट्स कौन मिले अफेक्टिव डिसऑर्डर में?
डिप्रेशन मैम, डिप्रेशन एंड
ज्यादातर,
बीपीएडी।
हाँ, तो ज्यादातर डिप्रेशन वाले आपको मिले, ठीक
हाँ
है
जी
ना?
मैम।
ओके, ठीक है, मेरा क्वेश्चन उसके बारे में सही रहा। अभी और दूसरा आपने, हाँ ठीक है, मैंने आपको ये पूछा था, दोनों चीजें मेरी हो गई है, ठीक है। हाँ, कितने सेशंस साइको एजुकेशन के?
मैम हमने एक तो जो प्री टेस्ट वाला जो ग्रुप था उसको हमने प्री टेस्ट दिया है, और फिर 1 मंथ फॉलो अप पे हमने दोनों को उन्हीं उसको सेशन को प्री टेस्ट करवा के, जो प्री टेस्ट वाला ग्रुप था, उसके बाद हमने एजुकेशन दी। और मैम एक ही सेशन हो पाया हमारा, क्योंकि उसके बाद लॉकडाउन वगैरह हो गया था, तो फॉलो अप पे पेशेंट बहुत कम आ रहे थे, जैसे दूर दूर के भी बहुत पेशेंट थे, तो एक ही
ये
सेशन हो
मेंशन
पाया है
करना
अभी।
आपको जरूरी है
मैम
कि
मेंशन है,
आपने एक ही सेशन दिया। हाँ
मैम मेंशन है, लिमिटेशंस में
और उसका
मेंशन है
ड्यूरेशन,
मैम।
और उसका ड्यूरेशन
मैम
सेशन का
30 मिनट्स 30 मिनट्स।
ओके ठीक है। मैडम नीरजा।
या
मैम
मेरा
नीरजा आप।
या थैंक यू सो मच। आपने जैसे बताया सुनैना कि 30 मिनट्स, क्या 30 मिनट्स आपको फिजिबल था उनको बिठाना कि 30 मिनट्स तक वो बैठ के आपके क्वेश्चनेयर को ध्यान से सुन के जवाब दें?
मैम जो विलिंग थे, हमने जो पायलट स्टडी में
प्रॉब्लम बीच में आई,
मैम पायलट स्टडी हमने कंडक्ट की, उस टाइम पे ऐसा कुछ नहीं हुआ था, तो तभी हमने मेन स्टडी कंडक्ट की।
नहीं, आप ये बताइए कोई मेन स्टडी में इश्यूज आए किसी भी पेशेंट के साथ?
मैम मेजर इश्यूज नहीं रहे थे,
बट जो भी अगर थोड़े भी आए हैं, देखिए स्टडी
एक दो पेशेंट जो बहुत ज्यादा जैसे सिजोफ्रेनिया वाले, एक दो जो थोड़ा हो सकता है, नहीं मेजर इश्यूज नहीं आए।
नहीं
जो
देखिए ऐसे है, मेरी पहले बात सुनो बेटा, हमेशा नेगेटिव फाइंडिंग इज आल्सो वेरी इंपॉर्टेंट टू
फॉर फ्यूचर रिसर्चर्स। फॉर फ्यूचर रिसर्चर्स
यस, जो आपको प्रॉब्लम्स आई उसको भी हमें हाईलाइट करना क्यों जरूरी
करना चाहिए।
चैलेंजेस एक्चुअली इंप्रूव योर स्टडी, इसको छुपाना नहीं चाहिए कभी भी। मैं इसलिए पूछ रही हूँ,
देखिए छुपा नहीं रहे,
बट छुपाने का इन अ सेंस कि यू शुड पब्लिश इट। ओके,
वी आर गोइंग फॉर पब्लिशिंग।
आपको चाहे 5 पेशेंट के साथ भी प्रॉब्लम आई है, कोई भी प्रॉब्लम्स आई है इंटरव्यू के टाइम में, अगर वो सिर्फ 15 मिनट ही आपको दे पाए, आपको उनको ब्रेक देना पड़ा, ठीक है, क्यों देना पड़ा, क्या प्रॉब्लम आई, तो ये चीजें लिखनी बहुत जरूरी है। अगर आई है तो इसको आप मेंशन जरूर करिए, मैं इसलिए कहना चाहती हूँ।
ओके मैम, ओके।
और दूसरी चीज है जो आपने कहा कि आपको कोविड के कारण फॉलो अप में प्रॉब्लम आई, क्या आप फोन पे उनसे फॉलो अप नहीं कर सकते थे अपना टूल को कोई मॉडिफाई करके?
हम कर सकते थे, वी विल थिंक अबाउट दैट।
सो दैट इज अ सेकंड अल्टरनेटिव। ओके,
यस मैम।
एंड फिर उसके बाद आपने एक कंसेक्यूटिव सैंपलिंग बोली थी।
यस मैम।
क्या आप पार्टिसिपेंट को समझा सकते हैं व्हाट इज, सो दैट दे आल्सो नो व्हाट इज कंसेक्यूटिव सैंपलिंग?
मैम कंसेक्यूटिव सैम्पलिंग है, इंक्लूजन क्राइटेरिया को फुलफिल करते हुए हम सब्जेक्ट्स को तब तक पार्टिसिपेंट की तरह लेते रहेंगे जब तक हमारा सैम्पलिंग क्राइटेरिया फुलफिल नहीं हो जाता, मीन्स जो सैंपल साइज है वो कंप्लीट नहीं हो जाता।
ये थोड़ी सी टर्म, देखो हर तरह का स्टूडेंट्स भी है ना हमारे पास, तो उनको ये टर्म समझानी जरूरी है। आपने एक चीज बोली ICD-10 established by psychiatrists. What do you mean by ICD-10? तो इंटरनेशनली स्टैंडर्डाइज्ड डायग्नोसिस होते हैं
मैम, बट वहाँ पे जो आउट पेशेंट डिपार्टमेंट में जो साइकेट्रिस्ट थे, उनने जो डायग्नोसिस मेंशन किया था, हम उनको ले रहे थे, इसलिए हमने ये मेंशन किया है।
तो ICD या तो आप करो कि which is as per your institution SOPs diagnosis you have taken into consideration, या ICD-10 यूज करो, एक चीज यूज करो।
ओके मैम।
या उसने ICD-10 को मॉडिफाई करके डायग्नोसिस बनाया है, तो यू हैव टू क्लियर दिस। ये क्लियर नहीं है बिल्कुल भी आपका। देन आपका मैडम ने वो पूछ सेल्फ एडमिनिस्ट्रेशन ऑफ टूल भी हो गया था। क्या आपने इन्फॉर्म कंसेंट सब पेशेंट ने दिया था या उनकी फैमिली मेंबर से भी किसी से आपको लेना पड़ा था?
सब पेशेंट्स ने दे दिया था मैम।
कोई प्रॉब्लम नहीं आई थी आपको?
नहीं।
कोई ऐसा पेशेंट था जिसने आपको बीच स्टडी में विड्रॉ कर लिया हो, कोई ड्रॉप डाउन हुआ हो स्टडी से?
मैम एक ही सेशन हुआ था तो कोई इशू नहीं हुआ।
कोई इशू नहीं आया। ओके। आप इसमें आपने सोचते कि आपको फैमिली का स्टिग्मा भी ऐड करना चाहिए?
मैम एक्चुअली फैमिली स्टिग्मा पे देयर आर लॉट्स ऑफ स्टडीज,
बट इसमें देखो लॉट्स ऑफ स्टडीज हैं, बट आपके इस पर्टिकुलर ग्रुप में फैमिली में
सिजोफ्रेनिया वाला पेशेंट है।
यस, और फिर वो सपोर्ट कितना मिलता है? देखो फैमिली सपोर्ट के बिना स्किज़ोफ्रेनिया
कुछ कर ही नहीं सकते
प्रॉब्लम। तो ये बहुत जरूरी चीज है, कहीं पे आप सेकंड फेज में इसको ऐड कर सकते हो। दिस इज वेरी इंपॉर्टेंट कंपोनेंट। वो तो घर से आ रहा है आपके ओपीडी में, बट उसके घर में कैसे केयर हो रही है, क्या है कम्युनिटी का रिस्पॉन्स क्या है उसके लिए, दीज आर द थिंग्स वन हैज टू। और आपने जैसे बोला दिस वाज द फर्स्ट स्टडी बाय अ नर्स लेड बाय ऑन ब्रीफ साइको एजुकेशन। आप सोचते हैं कि एक स्टडी एनफ है एविडेंस के लिए?
नो मैम, बट एटलीस्ट स्टार्ट तो है मैम।
यस, स्टार्ट करी है, बट यू कैन नॉट से मे बी फॉरेन कंट्री में किसी नर्स ने करी होगी,
बट आप इंडिया की बात
नहीं, अपने यहाँ भी बहुत लोगों ने की मैडम। निर्जा मैम अपने
मैम
यहाँ काफी लोगों ने किया।
मैम रैंडमाइज्ड कंट्रोल ट्रायल,
बट देन यू कैन नॉट से दिस इज अ फर्स्ट स्टडी। You can say the method used was the first time by randomized methods.
Okay ma'am, okay.
नहीं है?
That what I mean.
Yes. नहीं तो इसको
सुनना है ना? हाँ, yeah. And सुना है ना? Always in psychiatric patient, the family and patient is a single unit.
Yes.
Because without the family members, many a times, many institutes, they do not give medication in the hands of the patients.
Yeah.
Yes, yes, yes. Very correct.
Because he can consume completely or he can throw. Many patients do like that here in our regional mental hospital.
Yes.
They will just take and they will just throw out and go away. So what Nirja madam has said, that is very, very crucial point, that family and patient is a single unit in psychiatry. You cannot leave them. In any point of time, you have to include them in your psychoeducation.
Yeah, you should include. It is a good study. You are doing a good area. Area is very good. Just
very good, very good. Any psychiatric study is very good, and it needs lot of courage. Otherwise, people are afraid of facing the patients. Okay, so that's very good. But certain things, weaknesses in your studies, you have to cover up. Okay, and acknowledge people from where you take their material.
Yes.
Right?
Yes.
Sometimes people can even sue you. That ये तो हमारे पास का मटेरियल था, मैडम ने यूज कर लिया अपना नाम लिख के।
वो
तो
जनरल
रेफरेंस में तो लिखते ही हो, लेकिन परमिशन ले लेना।
चाहे जनरल भी हो, लेकिन आपको कॉपीराइट इश्यूज देखने पड़ते हैं। आपको कल भी यही इशू उठा था। देखिए हमारे नर्सिंग में क्या होता है, आप चाहे वेबसाइट पे अवेलेबल भी है, लेकिन आप देखेंगे सब में कॉपीराइट इशू नहीं होता है फ्रीली यूज करने का। सो यू हैव टू बी वेरी केयरफुल व्हेन यू यूज सर्टेन मटेरियल। Okay,
I will check it out.
You should give proper acknowledgement also.
Okay,
आपने जिस डॉक्टर का भी टूल यूज किया है, उससे आपको रिटर्न में लेना पड़ेगा। बाय चांस 5
we have permission.
और वो लगाना पड़ेगा स्टडी में आपको।
स्टडी में आप
लगा रखा है, लगा
कहीं भी
लगा रखा है।
ये छोटी छोटी चीजें आपको ध्यान रखेंगे तो आपको ही मुश्किल नहीं आएगी बात।
Yes, yes, सच बात।
थैंक यू सो मच वसंता मैडम, माया मैडम, प्लीज।
Thank you, ma'am. And I think all the points have been covered by Madam Neeraja Madam and Bharati Madam. And here I don't have anything to say. As Bharati Madam told, she was asking about the psychoeducation, because that is the very important aspect of your study. So in that case, I wanted all the presenters, kindly when you're talking about the tool, kindly tell about the intervention too. You can put the components under the intervention. You can show a slide on that. So that will be best. Also, my concern for you is, because it's a psychoeducation for schizophrenic and affective disorder patients. So in that case, have you included anybody as a co-author who is who had or otherwise you have any certification on counseling or any kind of psychoeducation? Because that certification is very important to speak more, because counseling certificates, and I think now everybody is taking some counseling certificates and only they're doing the study. If you have that, that will speak for you better than anything, I feel, because that will have a legal issue, legal implications too. Because when you're publishing, I think the problem now for the publication people, it's not only for the people who are publishing, even for the editors. If you are doing mistake, even editors are under sue now.
Yes.
So we have to be very careful when you are publishing things. Okay, so because these questions can come, as Madam was telling, no, psychoeducation, you have to get the consent, copyright, whatever may be, please get the consent. Also, if you are included somebody, but in future, see that if you do such studies, one thing, you take the certification or include somebody who has already certified in this.
Yes.
So that will be a good part of your study. Thank you.
My co-author was a social worker.
Okay.
No,
social psychiatric work.
No, she.
Collaborative
I did everything under his supervision.
Okay.
Okay. Social. Okay. Thank you.
Thank you, ma'am, and thank you, Sunena. And now the turn is for Anu ma'am. Anu ma'am, we ready for the presentation? Please, Anu ma'am, proceed your presentation.
Yes, sir, sure. Ma'am, may I know it is visible?
Yeah, yeah. We can see your screen.
Yes, ma'am. Can I start, ma'am?
Yeah, surely.
Okay. Okay, ma'am. A very good afternoon to one and all, respected jury members, NTA Association members, and dear participants. Happy Gandhi Jayanti to all of you. Myself, Anu Joykuti with code number AP50. Today, I would like to present before you the statement of problem, a descriptive study to assess the knowledge of antenatal mother on effect of malaria in pregnancy in a selected PHC at Bangalore with a view to provide health education pamphlet. Coming to the introduction, malaria is one of the important or major infectious disease that causes death. And during pregnancy, it causes various perinatal and maternal mortality and morbidity. As per the international statistics, more than 50 million women is getting infected with malaria and 2 lakh newborns die as a result of this infection. And as we see, the MMR rate increased from 36 to 110.2 from 2007 and 8 to 2009 and 10. When coming to the Karnataka state, in 2006, 62,864 cases were reported and Mangalore account for 24 cases. And out of this, 29 malaria-related deaths were from the Karnataka and 11 from the Mangalore. Coming to my objectives of the study, to determine the pre-existing knowledge of antenatal mother on effect of malaria in pregnancy, to find the association between knowledge score of antenatal mother regarding the effect of malaria in pregnancy with selected demographic variable, to develop and distribute health education pamphlet on effect of malaria in pregnancy. As I have taken this study, it is the main need, it is the mothers are at high risk for malaria infection and cause fatal and danger to the mother and the unborn baby. So keeping this aspect, the mother has to be given the important that knowledge aspect we have to focus. So by distributing the pamphlet, it can be increased and we can save the thousands of life. The hypothesis, which is H1, it is tested at 0.05 level of significance. There will be a significant association between the knowledge score of antenatal mother on effect of malaria in pregnancy and selected demographic variable. Coming to my methodology, research approach I choose was descriptive survey approach. Research design was non-experimental, typical descriptive design. Population was antenatal mother. Setting Surathkal PHC. Sample size was 50 antenatal mother. Sampling technique, non-probability purposive sample. The sampling criteria in which inclusion criteria was antenatal mother registered in PHC, residing in selected PHC area, irrespective of gestational age, and who were available and willing at the time of data collection. Exclusion criteria was who were antenatal mother who were previously infected with malaria. The ethical consideration was taken from the Institutional Review Board to conduct the study and also from District Health Officer, Dakshina Kannada District, and Medical Officer of the Surathkal PHC to conduct the study. And for the pilot study from the Bondal PHC, and also individual consent also was taken. Coming to my data collection, the tool used was close-rendered structured interview schedule with knowledge questionnaire containing part 1, demographic performa included 8 items of demographic variable, and the part 2 contained knowledge questionnaire included 32 items related to the effect of malaria in pregnancy. Maximum I could take 5 only per day with the 35 or 40 near to 1 hour for each mother. Coming to my result, we can see that in the age criteria, 21 to 25 where 44% was the majority, and the gravida, that is a second gravida, was 58%, that was a major, and 52% more candidate that has been done their education in high school, and employment was, most of them were housewife with a 56%. And the monthly income were in 38% more in 5,001 to the 7,000, and they were not having any history of malaria in their family, that was 92%, and no information of regarding this one, malaria, effect of malaria. that was 64%, and most of them were residing in the urban area, that was 56%. The level of knowledge of the mother regarding the effect of malaria in pregnancy, the result I obtained was 32 were having moderate knowledge and 68 were having poor knowledge. Coming to the area-wise analysis, the score was the highest score I have seen in 57.43% in the cause and risk factor, as I have divided in the 4 area: general aspect of malaria, cause and risk factor, effect of malaria in pregnancy, and treatment and prevention. The lowest knowledge score was seen in 26.50 in the effect of malaria in pregnancy. Overall score was in the study was 37.44 with a standard deviation 11.98 plus 2.62. And the association, the result was there was no significant association between the knowledge and demographic variable. So the null hypothesis accepted and research hypothesis rejected. The discussion, same similar study has been conducted in the Zimbabwe with a 61.9% in the age group 20 to 29%. In that, primigravida mother were 54.8 with a 62% of cases where more than 7 years they received the formal education. And coming to the analysis, similar study has been done in the Tanzania. 867 pregnant mother relieved, 63% of mother had poor knowledge and 37 obtained average knowledge. And in the association, similar study conducted in Nigeria with the result revealed 43% had the knowledge regarding effect of malaria, but there was a significant association between knowledge of effect of malaria and pregnancy with higher literacy, multiparity, previous history of malaria, and source of information. We can implement this in the nursing practice. That is very benefit because it will save so many lives, both the mother and the baby. And in education, we can prepare the nurses in the future to motivate the mother to do correct practices. And in administration also, we can do the in-service education training for the staff in the maternal wards so that we can give public awareness based on the effect of malaria in pregnancy. And in research also, we can guide the students to conduct the researches and can give the training for the providers, and also protocol can be developed and evidence-based practice for the quality services. The main limitation of my study was the sample size was less. It can be increased so that generalization can be made. And also it is done only in one PHC selected, so it restricts my generalization of the finding. And recommendation, it is the future study can be planned based on the knowledge and attitude of mother regarding the effect of malaria in pregnancy. Comparative study can be done in the urban and the rural aspect based on the effect of malaria in pregnancy. Follow-up study can be conducted to evaluate the effectiveness of health education pamphlet. So coming to the conclusion that as we have seen, the overall findings really majority of the mother had poor knowledge on the effect of malaria in pregnancy and no significance with the knowledge and demographic variable. So it is important we have to focus in this area. Thank you all members. Thank you for kind listening.
Vasanta, you can start.
Thank you, madam. I just wanted to ask Anujoy Kuti, because it was done on antenatal mothers, why you have selected antenatal mothers? This is my question. What is the reason? What you find? What is the scope of your?
Actually, they are vulnerable, madam. So if we give care for the mother, we are saving not only the mother, we are saving the unborn baby also. So 2 lives we are taking care. So that is the main importance why I have focused in this aspect, ma'am. Ma'am, I am not able to hear you, ma'am.
Hello?
I can't hear you, ma'am.
Okay, I'll come like this. Okay, I just wanted to know, you selected the PHC, no? And
Yes.
how you selected the PHC? How you selected? What was the sampling criteria that you have chosen to select the PHC?
Ma'am, it was purposive sampling only, madam. I have chosen, madam.
So that is correct? Do you think you can go with the purposive sampling and you can choose? What is the need for purposive sampling?
Because madam, usually in PHCs, mothers will be coming. So in that area, the malaria was more in that time. So I thought this vulnerable group, if you are focusing, that can be benefited for them. So that purpose only I have chosen the PHC. Because more gathering, we can get it through the PHC.
Okay. Because my concern is when you're going to choose a PhD, it's better you can opt a proper sampling technique, because that is very, very important when you're going to opt this. And what is the scope of yours? Because
lacking
that is
in
very
that
important.
area. Yes.
That is very important when you're going to do it. Okay. And similarly, what is the scope of your study? Because you are done on antenatal mothers and you're teaching them the effects of malaria. And what is the future outcome? Have you recommended, because your recommendation, any recommendation that we can do, like you have to do a follow-up study. And the follow-up study is very, very important to know what was the effect. Then only it will be very useful for us. Okay. So any effect on pregnancy. So such things, I think if you plan, that will be fine. Any outcome-based study or any follow-up studies and with the interventions, that those kind of recommendations will be given, and that will be very much fine. Okay.
Sure,
Thank
madam.
you.
Sure. Yes, ma'am. Thank you for the valuable suggestion.
Maya madam, you can. Maya madam.
In OB-GYN, it is commonly seen that various preventive measures are taken care by our nursing students or teachers from College of Nursing. So that area which you have selected, you used to go there, or first time you are going there?
No, madam. Actually, the students were used to go there. So we came to know that most of the antenatal mother usually will come there. So in that aspect, I thought of choosing this one.
No, were there any cases that who have suffered because of malaria? What is the need of the study?
What I have taken, it is only the mother who are not affected. Actually, the malarial case was more prone in that area in that time. That's why I have taken.
Okay. It's okay.
It is only one time morbidity prevalence you have, incidence, whatever you have seen is, or you have gone through the previous year's reports also?
Yes, ma'am. Yes, ma'am. Yes, ma'am. Reports
we had the same question. Yeah.
Yeah,
Have you seen the reviews and prevalence here?
Not only review, it is saying not only in the antenatal, in common also when we are taking malarial cases was more prone in that particular manner.
See, when you write your significance and justification of disease, all these things should come. Otherwise, it is your justification becomes very weak. There was no justification told by you. So the prevalence of malaria in your state, in that particular district, in that particular village, and in that particular PHC, how many cases over?
How many cases are registered with malaria?
2 to 5 years, how many cases were there? Then in particularly in ANC mothers, how many, what was the prevalence? You have to give all these things. Otherwise, community health studies, public health studies are very weak if you will not give all these things. Okay. And 50 with one PHC and only 50 mothers, it is just a pilot study. You cannot say this was your main study. That is the second thing.
Okay, ma'am.
And which was the year when you have done this study, and which were the months?
It was 2012, madam.
So 12 study you are presenting now. So one thing I would like to say, please update your study data when you present over so many years of gap period. Otherwise, your study will have no relevance.
Okay, madam.
It will have no relevance. Okay. And third is you have given, or in your discussion, you have not even given even an Indian study. You have quoted all these studies.
American study.
And there are hundreds of studies with ANC and malaria, if you will see, hundreds of studies available.
Yes, madam, in review it is there. Even I have also.
No, but you have mentioned us in the discussion.
Okay,
when you have compared your analysis with the studies, all were foreign studies. Okay.
Yes,
so all these things you should take care of. What was the language of the mother?
Madam, Kannada.
So your tool was in Kannada?
Yes, converted.
Translated from English to Kannada?
Yes, I have done.
Then it was translated from Kannada to English?
Yes, madam.
Have you, so you have to give the validity and reliability, both how you have established that?
Yes, madam. It has been done, madam.
And what was the literacy level of the mothers?
Some high school was the more majority, madam.
Okay, you were asking questions on malaria. Were they able to understand the?
Yeah, there it.
Just
there it I
let me
felt.
finish.
Yeah,
Let me
in
finish my question. Let me
sorry,
finish my
sorry.
question.
Okay.
Were they able to understand what you were asking in a closed structure question? Because I feel they must have tick mark with such a low literacy level, with no medical background. They were housewives. So how authentic information you have got? That is my question.
Madam, when I was taking the data collection, I faced this difficulty. I explain it, and then they were also not willing.
Then you should not say it was a closed, it was semi-structured when you are explaining them and going in depth and explaining and asking them questions.
Okay,
So,
madam.
and you should highlight this in your study, what was the problem you had faced and how you had modified your tool.
Okay.
Okay.
Okay, ma'am.
Okay.
Sure.
Okay. Thank you.
Thank you, ma'am. Thank you. Ma'am, any more?
No, your recommendation says na in curriculum we will include the teaching of malaria and all that. I think in one recommendation it is there, if I am not wrong.
Malaria in pregnancy.
Yeah, but it is there already in the curriculum. In community health nursing, in first year we teach, then in third year also we teach, isn't it? So it is already there, and in disease, communicable disease, second year also it is
Yes,
there, even
it
for
is
the
part of a
GNM step.
curriculum.
Yeah, it is a part of curriculum. So that should not come in the recommendation. That is what
And
I feel.
yeah, and you should also see there are guidelines by CDC, guidelines by WHO, guidelines by Government of India. Don't make your own guidelines or anything. Please follow the standardized guidelines for everything, even for educating a mother also.
Okay, madam, sure.
And there will be less queries. Once it is standardized and you give a reference, it is less queries are there by anybody if you present. That, oh, they have taken this from this source, which is very authentic. Okay?
Okay, sure. Madam.
Okay.
Thank you, ma'am. Thank you for the valuable.
Thank you, Anu ma'am. Thank you so much. And thank you, jury members. Jury members, can I ask something? We can have a 15-minute break.
As you decide, Farooq, you tell us.
Please. So if your permission is there, we can go for 15-minute break, ma'am.
Okay, so now it is 12:38.
Yes, it is 12:30. 38. Yes, we will meet after just after 15 minutes only.
Okay, okay.
Okay, thank you so much. Thank you so much.
Okay, welcome.
Thank you.
Welcome.
Thank you.
Bharti ma'am?
Yes, I'm there. Hello. I didn't
madam.
see you in the morning. Namaskar, namaskar.
We have a lot of problems here, ma'am, but 3-4 days power cut. I'm in the university. Actually, I didn't go to university now. I'm sitting at home and doing, because home I'm having Wi-Fi. At university, there is no power for 3 days. So no water for 3 days in the whole town. So this is a problem in Ethiopia. Working in Ethiopia, we have a lot of hurdles.
What other problems you face there?
Military, ma'am, always with a gun.
That is the biggest thing, really. How you manage? How you manage?
They respect the females and they respect Indians also. There is no problem, madam. And I think Ethiopians are actually, like yesterday, madam was telling, no, we have to acknowledge that, like we have to encourage people. So that is a very good humanity nature of Ethiopians. They encourage us a lot.
Okay.
So they, whatever I'm doing, they'll say you do, you do, you do. So the time initially I came itself, I started with a lot of projects all because of them only. Because we have a lot of funding projects here, and they are
That's
very
nice.
interested in research. They are very much interested in research. So you can see,
Very
SPS is all, they never go for any statistician. They do by themselves. They get the training. So they have a funding, UNDP funding, so they utilize it.
That's really nice.
Yes, ma'am. Nice meeting you all, ma'am. I'm so happy. I'm very blessed to be with you all. Okay, so
Same here. Vasanta, same here. Same here.
It is nice to meet. Yeah.
Yeah, nice to meet different people, because everyone has something to give and contribute.
Yeah.
So I really like that.
And once you have a mentally same thinking, then you enjoy more.
Yeah, exactly. Exactly. Yeah, yeah. Like-minded people, getting them is really difficult.
Yes.
But if you get, you shouldn't lose them.
Yes.
That is. Yeah,
I do agree with that.
Yeah, yes. 100%.
Like we had a very good knowledge from Raman madam, A.V. Raman.
Yeah, I know.
I know her.
Yeah.
Very
She's
senior
excellent.
madam. Yeah, yeah.
My UG and PG, she is my teacher, and I did my PhD in INC, Indian Nursing Council. Maya madam was my guide.
She is the one genuine person ever I have met. One of the best person.
Yeah.
So I'm blessed, ma'am. It's always my company, my association will be with good people only.
No,
so always,
actually, no. Previously, like I am from RAK College of Nursing, Delhi. We had excellent teachers, Dr. Arpana Bhaduri, Miss Haq, then Usha Malik Madam, Harinder Goyal, Asha Sharma Madam. They were my excellent teachers, Vandana Bhattacharya, Mrs. Katuria. There, you will not find those type of teachers.
Yeah.
They're excellent. Sandhya Gupta Madam, I remember my secretary teacher, till date I tell her, the way you have given us the basics of psychiatry.
Yeah, concept of psychiatry, very important.
No one else can give that. She is one of the excellent teachers. Excellent.
Ma'am, the way Neeraja ma'am is telling, you are giving the outputs for the students. I felt it was like Asha Sharma ma'am, because Asha Sharma ma'am also very nicely she will tell only the essence, whatever is required, that will come out. Okay,
like
so
I remember my guide was Dr. Sharma from education in RAK and Ms. KK Gulani. They told in the beginning, we will only work for you if you will work for your thesis.
Self, yeah, exactly.
And every Wednesday we used to have a guide meeting, and whole night I used to study research. But I was fortunate in BSc and Master. Dr. Arpana Bhaduri was our teacher of research.
Very great person.
Yeah, I can never forget. She was the best for the research in whole of India. One of the best person. After that, I met Dr. Raman, KV Raman. She was one person I found. Second person.
She's good in knowledge, ma'am.
Yeah. Like Miss Haq was a model teacher in RAK.
Yeah, ma'am.
I really tried to follow. I said I cannot become like her, but at least I can adopt some of her good qualities to become a good teacher. It's very difficult to find teachers like that.
Ma'am, I did my post-graduation under Madam Usha Ukande, Usha Malik at Choitram. At Choitram Hospital I did. So I know Usha Madam. Yeah, really, she was a very graceful and very,
used to come to our college, ma'am. She used to be in our college, Omaila.
Yeah, she was student of Raman madam. For our PhD guide was Raman madam. Yes.
Ma'am, very well, ma'am, from Chaitra.
Then I went to JNU for my public health PhD. Their teachers are altogether different. You will really amazed to see professors like that in universities. Amazing it is. Amazing. Excellent teachers. You will not find in nursing or this colleges teachers like they will do anything for the students. And the way they guide you, they give you a vision. I told my guide, I said, actually, I have learned from you how to guide a student.
Student, yes, that is so important. Yes, ma'am. Yes, ma'am, I think Vasanta, I think we are taking the time of the presenter. They are chatting that the legends are speaking. See, look at their chat. They are telling best wishes. We can listen to their speaking and all. They are putting on the chat.
When legends are speaking, we are looking to hear from the legends. We were just calm and quiet sitting here.
Yeah, I know that is your greatness.
I think the time takes changing.
So we'll start. Yeah.
Actually, ma'am, we are lucky. We are lucky to hear the chatting also, ma'am. Really.
Shall we start, Farooq?
Yeah. Yes, ma'am. Yes, ma'am. Dr. Guneshwari Das, ma'am. Hello, Doctor.
Yes, sir. Good afternoon. Good afternoon, everybody.
Yes, ma'am.
Yeah.
Please proceed.
Good afternoon, everybody. Good afternoon, jury. Madam Patlia, Madam Bharati Batra, Madam Neerja Sood, Madam Vasanta, Madam, and everybody, Binu sir, Farooq sir. It is my pride privilege to present my paper in front of everybody. It is with my own interest I started present. I did this small study and I want to share the slides now. Just I would like to ask whether it is visible. Is my slides are visible?
Yeah. Put it on slideshow. Yeah, put it on slideshow.
Yes. Yeah. So my topic, my study topic today is the prevalence of low birth weight and its risk factor among postnatal mother in district hospital of Kabirdham, Kavarda in Chhattisgarh. My allotted number is AP 70/2020. So the introduction of topic is children's health is a nation's wealth. Healthy citizens are the strong pillar of a nation. Mothers play a vital role in providing healthy citizens from the beginning of their life in the womb by taking care of them. Low birth weight infants are 46 times more likely to die in neonatal period. Low birth weight and preterms likes to die before their first birthday itself, and survivor may suffer from a number of health problems, and very low birth weight infants have 200-fold higher risk of the neonatal death. This has been given by the Dan Shankar 2013. Then an average birth weight of the newborn baby in our country is about 2,800 grams to 3,000 grams. A neonate whose birth weight is less than 2.5 kg at birth is called as low birth weight as per the Indian Academy of Pediatrics. In India, the low birth weight is in the country is estimated about 40%, and nearly 80% of neonatal deaths and 50% of infant death occurs among the low birth weight, the newborn itself. This also has been quoted by IAP. Especially in Chhattisgarh, the incidence of the low birth weight is estimated 17% of the total newborn birth, and it has been given by the National Family Health Survey. And percentage of live birth that weighs less than 2.5 grams, it is given by the UNICEF also 2019 again. The need for the study is the incidence of the low birth weight neonate in India varies between 25 to 30% as per the WHO. It varies in the state to state, and low birth weight is more common in WHO only, and UNICEF they have given the estimate prevalence that and the low birth weight is very common in the north side, and it is very less common in the northeast and south side. It was given like that. Then according to nearly 15% of the babies worldwide are born with the low birth weight as per the UNICEF. According to Pediatric Healthcare Survey in 2015, very low birth weight contributed, where baby contributed 75.6% in the total population, attribute risk to stillbirth and neonatal death nearly 29.4%. And I have developed another thing is that while going for the supervision along with the students, we used to go to neonatal ICU also, and there whenever we used to ask what is the weight of the baby, or we used to see the registers, no admission register, every time, many times I have noticed that low birth weight babies only comes to a hospital, many of the babies. So with my own interest, while visiting, I have seen that babies are, we have 12 beds only in our NICU, but in that, and rest we are keeping in the, along with the mothers also, if the baby is stable. But in that, majority 10 to 11 children, newborns used to be low birth weight, and very rarely we will see normal birth weight or it is appropriate. The statement of problem of my study is a study to determine the prevalence of low birth weight and its risk factors among postnatal mothers at the district hospital of Kabirtham, Chhattisgarh. The objective of the study was to find out the prevalence of low birth weight babies in the district hospital Kabirtham, to identify the level of risk factors for low birth weight among postnatal mothers in the district hospital Kabirtham, to find out the relationship between the low birth weight and its risk factors among postnatal mother in district hospital Kabirtham, to find out association between low birth weight and selected demographic variable, and to find out the, sorry, this is duplication. So this is the objective of my study. Then the research hypothesis are, there will be a significant relationship between the low birth weight and its risk factor among postnatal mothers in the district hospital Kabirtham. There will be a significant association between low birth weight and its selected demographic variable, and there will be a significant association between the low birth weight and that is also, sorry, duplication. And the conceptual framework was developed by the Rosen, Steck and Backers in 1974, and based on that, it has been, key domains has been taken: individual perception, modifying factors, and likelihood of taking actions. So in that, we have tried that all the demographic variable which can confer, or which can be, have any kind of association with the risk factors of another. We have around that, we have this has been categorized in two areas of prevalence of low birth weight by using electronic weighing scale, and risk factors such as antenatal factor, obstetrical factor, nutritional factor, and fetal factor. There are many factors, but all the risk factors we have categorized in 4 factors. Then in everywhere we'll find here the babies will be MLBW, that means moderately low birth weight babies, and very low birth weight babies, and extremely low birth babies. The WHO and IAP guideline has been taken based on the weight of the child. The 3 categories has been done. Between 2.5 to 2 grams, it is moderately low birth weight babies. Between 2 to 1.5, it is very low birth baby, and between this is extremely low birth, less than 1000 grams is extremely low birth baby. So self-instructional modules has been given to the, actually I had a plan to prepare that, but we didn't prepare it later on because it was not really useful. They were just, because before that also we have done one study, but they have not, they didn't take that. Sometimes they are living in the hospital and going home. So we started giving education rather giving pamphlets to them. So the review of literature was based on consists of 2 sections. Section 1 was literature related to association of low birth weight with risk factors, and section 2 was studies related to low birth weight. The research methodology was, the research approach I had used is quantitative approach. Design was descriptive research design. Setting of the study was postnatal ward in the government district hospital Kabirtham, and population was mothers of the low birth weight newborns. And sample size taken 60 postnatal mother and their low birth newborn to fulfill the inclusion criteria. Sampling technique was non-probability purposes sampling technique was taken. Then criteria for sampling selection was inclusion and exclusion criteria has been taken. So here the mother for inside the inclusion criteria, mothers of low birth weight newborns was selected, and mothers available during the time of study period, and mothers who were willing to participate in as study, and term babies with intrauterine growth retardation we were taking. Then exclusion criteria, if the babies are critically ill, mother is also critically ill to respond, and mother affected with any kind of psychological problem and they are not willing. In that condition, we exclude. The tool used for that is we have used the plant interview schedule and a description of the tool. It is consists of 3 parts. Part 1 was section A and section B. It deals with the demographic variable of mothers and demographic variable of newborn. And part 2, it was a weighing machine by which we were using electronic weighing machine by which we have used to weight the baby. And part 3 was consist of questions related to risk factors of the low birth weight babies. Here, it is again categorized in 4 sections. Section 1, obstetrical factors was there. Section 2, antenatal factor. Section 3, nutritional factor. And Section 4, fetal factor was there. Then scoring procedure was done for the based on the classification of the low birth weight babies. Here, as I have told you, moderately low birth weight babies between 1500 to 2500 grams. Very low birth weight babies 1000 to 1419 grams. And extremely low birth weight babies less than 1000 grams has been taken. Another in this tool 3 we have used consists of 4 sections, as I told you, that obstetrical factor, antenatal factor, nutrition factor. Each section carries a different score. I'll explain here what is the scoring criteria I have chosen. For the section 1, like for obstetrical factor, we have chosen 6, have formulated 6 questions in that yes and no pattern. All the sections was divided into yes and no pattern. Giving yes, then we were giving 1 number and no means 0 number. So total 6 marks. So total number of score was 6. Mild was 0, and if factors was again divided into 3: mild, moderate, and severe risk factors. So your mild means 0 to 2 if they are getting score, and moderate 3 to 4, and severe means more than 4. Same here in section 2, antenatal factor. Total number of questions was 20. Number of score was also 20. Mild was 0 to 10. Moderate was scored 10 to 11 to 50. Severe was more. This was done by us only. There is no standard guideline for that. The scoring has done by ourselves based on the percentage of questions and the education, this evaluation criteria. Then section 3, nutritional factors has been taken. In that total number of questions were 5. Total score was also 5. Mild was 0 to 2, moderate was 3 to 4, and severe was more than 4. And section 4, fetal factors has been observed. In that total 4 factor questions were there. And score was also 4. Mild was less than 1, moderate was 1 to 2, and severe was more than 2. The reliability and validity of the tool has been, reliability was done by the test-retest method and calculated by Karl Pearson values, and it was R was 0.86, and validity was done from the 5 nursing expert and 2 pediatrician. Hindi section of the tool was validated by the Hindu literature expert. The ethical consideration, formal permission was taken from the principal, Government Nursing College, Kabirtham, firstly, because as I am working here, so I have to take permission from my HOD. Then written permission has been taken from the civil surgeon of District Hospital, Kabirtham. Later written permission has been taken from the matron and NICU and labor room staff of the Government District Hospital, Kabirtham. Verbal consent has been taken from the postnatal mothers of low birth newborn. Data analysis has been done by using SPSS version 16. And this is the frequency and distribution of the samples according to demographic variable of the mother. I have taken 60 mothers. So in that, majority of mother was between 21 to 30 years. And if we see the educational status, majority of mother was having high school education. If you go for the occupation, here many of the they work as daily wages worker, and they were majority of the family, majority of the mother, they were living in the nuclear family. But joint and nuclear family, it was not so much difference, only 10% difference was there. And religion, if you see, majority of women were falling in Hindu religion. And if you see the family income, majority of the family income was between 2,000 to 5,000 per month. And they are living in the rural areas, majority of, and very less were in urban. And if you go to marriage also, non-consanguineous marriage was more common comparatively consanguineous. And if you go for nutritional pattern, non-vegetarian were high, 82%, comparatively vegetarian. Then this is the frequency and the percentage distribution of the sample of the demographic variable of the child, newborn. So here I have chosen 3 factors only, like order of the child, sex of the baby, and gestational week of the child. So frequency, you see, majority of the children, majority of the family, they have second child. most of the child was second child, they have more common. And 3 and above is also there, nearly 23. In one thing I want to tell here, ma'am, in Kabir Dhamma, when I came here, I have seen that many of the families, they prefer to have more children because of they want to have a male baby comparatively female baby. Even that I have come while doing this study only, I came to know all these things while talking to the mother. So that's why this more than 3 children and about 3 and 3 children also. If you see here, many of the children are having like this. And sex of the baby, male for 36, female for 24, apart from the 60 mothers. And gestational weight less than 37 weeks was 22, and more than 37 weeks was this was and it was also, I can't see this. It was also 36. Then in section 2, frequency distribution of the percentage regarding the prevalence of low birth weight. So here, what I have done during the till now, what I have collected the data during that time, total 210 children newborns I have seen through records. That in that we have categorized based on their birth weight. So it has been noted that moderately low birth weight children were 101 among these 210 low birth weight children, and very low birth weight 91, and extremely low birth weight was 18. So majority of the children and newborns, they falls into moderately low birth weight, which can be treated in the secondary care hospital. Then frequency distribution percentage of the sample according to the level of risk factor of low birth weight. So here I have, as I mentioned you before, that we have categorized in 4 factors: obstetrical factor, antenatal factor, nutritional factor, and fetal factor. So here mild influence, moderate influence, and severe based on the scoring criteria, this has been given. So if you see the obstetrical factors, majority 38% has mild influence, antenatal factor majority for 52% has mild influence, and severe influence was not there. Then nutrition factor, if you see, majority moderate influence was there in the 28%. That was there in the moderately influence. And fetal influence, if you see, the majority was 37%, 37 numbers, and 62% was factors were affecting mild influence. Then relationship between the low birth weight and risk factors of the low birth weight baby. Here we have seen that low birth weight and the risk factor associated with using the R values, and this was the important of this study, and it has been noted the R value was 0.369. And it was a positive correlation because it comes into, it falls, the result falls between the 0 to 1. So there is a positive correlation, and significance was calculated based on the 0.01 level of significance. So this was the actually essence of this study, that there was a correlation between the low birth weight and the risk factors. And another section, association between the low birth weight and demographic level of the mothers, has been again noticed, in that the result shows that there was a no significant association of low birth weight babies and demographic variables of the mother, such as occupation, type of family, religion, and area of residence, type of marriage. But there was a significant association between the low birth weight and the age of the mother, educational status, and income of the family, and nutrition pattern of the mother. After the calculation, the association between the low birth weight and demographic variable of the child, here the result shows that there was no significant association between the low birth weight and the sex of the baby, but there was a significant association between the low birth weight and the order of the child and gestational week of the newborn. And here again in section 4, association between the obstetrical factor and demographic variable of the mother and the child, here the result shows that there was no significant association between the obstetrical factor and demographic variables such as age, educational status, occupation, type of family, religion, area of residence, income of the family, type of marriage, nutrition pattern, order of the child, sex of the baby, and gestational week. But there was a significant association between the obstetrical factors and type of marriage. Then another association between the antenatal factors and demographic variables of the mother and the child. Here, the result shows that there was no significant association between the antenatal factors and demographic variables such as age, occupation of the family, religion, type of the residence, nutritional pattern, and order of the child, sex of the baby, and gestation week. There was a significant association between the obstetrical factor and educational status, income of the family, and type of the marriage. Then again, another association with the nutritional factor and demographic variable of the mother and child has been calculated. In that, the result shows that there was no significant association between the nutritional factor and demographic variable of the mother, such as educational status, type of the family, income of the family, type of residence, type of marriage, nutritional pattern, and order of the child, and sex of the baby, gestation week, etc. But there was a significant association between the nutritional factor and occupation of the mother and the religion. Association between the factors, the fetal factors and demographic variable of the mother. In that, the result shows that there was no significant association between the fetal factor and demographic variables such as age, education, status, type of family, religion, type of marriage, nutritional pattern, order of the child, sex of the baby, and gestation week. But there was a significant association between the fetal factor and occupation, income of the family, area of the residence. So in the discussion part, my study has been supported by Mondelb in 2010. They have conducted a study on risk factors of low birth weight in Nepal infants. He reported that the incidence of the low birth weight was 21.53%. The result is unvariable analysis revealed that the maternal age parity, gestation period, economical condition, and maternal education was significantly related to the incidence of low birth weight. Another finding, it is an Indian study, Radhakrishnan et al. They have given in 2013. The study shows that socioeconomic status was the principal determinants of the low birth weight babies. The implication to the nursing practice, there are many other implications also there, but I have quoted only for nursing practice. The study will help the nurses in the hospital and the community to plan the antenatal health education program, which area is associated and which area we are lacking. The health education activities can be initiated from the student and early detection of the risk factor. Marital counseling can be given to the girls and reproductive age group regarding the age of marriage and the pre-pregnant weight of the mother. And the finding would be the nurses in planning, organization, implementation, the mother, and implementing the measures to reduce the low birth weight children. And recommendations, similar studies can be conducted in large samples. Experimental study also can be done with the effectiveness of antenatal to see the effectiveness of proper antenatal care on risk factors. Then exploring a longitudinal study can be done in this. We can go for cross-section as well as longitudinal study. Then, exploring this study may be conducted by access of knowledge to the mothers regarding low birth weight and its prevention. Then explorative study may be done to assess the knowledge of the mothers regarding care of the low birth weight babies. A comparative study can be conducted among rural and urban mothers also. These are the reference. So just I want to conclude, if the baby is born with less weight, it is definitely anxiety for mother and the entire family. As per the record, the occurrence of low birth weight is high in government district hospital Kabirtham. Based on the result, I found that there is a need for the good antenatal care to prevent the occurrence of low birth weight. So this is all about my study. Just with that, I would like to ask expert that please you ask questions from me regarding my studies and give me suggestions, ma'am.
Unshare your screen.
Yeah.
Unshare your
I'll unshare
screen.
it. Yes, ma'am.
Bhuneshwari, put off the screen, your screen.
Yes, ma'am. Yes, ma'am.
Sharing the screen, you can put off.
Yes.
Yeah.
Yes, thank you, madam, for patience listening. And thank you, everybody, for giving me a
Bhuneshwari,
chance.
my question to you is, after all, what is the use of this study?
Yes, ma'am. It is very true. Actually, madam,
the use of this study, because see, one thing, whenever we do any study, it should be useful to the society, and it should add some knowledge to already existing knowledge which we have in different fields. So, how your study is useful, dear?
Yes, ma'am. I just would like to ask, tell about the reality of this Kabir Dham a little bit, because this is a remote area. And madam, why I chosen this study? Because it is very known that antenatal care is important for to prevent the low birth weight baby. It is published in every area, and it is recorded also and proved also. And use why I have chosen, madam, as it is a district hospital and nearby places, no ma'am. Here only this hospital, poor people comes. And thing is that here this is the border of MP and Chhattisgarh. So tribal people and Baga people, and they are really very illiterate. And when they come to hospital, their weight of the mother, and if you see HB of the mother and the how they are taking care of the children, and they are not going for the family planning also. So when we are educating them, it is very difficult to understand. They are not understanding to us. So when I was going to hospital, many of the children that comes from that side, that mothers are, they're not aware, because nobody goes to that. PHCs are very far, and they are not having a vehicle to come to some remote areas like that. They're very backward people, madam. They are not, sometimes they don't understand Hindi also properly. So we have to talk in their local language, then only they understand. So even while interviewing also, I had this problem. I have prepared in Hindi.
No, did you educate them or something? No, na? You have not done any intervention.
Madam, intervention, no, madam, because yes, ma'am.
It is a descriptive study in which you have only collected the data that what are the risk factors for the low birth weight, isn't it? Babies, isn't it? So how it is useful, that need to be thought over actually.
Then no, madam, what I did after getting this information, I have reported this one to CS also, and to the matron, and along with that we have, though our students are giving, and they're giving antenatal health education to wards also, but this has been made in routine, and only few numbers of mothers we were taking daily, and then batches wise we used to do, so that they will understand properly. And with some live things, means if you are talking about food materials, so we were showing them food, what can be used. If you are
yeah, but these are the part of curriculum, no? As a teacher, we know that we include all these things in obs-gynae, maternal child health care and all. We keep on telling students, these are the factors you need to look and all. So that's a different thing. But I have this question now, other panelists will also ask you.
Yeah.
But this was my concern, that how it is useful to the antenatal mothers and how it is useful to the babies, those who are already born and those who will be like they again coming as a low birth weight baby. Okay, that was my question and concern as well. Okay.
In support to Madam,
please.
In support to Madam Bharti, I want to just add in that it is very true that we just finding the report already, which is prevalence, and giving to CMO. It's nice, but as a nursing personality, when we go there, we can have some like high protein, some powders or something they can make and introduce. So they will feel happy that somebody has done something. So some future result may be improved. Just in support of Madam's question.
Yes,
yeah, very
thank
true.
you,
Very
thank you so much.
Yeah, Bhubaneswari say my observations are also same. There are thousands of studies which are available. And Chhattisgarh is a very progressive state where even under National Health Mission, they have done lots of good work.
Lots of study, yes.
Okay. My concern is if you would have done a study on, because nowadays ASHA and ANMs are following up the mothers in the villages. If you would have done a study on them,
what they're doing.
Yes. What is their role and how they are, why they are not able to reach to these mothers, and if they are able to reach, if they are giving education, what are the underlying factors? Okay.
Yes.
Then second is implementation of Government of India guidelines of kangaroo mother care. Then feeding guidelines for low birth. You could have seen, are they being implemented? If they are being implemented, what are the strong points and where are the gaps? And if they are not being implemented, and how to remove that gaps? That would have been a much better thing. Then there is a facility-based care for Government of India guidelines are there. Are they being implemented in your hospitals? Are the home-based care are implemented in your hospitals? If you take a broader conceptual framework, what every speaker is telling, your study will have a value. Rather than just seeing what is the knowledge of the mothers. We know, okay, because we know in these areas, when there is a concern of socioeconomic factors, the poverty is there, illiteracy is there, these will have, these factors will be there. But if you see why the guidelines are not being followed, where are the gaps? What are the strengths? Chhattisgarh have lots of strengths in their system. Find out that how to use those strengths to bridge out these gaps. That is an important thing. And my last question is, you have not taken permission from ethical committee. You have taken only permissions from the institutions, not from ethical committee. And verbal consent, who was your witness for the verbal consent? Verbal consent, you cannot say just they have given a verbal consent. Who was the witness to your verbal consent that actually you have taken a verbal consent? Why, from all the mothers' verbal consent, why mothers have not given you a written consent? वो अंगूठा लगा सकते हैं, अगर साइन नहीं कर सकते तो. So there are so many issues which you need to take care of. Okay. So these are some of my points. You have to broaden your study. What you can make is, you can base this knowledge, make a baseline of this knowledge, then go to the field and see how ASHA and ANMs are working, what are the facilities available, then find out the gaps and try to bridge up those gaps. Then your study will have value. These are my observations.
Yes, ma'am. One more question.
Very true. Very true. Descriptive study.
Why child's demography you have taken? That small child who cannot, what is the importance there?
Madam, because sometimes they also have their own factors to be the low birth weight. Sometimes maternal factor also influence and child factor also influence. So that is why I have taken their factors also.
So in that demography word का मतलब क्या है? मतलब मेरे को थोड़ा clear करते हैं.
Madam, it is some
baby's demography.
Yes, ma'am. It is actually some factors which affect our study directly. That we are controlling in the beginning itself. So because of that, we are stating the demographic variable. For that, we have stated this. So how it is affecting our study and whether it is associated, because chi-square I have taken at the last, whether it is any kind of association is there. So for that demographic variable.
Operational definition में आपने उसको specify किया क्या?
Yes, ma'am. Yes, ma'am. Though I have not shown the charts, tables, but I have written in description, madam.
And one thing I will request all the nursing researchers, it is very important to move forward from descriptive studies. Just statistically proving is not enough unless you find out what are the underlying factors, what are the gaps, what are the strengths, and what nursing can contribute actually in the practice area to bring out that. Then only our studies will be, recommendations will be taken into consideration by the authorities. Otherwise, they will not take into consideration. Okay, that is the
very true.
Actually, thank you. I just wanted, Bhuvneshwari, that's a question from myself. Like exclusive criteria, you have mentioned mother and child. Because you have taken a child of moderate. Are you able to listen to me, Bhuvneshwari? Bhuvneshwari?
Maybe some network issue, ma'am. She is not here.
She's not here. Okay. No, then there is no issues.
Yeah.
Bhuvneshwari?
She joined. She joined.
Yes, ma'am. Yes, ma'am. It was.
Bhuvneshwari, I just wanted to ask you. Exclusive criteria, you mentioned critically ill mother and critically ill child. Okay. Critically ill child, the child is, the classification is moderate, extremely low birth weight, and you are told about a very low birth weight. So when they are under very and extremely low, most of the time they will have a critical illness. They'll be there. So I think it would have been better that you could have mentioned what are the critical illness you have excluded. So that should have been mentioned. Okay. And also the reliability, you're done, the tools, 0.86 was the score. But what about the instrument that you used for checking the weight? It's a standard weighing machine.
infant weighing scale, you would have checked.
Yes, ma'am. Yes, ma'am. Yes, ma'am.
But what
It
about
is a
the reliability of that
electronic
instrument? That is also important. Reliability of the instrument is required. That is
And
more.
then one thing I think, Vasanta, what you are saying is very relevant. And what was the standardized procedure? How you have taken the weight is also an important. That's what I will like to add with the Vasanta.
Thank you, ma'am. Thank you. So here also review of literatures, and I think you are taken from IAP 2015 all. IAP is very much more and more studies on low birth weight is coming in IAP journals. Updation is required in regarding that, and Nepal studies all. I think in India we have many studies. As I think all my experts, those who have told you the inputs, they have told very well. Kindly go for at least you can do a mixed methodology design. You could have taken all the factors and then you could have gone for some intervention that would have been very much. It would have given a lot of strength for your study. So you could have tried in that way. Okay,
Sure,
I think you can. Future you can think about that, and as
madam, I can extend the study in that way.
Sure. Yeah, that will be best. That will be best.
Yes, ma'am. Yes, ma'am. Sure,
and see, something is useful for the people, those who are involved as subjects. Something they gain.
Yeah.
Okay, that should be your motto.
Even, madam, the basic thing here which is lacking, truly speaking, even breastfeeding techniques and breastfeeding by the mothers, it is really lacking. When we go and kangaroo mother care, really very sorry to say, but practice is it is really nil. I have seen though low birth weight babies. We used to tell, we have kept posters also, but they don't practice.
Then you find out the gaps. Why these gaps are there for the practices? That will actually strengthen your study.
Yes, that is the area which you can always tap that area which is lacking there. No, that will give you strength to your study, and it will be accepted in the by the people those who are practicing that. Okay. Yes.
Yes, ma'am. Yes, ma'am.
Okay, all the very best.
Look for this.
Very best. Best of luck.
Thank you so much, madam. Thank you, madam, for giving me valuable suggestions and
take it positively. Take it positively. Okay.
Sure, ma'am. Sure. For that only I have joined this webinar, madam.
Your area
thank you, ma'am.
is a very need-based area. This is a
need-based area
of government also. If you will come out with a good recommendations, even your state government, I know some of them are very positive. Even the mission directors and those people are very positive in Chhattisgarh. You can present to do a good study.
I think so. I need to find out, madam, where is the how to approach to them and how to bridge this gap. So that I can at least
you can meet your first district people, then you can approach them, but you should have some good data in your hand to present to them first.
Some evidence I should have.
Yes,
Thank you so much, ma'am. Thank you for valuable suggestions.
Thank you, and
thank you, ma'am.
All the best.
Thank you so much, ma'am.
Thank you, Guneshwari ma'am. Next. Yes, next, Matthew, sir.
Yes, sir.
Yes, yes, sir. Please proceed your presentation.
Is it visible, sir?
Yes.
Yes, sir.
Okay. Good afternoon, most respected jury members, respected NTI members, and my dear friends who are listening me now. First of all, I would like to thank scientific team and office bearers of NTI for giving me an opportunity to present my research paper, which I done as part of my PG thesis at RK College of Nursing in front of such a wonderful, renowned research panelists and judges. And I would like to start my presentation. Introduction and background. Cancer is a very common non-communicable disease in our country. It can affect all walks of life at any time. There are more than 200 types of cancers which affects almost all parts of the body. As per the latest cancer statistics published in cancerindia.org.in, in the male community, the most commonest cancer is mouth and lip cancer, followed by lung cancer, stomach cancer, colorectal cancer, and esophagus cancer. Whereas in female community, the most commonest one is breast cancer, followed by mouth and lip, cervix, lungs, and stomach. Title of the study: a study to develop and evaluate the effectiveness of a mobile app, CanScreen, on selected common cancer screening procedures and preventive measures in terms of knowledge and practice among the undergraduate students of selected colleges of Palakkad district, Kerala. Operational definition. In this study, mobile app CanScreen refers to an Android mobile-based self-learning material for achieving knowledge and practice regarding selected common cancer screening procedures and preventive measures. In this study, selected common cancer screening procedures and preventive measures refers to screening procedures and preventive measures of cancer of mouth and lip, cancer of breast, cancer of cervix, cancer of colorectum, and cancer of testis. Objectives of the study: to develop mobile app CanScreen on selected common cancer screening procedures and preventive measures, to assess and evaluate the knowledge and practice of undergraduate students regarding selected common cancer screening procedures and preventive measures before and after the use of mobile app CanScreen, to find the relationship between knowledge and practice of undergraduate students after the administration of mobile app CanScreen, to determine the association between knowledge and practice of undergraduate students after the administration of mobile app CanScreen with selected variables such as gender, stream of study, year of study, religion, education status of mother and father, history of cancer in family, presence of healthcare professional in the family, previous exposure to education program on cancer screening and prevention. Objectives of the study. Last objective is to determine the acceptability and utility of the mobile app CanScreen in terms of opinion of undergraduate students. Research methodology. Approach is quasi-experimental approach. Design one group pretest post-test design. Independent variable mobile app CanScreen on selected common cancer screening procedures and preventive measures. Dependent variable knowledge and practice of undergraduate students. Research setting is CEDAC Arts and Science College, Manarkad, Palakkad district, Kerala. Population undergraduate students of arts and science colleges. Samples is 126 students. Sampling technique, stratified random sampling technique. I have taken students from art stream, commerce stream, and science stream, 42 students each, and also taken equal number of students from first year, second year, third year, 14 students each. And both boys and girls I have taken equal in number. Tools. I have used 7 tools. Tool 1 for demographic profile. Tool 2 is structured knowledge questionnaire. Tool 3 is structured self-express practice checklist for mouth cancer and colorectal cancer screening. Then tool 4 is breast self-examination practice checklist. Tool 5 is checklist for cervical cancer screening. And tool 6 is self-express testicular self-examination practice checklist. And tool 7 is structured opinionaire. Test, retest method, Cronbach alpha used to establish the reliability of the tool. Validity of the tool established by submitting to 11 experts in the field of oncology, nursing, and oncology. Schematic representation. On day 1, I have administered a pretest, followed by intervention, that is administration of mobile app CanScreen. And day 8, I have done the post-test. Collection, ethical clearance from the institute body. Administrative approval got from the college. Written informed consent obtained from the college students after explaining the purpose of the study. Confidentiality and anonymity maintained throughout the study. Total duration of the data collection is 15 days. Approximately 45 minutes took by sample to answer the tools. Analysis. Section 1. Findings related to this sample characteristics. The pie diagram shows the percentage distribution of undergraduate students in terms of gender. Both females and males equally distributed, that is 50%. And most of the samples belongs to Hindu religion, that is 46.04%. Educational status of the mother, most of them belongs to 11th to 12th class, that is 41.27%. Educational status of father, that is also same 11th and 12th class, 38%. And history of cancer in family, majority of them does not have any history of cancer in family, 76.62%. And the presence of healthcare professional in the family, majority of them does not have any healthcare professional in their family, that is 83%. And the previous exposure to cancer screening and the prevention education program, 77.78% does not have any previous exposure. Section 2, findings related to evaluation of effectiveness of mobile app in terms of knowledge. Table number 3 shows that post-test mean, that is 22.91, is higher than the pre-test mean, that is 5.94, which is suggesting that the mobile app CanScreen is effective to enhance the knowledge of undergraduate students, as well as the post-test ST 2.44 is lower than the pre-test ST, that is 3.22, indicate that the group become more homogeneous after the administration of mobile app CanScreen. And the area-wise gain, highest gain occur in the area of carcinoma breast, 64.88%, followed by colorectal cancer, that is 62.60%. And section 2C, my research hypothesis H1, the mean post-test knowledge score of undergraduate students will be significantly higher than their mean pre-test knowledge score after the administration of mobile app CanScreen on selected common cancer screening procedures and preventive measures, as evident from structured knowledge questionnaire at 0.01 level of significance. Table number 4 shows that the calculated t-value, that is 41.39, is higher than the table t-value for the degree of freedom 125, that is 2.62. And the mean difference obtained is a 2 difference, not by chance. Hence, the research hypothesis H1 is accepted and the null hypothesis is rejected. Section 3, findings related to evaluation of effectiveness of mobile app CanScreen in terms of practice. My post-test practice mean, that is 45.94, is higher than the pre-test mean, that is 12.76, suggestive that the mobile app CanScreen is enhancing the knowledge of undergraduate students. And the standard deviation, post-test standard deviation 3.23 is lower than the pre-test standard deviation 3.86. So indicate that the group become more homogeneous after the administration of mobile app. And the area of knowledge for the female sample in the practice section, highest knowledge, highest practice in the area of CA breast, that is 93.57%. And for males, the highest gain occur in the CA testis, that is 78%. And my second research hypothesis, the mean post-test practice score of undergraduate students will be significantly higher than their mean pre-test practice score after the administration of mobile app CanScreen, as evident from the structured practice checklist at 0.01 level of significance. And the table number 6 shows that calculated t-value 72.13 is higher than the table t-value for the degree of freedom 125. And the mean difference obtained is a 2 difference, it's not by chance. Hence, the research hypothesis H2 is accepted and null hypothesis rejected. Section 3, findings related to relationship between the post-test knowledge score and post-test practice score. Here my third research hypothesis, there will be significant relationship between post-test knowledge score and post-test practice score of undergraduate students, as evident from structured knowledge questionnaire and practice checklist at 0.05 level of significance. Table number 7 shows the calculator R value, that is 0.21 is higher than the table R value for the degree of freedom 124, suggests that there is a positive correlation between the knowledge and practice. As the knowledge increases, practice also increases. Section 5 is findings related to association of the selected variable with the post-test knowledge and practice. First, we'll discuss the association between the post-test knowledge score and the selected variables. Here the fourth research hypothesis, there will be significant association between the mean post-test knowledge score of undergraduate students and selected variables after the administration of mobile app. And the selected variables are gender, stream of study, year of study, religion, education status of mother and father, history of cancer in the family, presence of healthcare profession in the family, and previous exposure to cancer screening education. Table number 8 shows that there is a statistical significant association between the variables such as stream of study, year of study, and presence of healthcare. So my research hypothesis H4 is partially accepted and the null hypothesis H04 is partially failed to reject it. And the findings associated with the selected variables and post-test practice. Here my H5, that is there will be significant association between the mean post-test practice score of undergraduate students and selected variables after the administration of mobile app CanScreen. And the table number 9 shows that there is statistically significant association with the gender and post-test practice score. Hence my H5 research hypothesis partially accepted and the null hypothesis partially failed to reject it. And the last section is findings related to acceptability and utility of the mobile app CanScreen by the undergraduate students. The pie diagram shows that 72% of the students accepted the mobile app to a great extent. And discussion, in the present study, there is a inadequacy of the knowledge we could find out in the pretest, and the similar findings are reported in the Manigandan S. et al. They conducted a study at Bangalore in a professional college students, as well as in the Tapera R et al. Conducted a study in Botswana University of College regarding the cancer screening technique. And in the practice also, the inadequacy of practice among the undergraduate student in present study. Again, the similar findings reported in Madhu Kumar S. and Tambarian et al., as well as Gandhi MB and Milat WA. Then effectiveness of mobile app, effectiveness in improving the knowledge of practice about cancer screening and preventive measures among undergraduates and students of Kerala in present study. The similar findings reported in Coughlin SS et al. where he did a mobile app for preventing cancer through educational behavioral intervention found effective. Limitation, the present study was limited to 126 undergraduate students, and the study sample was restricted to only one setting, and long-term follow-up could not be carried out due to time constraint, and tool is valid and applicable to Android phone users only. Recommendation, similar study can be undertaken with a large sample. An experimental study can be carried out with both the control and experimental group. A study can be conducted among medical and paramedical undergraduate students. The mobile app information can be translated into various local languages. The mobile app information on cancer screening and prevention should be updated time to time, and similar study can be conducted on various other diseases also in different settings. These are my reference. Thank you.
Mr. Matthew.
Yes, ma'am.
What was your total question number in your all the you have shown now? You collected in 45 minutes. So what was the total number of questions?
Yes, ma'am. In structured knowledge questionnaire, there was 30 questions, ma'am.
Only? No, you have shown 2, 3, 4, 5, some, no? You have collected data?
Yes, ma'am. In structured in tool 2, ma'am. In practice checklist, in cervical cancer screening, there was 5. And in the breast self-examination, there was 15. And mouth and colorectal, total 10. And in the testicular self-examination, again 10, ma'am.
Means total 70 questions were there, isn't it?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
So means in 45 minutes, there was no like exhaustion to the samples with these questions. Means 70 questions
for males and first few for the females.
Females?
Yes, ma'am. No, ma'am. Actually, there is a difference. The structured knowledge questionnaire is applicable to everyone, ma'am. But the practice checklist, I have given the breast self-examination and cancer screening checklist, breast self-examination checklist, and the colorectal and mouth to the female candidates. And for the male candidates, I have given mouth and lip, colorectal, and the testicular, ma'am.
So
okay,
average,
only 10 question difference, no? 10
yes,
question differences.
Yes,
so
ma'am.
Average it is 50 questions.
Yes, ma'am. Yes, ma'am.
That's what madam is asking.
Ma'am, yeah. They were cooperative only, ma'am.
No, not. It is not cooperative, Matthew. It is
yes, ma'am.
Like then they are not interested in understanding the question. They will just stick it and give you as if it is a burden to them. You're given some assignment and they will just stick and give to you back. That is what we are concerned. But if the number of questions are less, then they think on it. But when they see there are 50, 60 questions, so they hardly, it is done mechanically. So that is what is our experience over the years. So that's why I asked. And in review of literature, you have not mentioned or I have missed?
Ma'am, in review of literature, I have done in 7 main headings. The main first heading is the global burden.
No, did you mention here in the slide?
No, ma'am. No, ma'am.
Because I thought I missed it.
He has not.
Okay. So that is one thing. The third question with me is that CanScreen, what is the content of it? Because I have not seen, so I'm asking you. What is the content?
CanScreen content, mainly the first content is the global burden, burden of the cancer, in which include what is the definition and what is the prevalence of topmost cancer in the India. Thereafter, I have included 5 main headings of each cancer. That is definition of cancer, for example, for a CA breast, definition, causes, risk factor, warning signs, screening techniques, and preventive measures.
So this app is developed by you?
Ma'am, content and content I have made, and I got a help from a app developer, ma'am.
Yeah, that's okay. But this,
content.
It is done by you.
Yes, ma'am.
With the help of a technical person.
As per the guidelines of American Cancer Society as well as National Institute of Cancer Prevention and Research, ma'am.
So it was not available ready-made by these agencies which you are mentioning?
Ma'am, it's not available in the form of app, ma'am.
Okay. So you have made it as an app?
Yes, ma'am. Yes, ma'am.
Okay. And it is readily useful for the people, those who are giving. Now, yes, another thing is that, did you mention in the operational definition what is undergraduate student?
Ma'am, it's
which faculty?
Yes, ma'am. It's mentioned. I have taken, but actually not included in the slides. But I have mentioned, ma'am, undergraduate students who are studying in the art stream, science stream, and commerce stream, ma'am.
Okay. Okay, that was my question. Now my hand over to other panelists.
Thank you, ma'am.
Maya madam, unmute yourself.
I like to know how did you got reliability or validity of your app?
Ma'am, content validation done by the 11 experts, ma'am. Include expert from the oncology sector, medical oncology, radiation oncology, preventive oncology, and surgical oncology. I have also got validation from the oncology nursing from the teaching side as well as the clinical side, ma'am.
So students, they are permitted any time to do further in this study or only that particular time they have done? Did they ask using this app to various family who are suffering with cancer or something?
Yes, ma'am. We can now it's available in the Play Store, ma'am. Now we can.
Sorry.
Okay.
Vasanta, any question?
Thank you, ma'am. Actually, I'm having a little bit doubt because I'm very happy that you're including technology, because I think the technology importance in nursing, I think this 5 months of lockdown period, we were very much aware. So technology usage have you started, and it's very good that something new, advancements is coming in our field also, and our students are becoming techno savvy, which is for the future, it is going to be good. So in that way, I'm appreciating you, but the choosing of the participants, the subjects, I'm little because the scope, when you talk about the scope, I think you could have chosen some other participants, maybe even the community. I think you have many youth clubs are there in the community. You can choose something in the volunteers who will be who can do something, because the contribution, we are all talking most about the contribution, how it is going to contribute to the field, how the significance of the study is going to occur. So in that case, I think that would have been better. And also other thing I just wanted to say, the practice aspect, because practice should be defined properly. Practice is observable. Observational checklist is not possible because it's a knowledge on practice, I suppose. It's not exactly practice, and it is a self-rated checklist what you have used.
Yes,
it was not observational. Yeah. Okay, because observation means you should have observed it.
Yes.
That is my concern. And also another thing that changes has to come into your study, limitation. I am very much worried because it's a sensitive issue, because you are talking about the breast cancer, cervical cancer, testicular cancer. How you have handled that? That is my, I'm very on that. Please answer that. Thank you.
And the area is good. Use of technology, it is coming up. Even Government of India, state governments encourage the use of mobile app. Same what Vasanta was telling. For preventive aspects, preventive cancer, yes, okay,
Yes,
you
ma'am.
have chosen the undergraduate, but if you have widened your sphere, it would have been very useful.
Okay.
And second thing, if you would have made content even for the ASHA and AI. See, ASHA today we should not forget. ASHA is the, like ANM was the basis of our health system, now ASHA. If you would have made for NCD, all the NCDs together, this app will have a tremendous impact, because in the app, it is very easy to update the content, and always follow Government of India guidelines. Please see ICMR guidelines also on the breast cancer. See, American guidelines and other things are okay, but nowadays Government of India is giving almost in all the areas the SOPs, guidelines, protocols. We should first follow those. Then maybe if required, we should go to all these American association and all, because they are not in our Indian context. That is my first thing. Then ASHA ANM preventive aspect, and again, you have on the first day, you have given the pre-test, and the 8th day, you have taken the post-test.
Yes, ma'am. Yes, ma'am.
The gap was very less with the international, and students, young students will remember everything. They are very smart. So that thing you have to take care of.
Yes, ma'am.
Then if you are doing this type of study, I will request parallel, if you add on the objectives, your objective is preventive cancer, preventive aspect. But on the other hand, tomorrow when they go for services, what is the attitude of utilization of services by the community? What are the services available? What are the timing? Are they available to these college students? If you do parallel, then there is an advantage of giving this. Suppose after using this your app assessment, have you found any student was facing actually with the problem, or they could identify some of their symptoms? I don't know, you have not done that.
Yes, ma'am. Yes, ma'am.
So it is better in the early stage if they can recognize their symptoms, and if they can go for the treatment at the early stage. Family is supporting or not, can they afford this cancer treatment or not, then only these things will be effective. Otherwise, what will happen, they will go through the app, and your app should be very interesting, not only text. Put some animations, you can give some links for the videos, make it so. See, young people you are dealing with, they need variety and very interesting content. They will not go through only the text material. Okay, these are some of my observations.
Ma'am, I would like to add, you have mentioned the Ministry of Health guidelines. Ma'am, that's I followed in my app.
Yeah.
And in my app, as you mentioned, I have mentioned very less text content, more videos, as well as figures and tables.
Good. That's good. And go on updating, because the knowledge is changing. Yes, go on updating that. That is important. Yes, and whatever areas about the service, give them the not only knowledge about the cancer, but what are the services available, where they can go, what is the timing, okay, what are the free services. If they have to see, cancer treatment is very costly. If they have already a cancer, from where they can get the treatment, with free treatment, with the support for the finance, what is the family support they will get. So all these things should be part of your app and education.
Surely, ma'am, I will add these parts in my app. I have a provision to add also, ma'am.
Yeah,
surely I will add it.
That's good. Thank you.
Thank you, ma'am. Thank you so much for your valuable suggestions and advices, ma'am.
All the best.
Thank you, ma'am.
All the very best.
Thank you, Matthew sir. Thank you so much. Regarding your app, you have given us so much nice information.
Thank you, sir. Thank you so much.
Thank you. Next, Shobha ma'am, are you ready?
Yes, sir. Good afternoon.
Yeah. Proceed your presentation.
Good afternoon, everyone. It's my privilege to share the platform with such stalwarts. I know virtually we look very near to each other. So before without wasting a lot of time, can I share my screen, sir?
Yes, ma'am.
Okay.
Farooq, which sequence she is? On which sequence number? Because Shobha ma'am, I'm not.
Eighth, I think. No?
8.
Yes, 8 number 8.
Yeah, 8.
Okay, 8.
Is my screen visible, sir?
Yes.
Okay.
SNDT, Mumbai.
According to the, can I start?
Yeah, you can start. You can start.
As we all know, according to the ICMR Bulletin 2001, as per the World Health Organization, around 25% of the world population suffer from some or other mental illness at some point in the life. As per the Indian Psychiatric Guidelines, it is given, and we all know this is what is going on in the present pandemic also, and most of us know many youngsters are also going through this in the present pandemic. And if you see as per the present condition also, many youngsters are mostly affected with this particular neuropsychiatric problem, not only due to, if you see, it is not neuropsychiatric per se, we say it's due to a number of conditions at present, which can be mental also, which can be inborn, which can be not inborn also. The global burden of disease for neuropsychiatric disorder as measured by the laws of Delhi was estimated to be 6.8% worldwide in 1990. Psychiatric disorders account for 5 to 10 leading causes of disability as measured by years lived with the disability. Overall Delhi burden for neuropsychiatric disorder was projected to increase by 15% by the year 2020, and this increase is proportionately larger than by any cardiovascular disease. Nowadays, we tell psychiatric disorder is the third largest disorder in the world. Although most people encounter disease within the family, neighborhood, there is a tendency to show ignorance or actively ignore this fact due to the stigmatization in the society. There's a wrong depiction about mental illness by media and the stigma also associated with it. According to a report in India Today, in the latest, that is 2011, the National Institute of Mental Health and Neurosciences, it was estimated that 2 crore Indians need some or other form of mental health which is required, which furthers that 5 crores suffer from some or other form of mental illness, which is not considered very serious, but it should be looked into. According to the WHO Health Report 2001, every 1 in 4 families is likely to have at least one member with a behavioral or a mental disorder of some form, which can be due to some stress associated in the family or due to some form of a secondary or a primary disorder which runs in the family secondary to some disease condition. Most of them, that is greater than 90%, usually remains untreated because you must be not knowing of it at all. Poor awareness about these symptoms of mental illness, the myths or the stigma related to it, the lack of knowledge on the treatment, availability or the potential benefits of seeking the treatment are the important causes. And that is where the gap has to be taught about, and the treatment or the way we need to seek treatment is what is important. There are many negative attitudes or positive attitudes related to it. There are many misconceptions related to psychiatric disorder. A cross-sectional study was conducted by Mohan C. with a group of authors on undergraduate medical students also related to attitudes towards psychiatry, which was one of the review of literature by the researcher itself also. In a study done by Srivastav, it was a monograph study, which also stated that this stigma leads to negative outcome, which showed that a mental illness was what required people avoided seeking treatment because of the stigmas related to it in the society, because that gave a label of a mad person. Because very clearly it was a qualitative statement which stated that once I tell the people that I'm taking treatment, people term you as mad. So that itself leads to many debilitating treatment symptoms, and people stopped taking the treatment or avoided going to the hospital itself, because the hospital itself puts you into going to a particular unit that shows that you're going to a psychiatry ward or a psychiatry OPD. So that itself was a stigma, and people avoided going or taking the treatment. So that was why I termed it under the heading that is negative attitude. So the researcher decided to take this study, and the statement of the problem was a study to assess the knowledge and the attitude of citizens towards psychiatric disorder in selected areas of Mumbai. The objectives were to find out the knowledge of the citizens with regard to psychiatric disorders, to find out the attitudes of citizens to the psychiatric disorders, to determine the relationship between knowledge and attitudes of citizens towards the psychiatric disorders, to compare the knowledge and attitudes of citizens towards psychiatric disorders with regards to selected demographic variables. The review of literature was grouped under the following headings. That is, studies related to incidence and awareness of psychiatric disorders, studies done on knowledge of psychiatric disorders in citizens, studies on attitude of citizens towards the psychiatric disorders, studies done on effect of certain intervention on knowledge and attitude of citizens on psychiatric disorders, studies on stigma present towards psychiatric disorders, and studies that were compared the knowledge and attitude of psychiatric disorder between different groups of the citizens. This review of literature were taken in the last 15 years. In each, total 15 studies were taken, and then they were grouped, and those were the studies before the actual study was stated. The review was collected, they were summarized, and then the study was further taken. Operational definition. The terms were operationally defined. Now, what was defined was knowledge, the correct response of the citizens regarding psychiatric disorder, which was elicited using a structured interview schedule. Each correct answer was given a score of 1. The percentage of score was arbitrarily graded as follows: that is 0 to 25% poor, 26 to 50% was satisfactory, 51 to 75% was very good, 76 to 100% was excellent. This was after doing the content analysis of the tool. It was given to experts, and based on the statistician analysis, it was graded arbitrarily. Attitude, it refers to the responses of the citizen towards the statement, which is expressed in a 5-point Likert scale. Again, the responses were scored and graded arbitrarily. 20 to 40 were negative, 41 to 60 was neutral, 61 to 80 was positive, 81 to 100 was highly positive. Psychiatric disorder, it was taken as per the Ahuja statement. Citizens were people living in Mumbai and working in different capacities in different organizations, and they were grouped under 6 categories, which we'll see further in the further slides. Assumption, the citizens may have some knowledge about the psychiatric disorder. The citizen may have developed certain attitudes related to the psychiatric disorder. Knowledge may vary from person to person. Attitude towards psychiatric disorder differs from person to person. The conceptual framework was based on the iceberg model, that is pre-survey and post-survey. That is, when you see the line of demarcation, the tip of the iceberg, there is some existing knowledge and attitude regarding psychiatric disorder in the citizen. That is, before there was some knowledge, that is pre-survey, and based on that amount and attitude of the knowledge which is apparent, and the amount of attitude of knowledge that is submerged, post of that, you can give certain knowledge, and then after that, what is the knowledge which is existing, the disease causation, and can you do certain things in the form of health education, in the form of this, and certain studies which can be visible portion, and can you do later certain things based on the post survey, which can be taken up later after the studies. Delimitation, the study is limited only to the groups mentioned. The study is limited only to the tool prepared and validated by the ethical team of the SNDT Women's University. Information is elicited only through single contact with the citizens. The scope of the study before the survey was done was to help students understand how the citizens perceive the psychiatric disorder. It will help to identify areas lacking knowledge in the citizens with regard to the psychiatric disorder. It will help to identify the myths and conceptions regarding the psychiatric disorder. And based on the finding, nursing experts can plan and conduct health education programs to improve the knowledge and attitude in the citizen with regard to the psychiatric disorders. The research methodology which was used was descriptive exploratory. Research design was survey. The settings that were used were schools, colleges, government offices, bus depots, banking sector, and public gardens. Research methodology, the population that was included was teachers from the schools and colleges, bank employees, students from degree colleges, bus drivers and conductors, clerical staff from government sectors, people from selected gardens in Mumbai. Sample were school and college teachers, students, bank employees, bus drivers and conductors, general public and clerical staff from government office who had fulfilled the inclusion criteria. Sample size and technique, 300. 50 samples were selected from each of the 6 groups. Cochrane formula was used to select the sample size. Non-probability convenience sampling was used, and it was put into quota sampling depending on the 50 samples which were taken for each of the quotas. Inclusion criteria, citizens above 18 years of age, citizens who can understand and speak in English, Hindi or Marathi. Exclusion criteria, citizens suffering from any psychiatric disorder. Research design, identification of research problem on the knowledge and awareness of citizens towards psychiatric disorder. Review of literature was done on knowledge and attitude of citizens to psychiatric disorder. Meeting of experts, Exploring the area for conducting the study, development of the research tool was done, ethical consent was taken from the University Ethical Committee, that is SNDT Women's University, obtaining the consent from the selected banks, bus depot, service sector, school, colleges. Validity of the tool was done, reliability of the tool was done, pilot study was conducted. After that, obtaining permission from the head of the various institute, organization, visiting the area, identification of the respondent as per the criteria, that is the inclusion criteria, obtaining the consent from the respondents and interviewing them. After that, analysis of the collected data was done. Then the conclusion and the recommendation, that was what was done. Tools and techniques. First, that was the tool A, that is the structured interview schedule, which included section A, that is the demographic data, section B, that is the questions to be asked in the interview, which included the meaning of the psychiatric certain condition, that were 5 questions, the causes, that were 5, investigation, that is 1, signs and symptoms, that is 5, management, that is 4 questions. In all, there were 20 questions. Tool B was a 5-point, that is attitude scale, Likert scale, 20 statements. The technique for both of that was interviewing, which was used. Validity of the tool was done by giving it to 3 psychiatrists, one from Nair, one from GG, one from KM, all head of the departments, which were given. 7 nursing experts, one from Hinduja, 2 from LPCN, one from CMC Vellore, one from Pune, one from INE, and one from AIM. 2 clinical psychologists, one from JJ, one from St. Xavier. All were selected as per the university guidelines framed by UGC, because SNDT follows UGC guidelines. Translation of the tool to both the languages were done. It was retranslated back to the English language to check whether it is the same tool by the language experts. Reliability of the structured interview schedule was done by Carl Pearson correlation coefficient. It came to 0.7. Likert scale, it was 0.898. So both the tools were reliable, and then it was ready to be used. After that, the pilot study was done. 5 respondents were selected from each of the 6 groups, so total 30 samples. The mean questionnaire, that the interview schedule score was found to be about 9.96. So then it was ready to be used for the actual study. The significant difference was found between the attitude of different groups was P less than 0.05. So the actual study now started. So the data, after the data gathering process, the hypothesis that was framed for both the studies, and then the tool was ready. The research variable here was only knowledge and attitude, as it was a study for a survey. The analysis and interpretation here was deal with the analysis of sample with regard to their demographic data, that is age, gender, religion, education, occupation. So this was the first analytical step. So the distribution of sample according to the age. So you see maximum of the sample was between the age group of 26 to 40, that is 34% of the sample, and 41 to 60 was 35, but that is the age group, mostly the working age group. That was the age group. Maximum working people are the male, so 58% of the sample was in the age group of the male age group, and 42 were the female age group. If you again see, the graduate were, according to the education, 47 were the graduate age group. Illiterate were minimum sample, okay, and 33% were the secondary age group. The analysis of sample with regard to their knowledge, it was seen in the area of the concept what I told you, the 6 areas what I have shown, the 5 areas what I have shown you, that is the meaning, investigation, and all that have clubbed up. That is the 6 groups, that is banking, student, depot, okay, the teachers, clerk, okay. So now when we see in the concept of this, that is the students had the highest knowledge of psychiatric disorder, maybe because they are studying and they're not into Google. So their knowledge is better and the teachers are better. So they are the educated groups. So 78 and 72% is highest. If you actually see the general population, so these are the people who are the bus conductors and all. So they had less population, less knowledge about psychiatric disorder. So they were the bus conductors and those other people. So their knowledge was little bit less. Okay, then comes the 51, that is the bus depot people. Okay. Same way, distribution of sample based on the causes of psychiatric disorder. There again, if we see 51% of the bus depot had poor knowledge, and same way the general people had poor knowledge. If we again see 66%, that is the teachers. Here again the causes, students are again, I think, higher. The clerks had better knowledge here. So the clerks had better knowledge here, 61%. Okay. Now we come to the investigation. Okay, so bank people have highlighted here better knowledge, that is 62%. 57% again the clerks have better knowledge. The depot again have the less knowledge, and that is signs and symptoms of psychiatric disorder. The bus conductors have less knowledge. Then we come to the overall knowledge on. Okay, so here again, if we see 67%, the clerks are scoring better. Okay. Then we come to the attitude, related to attitude towards psychiatric disorder. When we check here, teachers have better attitude towards the psychiatric disorder, and the clerks are showing better attitude. But again, you see here the bus depot employees, the attitude is poor, or the clerks are poor. So again, we see the lower cadre has poor attitude, and the educated have better attitude towards psychiatric disorder. Now, when we come to the analysis of knowledge score between 6 different groups, the comparison between the group, if you see the clerical and the general, the clerical and the depot, so that is what it shows, that there is a marked difference when you see the Z score. Okay, so there is a significant difference between the lower cadre, the student, and the, so that means the students have better knowledge, and the clerical teachers have better knowledge than the lower cadre of the group. So that is what it proves, that this inferred that the bank teachers, students, and the clerical group had better knowledge score than samples from the general and the depot group. That means we require to have a general awareness to a general public, and then the teachers and because as I told you, the education gives you better knowledge than the lower group. So somewhere we need to have health education for the general public to be given regarding the mental awareness things. Okay. Same way, when we talk about the analysis of the attitude score between the 6 different group in relation to this, we again see here, okay, that the F value is again 5.007. So that means we need to see that somewhere the awareness has to be done. It has to be between -1 and +1. So we can see that it's all between 0.3, 0.0, 0.0. So that the attitude, that means it's very poor. The R value always has to be between -1 and +1. So that means the attitude is very poor, and we need to increase the attitude of the general public related to here. Even the teacher's attitude is very poor. Okay, so that means the stigma is there between all of us, and we need to improve the stigma of every person in the society so that the attitude is improved related to psychiatric disorder of the general public. Now, comparison of the knowledge and the attitude score of citizen towards psychiatric disorder in relation to your gender. So there was no, this was also showing significance between the male and female. If you see the T calculated value and the T table value. So the T table value is less than the T calculated value. So there was a significant difference between the male and female. Again, the difference between this. So the calculated value was higher than the table value. So definitely it was a better this. Same way between the F critic value, again you can see that it is the F value was 1.47 than the critic value. So there was no significant difference between here because the F value was lower than the critic value. So it was not showing any major changes between the groups. There were no different changes what was identified when it was related to the age group, what was seen in the difference. Related to educational qualification also, as you see, there was as higher the education, better was the difference between the T value, because the T value is showing calculated value is higher. That means better the education, better is the knowledge of yours, or better is the acceptance of the psychiatric disorder or the stigmatization of your psychiatric risk. So same way related to your educational quality. So the discussion here is the group which had a better knowledge, had a better acceptance towards your, or the stigmatization of your mentally health person. So you had a better acceptance towards it. And that was shown due to some studies done by Chamber and all, in particular certain areas related to mental health problem also. And there were many other studies also which I had done, which is there in the survey and in the review of literature chapters also. All I could not put here because the PPT was becoming very big. So I just stopped it because already there were 45 slides which had increased to my this. So I did not include all the discussion in the particular slides. Okay. So conclusion was there was only a minimal positive relation between knowledge and attitude. The teachers, bank employees, students, and the clerical had better knowledge related to psychiatric disorders compared to the bus drivers, the conductors, or the samples from the general group. So some way, as a nursing group, we need to see that the nurse administrator can plan certain workshops, seminars, where nursing staff can train or have certain sessions for the where we can help out in the form of health education, health this to eradicate the stigma related to the medical illness. We can have community programs related to it. Nursing services itself, staff nurse can help to identify the attitude, the knowledge about this to general public. Okay, the data can be collected to help mental health nurses itself to work in the community to disseminate the knowledge related to psychiatric disorder or to improve the attitude in the right direction. In the nursing education itself, nursing teachers can improve the curriculum because our curriculum itself needs to be have certain changes where we develop in the students itself to improve the myths or change the psychiatric myths and misconception or change total, have certain small booklets being removed where we can have a mass eradication, and nowadays it is required because every second child has some or other mental illness. So can we have a change in the total curriculum and reach out to the society or reach out to the students in general? Nursing colleges can collaborate with community center and have various mental health programs. Okay, and nursing research can be conducted in this particular areas, and we can motivate and have different aspects of mental illness. Now online is there, through online can we have number of things. I know many people are doing many things, but still we can have many more such activities. The limitation of the study was the finding of the study cannot be generalized as the population was very small, though it was 300, but it was done in small groups. So the study sample was small. Recommendation, as I told, brochures can be made, booklets can be made, comparative studies can be done, and it can be done in urban, rural, and different settings. So thank you. With this, I have come to an end of my study. So I just stop sharing. It was, thank you to the jury members.
Respected jury member, please note, Shobha madam was last. Code number was 17.
Yeah. I was searching for that because she was not on 8. Then I saw and I found her on 17. 17. Yeah.
Okay.
Yeah. Yes, I found it.
Okay.
Sorry, I jumped into because I was in the board of study panel and we have our exam. So I just requested him that can I jump into, because I'm in the our exams are going on in the university.
No issues. That adjustment can always be done. Yeah. Shobha ma'am, I have 2 questions to you.
Yes.
One thing is that how much time you took to collect this data? What was the duration?
It took almost 3 months, ma'am, because it was done in different sectors. Okay.
Yeah, that's why I'm asking. And second thing, when these standardized tools are available for this, why you have gone for making your own?
Because first and foremost, standardized tool, I require to take permission from the standardized people. Okay. So that would have taken a long time, and our university prefers that we prepare our own tool also. They're giving a lot of importance to that. Okay, so that is also one of the requirement by our particular.
But ideally,
that is one.
But ideally, it is better to use standardized tool if they are available, because see, you are unnecessarily our energy, time, and everything is going in this. In spite of this, taking a standardized tool and putting some intervention or implications which you have suggested for others in your study
Right.
would have been much more widened your area, because you have taken a very large group. I'm really happy that you have taken a cross section of the society to analyze their or assess their because CAMI is available, community attitude
Yeah, I
towards
know.
mental illness.
I
Knowledge
make
interview is available. Yeah, so
there
it is
in my
better always to use standardized tool and put some intervention, because see, your all this assessment has only helped you to understand what is the attitude of community and what is the knowledge level of community about mental illness, but what they have achieved, isn't it?
Right.
So that intervention part, I think, has to be means taken into consideration, especially in our area of nursing, because we are mostly into the practice field, isn't it?
Right.
Like if someone diagnoses and he just diagnoses and he prescribes medicine, but we are into practice, so always it is expected from us, our fraternity, that we should put some effort to intervene in some problem if it is existing. So that was my thing which I have told to you. That, and second thing is that one sentence you said, attitude can be increased, but I think maybe a slip of tongue, but attitude can be only changed. It cannot be
Yes, attitude can
increased
be
or
changed.
reduced. Okay, that was the
may
two
be
things which I wanted to tell.
Sure.
Yeah, maybe to other jury members. Mine is over in that.
Yeah, thank you so much. It is a very critical area what you have taken. For the base, this is a good study. But I have a one observation with you.
Yes, ma'am.
15 years studies are not at all nowadays accepted. The evidence of the study is 5 years ideally. If studies are not available in that area, then only you can take 10-year studies.
Okay.
So you have to review the current studies,
5
and
years.
lots of studies are available.
Okay.
Lots of material is available with CDC, WHO, even Government of India. So that is my first basic observation with your study.
Okay. Last 5 years.
Yeah. Then you have given the recommendations. I would say you have to improve upon your recommendations, because very important factor is a family again in the psychiatric problem. Family plays very important role. Unless family's attitude is changed, family support is being given, patients are not able to
Very
get
important. Yeah, right. I agree with you.
And India, psychiatric treatment is available in very limited institutions. So you have to see from where these patients will get the treatment.
Right.
Again, stigma is associated. Will they go to these institutions? If you see, even in tuberculosis, till date, people have a stigma. For leprosy, even people have stigma. They prefer to go to a center which is away from their home.
I totally agree with you.
Same thing is with the psychiatric problems in India. Even your family members, I have seen even in the educated families, families do not accept the patient, and patient suffers, and it is a big problem. Then your recommendations can add the training of even your again basic health workers, where Government of India is giving emphasis on ASHA, ANM, and community health officer and a nurse practitioner. Training on life skills, training on stress management, training on your criticism handling or soft skills. These are very important. And again, when you use a term, you said every second child have a mental illness. Please be careful when you give these type of statements. You have, you please do. You have to justify when you give these type of statements in your research study. Then I think you could have studied, you can extend your study, especially what is the role of the media? What is the role of films? You see the way in the serials, films, the media, the psychiatric patients are shown, the way the
Yes.
psychiatric wards are being shown, the psychiatric nurses are being shown. It is pathetic. Actually, that gives a vision to general public. So you have to do some interventions for that. If you find out, that will be very useful for the society. Then my last suggestion is, if someone can do study on mental health services in the prisons, that is a neglected area where hardly anyone do studies in the mental health services and mental health condition of the prisoners. That is my concern.
One of my my student has done study on juvenile delinquents in prison.
Yeah, because that is a very crucial area. Already they are having a background, different background. They are being in the jail, and the type of treatment they get, not only from the public but also from the other
In
people.
fact, one-to-one, I'll share with you the findings of it.
No, it is let her present when she
even next time.
when student. It is when she has done the study.
Right,
She has the right to present. Thank you.
Next time I'll do. Okay.
Thank you, ma'am. Thank you.
It's done.
And, it's a good, very good study, Shobha madam, because as madam told, it is having a very good effect. Even common people also can be affected with this, because as WHO is telling about the definition of health, we all know mental health playing a very important role. It is a very important aspect which can also result into many psychosocial problems. So here, so in that, I am really congratulating you. I just wanted to know, you've taken 6 different groups. It is good because you're concentrating on varied population. But how was your sampling, sample selection technique? What you followed? You just give me the answer on that. And also the implications, curriculum for nursing. As already the curriculum is telling about the myths. We all know about the myths. But as madam, I think Bharti madam was telling, putting into practice. I think curriculum is very good for us. We have a very strengthened curriculum, but we are not putting into practice. So as like always, Neeraja madam will tell about the gaps. That is very important. In all the studies you see in the foreign studies, they are mainly concentrating only on the gaps, and they will want to bridge the gap. So see that you can do something on this aspect, not on the curriculum, because curriculum we cannot decide, and it is already a good curriculum we are also having, and we have experts, psychiatric experts are there in even nursing fields. Also, then madam was talking, no, you can, because these people who are in depots and people who are in like because you told bank teachers, students, they are educated population, they have a good knowledge, and knowledge is also having a very good impact on the attitude. We know very well. So now we have to concentrate only on the general population, and we need to concentrate on the depots and people who are like who are the bus drivers and all that only. So in that case, I think how we can reach them. Maybe the media, the technology, the FM radio, you can also involve in that, and you can plan for a telefilm that can be, because always we can see people only with the mobiles. So if such things are coming, I think that will be very much fine. People will be able to see that. So you can see that you can approach such type of authorities. Because why I'm telling this, in Ethiopia, recently we have done that. Here, common FM audio is there, where they have just projected, and we have just given awareness regarding the mental health. So this type of such things you can, I think that could have been tried. So technology can be used for this type of people, because everybody is having a Android. Everybody is always with this only. So naturally, and hearing some common radio where they can get this out. That is more better. Okay, or pamphlet distribution, all such things you can. But that is, pamphlet is mainly for educated people. If they hear, listening, uneducated people also can get into that. So that is one thing. And just tell me what was the sampling criteria you?
The sampling criteria, what we planned was, because we were thinking, who are the lifeline of Mumbai, lifeline people of Mumbai. So then they are students. Okay, these are the stressful people. Okay, the clerks who are 24 hours in the hospital and doing a lot of stressful job. These are the people, the bank people who are continuously working with.
So what technique you use? What technique you use?
The quota sampling.
Technique, okay.
I mentioned that I took non-probability convenience quota sampling.
I hope you have defined your operational definition of mental illness.
Yeah, I have mentioned, ma'am.
Because these type of people will not have a severe mental illness.
Right,
Maybe it is stress, anxiety.
Yeah,
and
in fact, that each I have mentioned very clearly, there was no mental disorder as such. Those were not part of the study also.
Yeah. And main thing is, I would say in the teaching, if you change the attitude of media,
right,
media can bring in lots of changes. If they give a negative aspect of mental illness, people will have that. So do some studies with the media.
Definitely. Sure. I keep that in mind. And thanks for your suggestion. So, is it done, Maya ma'am?
Maya ma'am, unmute.
Maya
ma'am. All what is in my heart, things have come out, because I too feel that these days people are very much oriented their prosperity and the environment surroundings. We can see people go in depression and die, even getting so much money and all. They want name and status. So such kind of something we develop now as a nurse. We nurses have nothing contributed to India, which can be proved and shown out. So something you people can do from Bombay and other places.
Yeah, your blessings are there, ma'am. So definitely.
God bless you.
Thank you, ma'am. And thank you, because this virtual has brought us so near, and with you stalwarts being, so it was nice interacting with all of you. So thanks a lot. Okay, so I'll move out. Okay, thank you, ma'am.
Binu,
yes,
are you there?
Yes.
Binu, 6 number was missing, I think. He is not there, na? 6 serial as per the list.
Shakuntala.
Yeah.
She will be kind of presenting last. Actually, she needed.
Okay, no issues. I was just confirming it. Yeah.
Next, Manisha madam, be ready.
Yes, sir.
Share your PPT.
Yes, yes, sir.
Manisha madam?
Yes, sir. 2 more minutes. Just connecting.
Okay.
Slide share is connecting.
Yes. Click on the share button.
Yeah, yes, sir. Share.
First click on the share.
Google desktop. अरे मला यायला पाहिजे दिसत नाही कनेक्ट तुझ्या ईमेलवर आहे ह्याच्यावर आहे ते साइन अप वगैरे काय येते अरे ते लोकांचं वेगळं आहे
मैडम पहले शेयर बटन दबाइए।
हाँ
पहले शेयर बटन दबाओ तो हमको पता चल जाएगा आपने दबाया है।
ओके सर, दिस डाउन स्लाइड शेयर लिखा है वो ना?
हाँ वो क्लिक करिए
ना?
बस।
हाँ हाँ
हाँ क्लिक करो।
ओके,
ये आपने क्लिक नहीं किया, नहीं तो हमें दिख जाता।
शेयर तो क्लिक किया सर स्क्रीन।
क्लिक करने के बाद फिर उसके बाद आप जाइए एडवांस्ड में या तो डेस्कटॉप में जहाँ पे भी है आपका।
ओके ओके ओके, शेअर करण्याच्यावरती ऍडव्हान्स मध्ये जाऊन वंदना खंबांचा.
Hello, Binu sir. Binu sir, I will try to share her PPT. Okay.
No, ma'am. Actually, I have made little bit of changes.
जैसे ही आप शेयर दबाएंगे तो स्क्रीन आए।
Binu, let some next person.
Next person. Yeah, sir. No
next
problem.
Person can present rather.
Yeah, sir.
After that.
Yeah, sir. No problem, ma'am. Thank you very much, ma'am.
Jennifer, madam, are you ready? Jennifer, madam.
Good afternoon, sir. Sir, myself Devashruti. Can I present, sir? I am ready.
What is your name?
Devashruti. Serial number 13.
Okay, you can start. Judges, please note the code number.
Yeah, no problem.
Okay, thank you, sir. Thank you, ma'am. I'm sharing my slide.
Okay.
The slide is visible?
Yes.
Hello? Ma'am, slide is visible?
Yeah, make it slideshow.
Yes, ma'am. Is it visible, ma'am?
Yes. Yeah.
Thank you, ma'am. Thank you, ma'am. Good afternoon to all my respected teachers. Myself Devashruti Bhuyan, and my code number is AP23/2020. My research topic is effectiveness of stick bundle for the prevention of IV infiltration rate in the terms of practice among staff nurses working in tertiary care hospital, Bhubaneswar, Odisha. My objectives of the studies are to assess the existing practice level skills of staff nurses about the stick bundle, to assess the post-practice level skills of staff nurses about the stick bundle, to find out the effectiveness of bundle in terms of improvement in post-test level of practice course. Now come to the operational definition. First is effectiveness. In this study, the effectiveness denotes the behavioral or any practical changes observed by the nurses after receiving the protocols by the demonstration on stick bundle. Now, what is stick bundle? That is the full form of stick. S for securement, that means a standardized step-by-step approach to securing the IV. When we put the IV cannula, there are some step-by-step approaches to apply the IV cannula care. Then T for touch, look, and compare. Here we will check the IV cannula side by the touch, look, and compare with the another hand. Then irritants, if any irritants are there which can causes the infiltration of the IV cannula site. Then the catheter size, in case of children, which type and size of IV cannula we will select, and in which site or location we will put the IV cannula. Then K for keep it. That means every day we will review that if there is any necessity that, to keep the IV cannula, otherwise we can remove this. after 3 days, or if there is any sign and symptoms are there. So every day we will check if there is any necessity to keep the IV cannula. Next is the practice. In this study, practice refers to the ability to perform and adapt strict protocol correctly in clinical settings as measured by the checklist. Next, the infiltration. In infiltration, it is the diffusion of or accumulation in a tissue or cell of foreign substances or in amounts in excess of the normal. It will be assessed by the infiltration scale adapted with the permission from Infusion Nurses Society 2006. Next, the hypothesis is there will be significant difference between pre-test and post-test practice score regarding the stick bundle protocol among the staff nurses. Next, conceptual framework. That is the Catherine Kolkaba's comfort design is used in case of my study. So here the main three things are healthcare needs, nursing intervention, and intervening variables. First, when we will give the care, first we will check the healthcare needs. What is the healthcare need in case of my study? That is the prevention in IV infiltration among the hospitalized children. Then the nursing intervention. In case of my study, the intervention is or practice which a registered nurse should perform to prevent the IV infiltration, that is the stick bundle. And then the intervening variables, there are mainly 3 types of variables, that is independent variable, dependent variable, and demographic variable. After collecting that all data, then we will check for the enhanced comfort. Either the participants are showing they are ready to perform this procedure and adapt the existing IV infiltration prevention protocol to improve their Madam, it is not safe. Hello?
Not visible, not visible.
My screen is not on.
You can unshare and share again. Unshare it and share again. Unshare your screen, then come back and share.
Ma'am, now it is visible?
No.
No. You have to close that, I think so. Close
First,
those.
you have to close it, unshare it first. Then you come again, share it. Yes, now it is visible.
Okay. Thank you. Now, after the enhanced comfort, then we will check for the health checking behavior that for the protocols of the stick bundle that is follow in their daily routine or daily practices. After that, we have to need the institutional integrity, because in one ward or one part of the hospital, we cannot do that things or allow any protocol, any protocol. So all the institutional integrity and all the co-workers need to integrally work for this prevention, the IV infiltration, and to allow the new protocol. After that, we will check every day good practice and bad practice. If good practice, then okay, we will follow that, and if it is bad practice, then we will for the feedback, and then from the first stage we will continue that thing. Next, the research methodology. In research approach, that is mainly the quantitative research approach. Then the research design, that is pre-experimental, one group pre-test post-test design. Here the staff nurses is the only group who are working in the pediatric unit, that is Kalinga Institute of Medical Sciences, Bhubaneswar. Next, the variables, the dependent variables in the study. The dependent variable is the level of practice of staff nurses regarding prevention of IV infiltration. An independent variable in this study, the independent variable is stick bundle protocol to prevent the IV infiltration rate. And the demographic variables are mainly the age, religion, educational qualification of staff nurses, total years of clinical experience in pediatric, source of knowledge, attend any continuing nursing education program on IV infiltration. Next is the research setting. The research study was conducted at Kalinga Institute Pediatric Ward of Kalinga Institute of Medical Sciences, Bhubaneswar. Next, the population, that is target population, that staff nurses of pediatric unit in KIMS, Bhubaneswar. And the accessible population are the staff nurses in pediatric unit KIMS, Bhubaneswar, who will present at the time of the data collection. Then the sample size. In this study, the sample consists of 30 staff nurses who met the inclusion criteria, as there was only one review of literature. So the calculation of the sample size was not possible. So according to feasibility of my setting, I took the 30 staff nurses. Next, the sampling technique. In the study, consecutive sampling technique, that is non-probability sampling technique, has been used for selecting the sample. Next, the sampling criteria. Inclusion criteria: staff nurses who are willing to participate in the study, staff nurses who are present during the study, those who have licensed or registered to work as a staff, that is GNM, BSc Nursing and Post-Basic BSc Nursing. And exclusion criteria are staff nurses who are on supervisory duty and staff nurses who are absent during the time of data collection. Next, the description of the tool. In the socio-demographic data, there are the 7 criteria: age, religion, educational qualification of staff nurses, total years of clinical experience, year of clinical experience in pediatric, source of knowledge, and attend any continuing nursing education program on IV infiltration. And in case in the section B, the questionnaire was, there are structured questionnaire checklist. There was 24 points on practice aspect of stick bundle. The questions are divided into the different parts, which are securing IV cannula, touch, loop, compare, irritants, and catheter selection, and keep it. Next, score interpretation. There are total 24 question and score was 24. Each correct answer 1 and wrong answer 0. Then the score keys are divided into 16 to 24 marks, that is good level of practice, 8 to 16 average, and 0 to 8 poor. And it is validated by 7 validators. Then the reliability, in case of pilot study, I took the 5 staff nurses in another setting, and test retest method was used, and R is equal to 0.82, which was reliable. Then the data collection procedure, first permission was taken from the nursing supervisor in the pediatric unit, KIMS Bhubaneswar. Then data collection period was 5th April to 20th April. That was only 15 days, and researcher met each staff nurses and explained the purpose of the study. Then consecutive sampling technique was used to collect the sample subject. Then informed consent was taken from the sample, and the questionnaire on demographic profile were given, and practice was assessed according to checklist. After taking the pre-test, demonstration was given to the staff nurses about the stick bundle, and after 3 days of giving demonstration, post-test was assessed according to the checklist. All the staff nurses and sample respondents cooperated well. Respondents cooperated well with the investigator during the data collection. Then analysis and interpretation. First, that is the age. Here, the 60% person was, the age group was 21 to 25 years, and 26 to 30 years was 40%, and no one including the 31 to 35 years and above 35 years. Next, in case of religion, all the samples came from the Hinduism, no Muslim was there. Next, the qualification all from the GNM, that is 100% in the GNM qualification. Next, the total year of clinical experience, where the maximum clinical experience were 1 to 5 years, that is 70%, and 30% was less than 1 year. And no one is included in the 6 to 10 years and greater than 10 years. Then the total year of clinical experience in pediatric. That was for a maximum was 1 to 5 years, that is 53.3%, and less than 1 year was 46.7%. Then the source of knowledge, maximum samples were collected their knowledge from the teachers, that is 56.7%, and the others are 43.3% from the nursing journal. And the maximum samples, that is 60%, did not attended previously any kind of CNE program about the IV infiltration, and 40% attended CNE program about the IV infiltration. Now the frequency percentage distribution in case of pre-test practice level. Here from the graph and pie diagram, we can see that maximum, that is 67% in case of pre-test, there was average knowledge about the IV infiltration or stick bundle, and 30% was good, and only 3% or 1% was there in the poor knowledge. And in case of post-test practice, they are about 66.7%. That means maximum was good knowledge, and 33.3% was rest are the average practice, but no one in the poor practice. Then the effectiveness from this diagram, we can see that in the dark color is the pre-test and post-test is the light color. So 67% is the in case of post-test, that is the good practice, that is higher than the pre-test. So the in the post-test, the knowledge was increased than the pre-test. And in case of pre-test, the descriptive statistics was mean was 15.4 and median was 15. And standard deviation was 2.317. In case of post-test, mean was 16.7, 18, and median was 18, and the standard deviation was 3.21. And I check the effectiveness by the paired t-test, and t-test value was 2.16. The when the degree of freedom was 29, and the p-value was less than 0.05. So we can come to the conclusion or major findings. Maximum in case of demographic, maximum subjects 60% was 21 to 25 years, and maximum 70% was the total years of clinical experience 1 to 5 years, and 53.3% were having the total year of clinical experience in pediatric 1 to 5 years. And highest score of knowledge was teacher 56.7%, and no maximum subject, that is 60%, have not attended any program on IV infiltration. So in my second objective, that among the 30 subjects, majority, that is 66.7%, have had the average practice, and 9, that is 30%, had good practice, and only 3.3%, that is one subject, had poor practice. And at that time, the mean was 15.5 and median was 15. In the second objective, the that means the post practice level, among the 30 subject, majority, that is 66.7%, had the good practice, and 33.3% had the average practice, and no one had the poor practice. And at that time, the mean was 16.7, median was 18. So in case of third objective, analysis of mean practice score is apparently higher in the post group in the comparison to the pre-test group. The paired t value is found 2.816 at the degree of freedom 29, but the p is less than 0.05. So this indicates that there is statistically significant difference between the practice scores in the post-test and pre-test group. Research, so we can accept the research hypothesis at 5% level of significance, and can be inferred that there is significant difference between the pre-test and post-test practice level regarding the stick bundle for prevention of IV infiltration. Now, the implication in case of nursing education, we can use the new protocol. We can teach the students about the new protocol to prevent the IV infiltration. And in case of nursing practice, not only in the pediatric unit, we can use this protocol in the whole hospital, and in case of every hospitalized patient. Nursing administration, without the nursing administration's permission, we cannot allow or start this protocol. In case of nursing research, we can develop the new protocol by this way. Then the recommendation, the study can be replicated on a large number of samples to draw the generalization. A comparative study may be conducted to find out the effectiveness between the existing protocol on prevention of IV infiltration and stick bundle for prevention of IV infiltration. A similar study can be replicated with random sampling technique. Then similar study can be conducted on all the staff nurses of a tertiary care hospital. Similar type of study could be conducted on the staff nurses on the other aspects like knowledge, attitude, compliances, etc. In limitation, as observation checklist was used, So for the data collection, it may be restrict the amount of information that can be obtained from the respondents. Small number of subject and the study was restricted to one setting. Hence, the generalization is limited to the group of 30. And the study was limited to the staff nurses who are already working in the pediatric ward setting. So these all are the about my study. Now open discussion, madam and sir, please.
Can unshare your screen now?
Okay, ma'am. Yes, madam.
You have done a very good effort, and you are trying to bring in some procedure which can be implemented by your hospital, I think. That is your basic thing?
Yes.
So
Sorry,
it was only 30 staff nurses you have done this study?
Yes, ma'am. Because in our setting, there was only 40 staff nurses in my setting, and the data collection time period was only 15 days. So it was not possible.
Okay. Then you cannot generalize the findings of this study. This you can take it just as a pilot. Okay.
Yes,
so,
madam.
And the second thing is you can do in some other hospitals where you can do randomized trial in 2 different hospitals. You can take if you get the permission. And what was the, how you was doing observation for the practice? What was your procedure?
Madam, during the in the morning, evening, night, I was there, and whenever they are giving the IV infiltration care, I just tick the checklist, and checklist was to me only.
So only you were going and observing, or you have trained some more nurses to observe?
So myself only.
So in one day, you were also doing your job also. So in a one day, how many nurses you were able to observe?
Madam, in every shift there was only 2 or 3.
Okay.
In one shift I will check that 2 or 3. Then next shift I went and checked. In one time only I checked. Yes.
It was feasible for you to check. Suppose they are doing simultaneously the procedure or something. How you were able to manage your time?
Only one time I check in one shift.
Yeah. Okay.
And they are doing they are doing so many times, but I checked only one time.
Okay.
In one shift.
Okay. So you yourself were trained in this procedure?
Yes, ma'am.
Demonstration
is given by me. Yes, ma'am.
No. You are certified by someone for this procedure?
No, ma'am. This is the this procedure is already taken from the review of literature. Only one review of literature was there.
No, 1 minute. It is very important. First, you should be certified. You should have you yourself should have TOT. Unless you have yourself certified, how you can train others. Okay, that question will not come. And when you are training others, you have to ensure when they have competencies are being obtained by them, they should also get certificates so that they can practice this procedure. So this is a proper procedure for them to do. Okay.
Yes, madam. Yes,
so
madam.
only these things were my observations. Rest other members can tell you.
Thank you.
Yeah.
Thank you.
Debashruti, I have one question to you that you did your post test just after 3 days, no?
Yes, madam. Yes, ma'am. After 3 days. After 3 days.
But I think other panelists will also agree to me that that is a very short period
Yes,
that
madam.
we are doing. Yes, no? Only 3 days.
Yes,
after 3 days she did.
Yeah,
so this is what happens. The recent memory is so good that we don't forget. We, as soon as you give them the checklist, they will just do tick, 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 and they will do also. So I think some time should be given to go to that knowledge or practice to remote memory.
She has
and then it has to be.
Yeah, madam, what she can do is she can do after 1 month, 3 months, 6 months. Same
follow up like
That is important for her.
That is what is my observation. And second thing is that when we write religion, if you got only one religion 100%, you have to just write that other religion, they were not there. You have mentioned, na, like Muslim or some Sikh, like you don't have to. No? You do, no other religion, na? No other religion. Okay?
Yes, madam. Yes.
Because there may be Christians also in your community, there may be others. So no need to mention one particular religion. You can write no other religion people were there, or it was 100% Hindus.
Madam,
Okay?
okay.
Yeah,
Yes,
that is
madam.
there. So post test, and this was my this thing. And I think you have excluded the supervisory staff. But I think they should be trained, because they are on supervision. So not only for study, but when they are going on supervisory rounds,
yes, madam,
they will be for.
Right.
So maybe a separate group, but once you are certified and trained, you should not exclude the supervisory staff, because they are the ones, those who have some power also to implement something, isn't it? So that is what I feel, and I hope Madam will agree with this. Supervisory staff should also be trained. Then only their eyes can see what the staffs are doing wrong or right.
And then only they will support also. Then only
they will do. And second thing, they will validate, and if it is not there, they can check them. And after that, they will do the corrections and all. Okay, so I had these many points only. And sample size, Madam has already told. And review of literature, you said only one study you got. So need to explore some areas in some other places. Or very less.
Yes, you have to
explore. Very less review of literature, which does not give you much views about these things, that whether it is right, wrong, or what are the views of people. So these are the three areas where I want you to improve.
You can see some related studies. Okay.
Related study. Yeah. Not only this, but you can see related studies about IV infusion or care of the IV infusion site.
Yes,
like
madam,
that you can put, and that mine is over now. Madam Maya madam and Vasanta ma'am will talk.
I would like to add to it just a little bit also, that related studies also in that. Whether you have considered the sterilization of the procedure and the trace complete setup was there in hospital facility was there, beta?
No, madam, actually, whatever was needed, I prepared that. That was not prepared by the hospital. I prepared everything. Whatever was needed, I prepared.
That is why Sood madam has also said you should be certified with that procedures, because now those nurses are not going to work only in your hospital. They may go and work America also.
Yes,
so
madam,
take care of these things.
Yes, right, madam. Right. Yes. Thank you, madam.
Shruti, and I think it's a very good intervention, nursing intervention, our field. So I'm appreciating you in this regard. And one question is like reliability. Don't go for test to retest. I think you have to go with the interrater reliability, because it's observation and the practice observation. So always go with
observation.
So you have to correct that. And 40% people have attended the CNE. That's what you have told. It had any effect on your study? 40% have attended CNE on this infiltration. I just wanted to know about that. Okay. And also as madam all told, no, if you have taken the proper certification, everything, I think future you can try that. If you complete everything, and then you can just include this particular protocol into your hospital policy. So that will be better. And only I think the implementation could, your study will have.
Yes, madam. Certification was needed, madam. Yes, this is the.
And in which you have done in which ward in your hospital?
Madam, pediatric ward.
Pediatric. So you should include HOD pediatric also, so that they can allow you to practice this. Okay.
Yes, very much.
Thank you.
Thank you so much, madam. Thank you for your valuable comments.
All the best.
Thank you, madam. I'm leaving, madam.
All the very best.
Yeah, sure.
Thank you.
Next, be ready. Next, Shanta madam.
Yes, sir.
You can start sharing the screen.
Okay. Good afternoon. to all.
What is the sequence?
I think 11 number. Shanta?
No, 15.
15.
You are
number.
15.
15 is
serial
Jennifer.
number
Yeah,
15, but it is 11th number.
15 is Jennifer, na? Your name is in 11th.
No, ma'am, 11th mine.
11th. Shanta.
Okay.
Visible?
Yes.
Yes, I got it.
Visible, ma'am?
Shanta Chaudhary, no? You are?
Yeah, ma'am. Ma'am, screen is visible?
No.
Yes. No, I got it. I have.
No, it is not visible to us.
On my screen?
Shanta,
Yeah.
ma'am, please share your screen.
Ma'am, sir, I share. It's
Now
not
you close that. If you have shared, you close it, and again you press the share button, and then you share.
okay. Now it's visible?
No, madam.
It is not visible. First you stop sharing, then you again share your screen.
I done again.
Yeah. Otherwise, you join again. Sometimes due to network, you have to join again. Try to join again.
Okay.
Share your screen.
Okay, ma'am.
And you can put up your video if your internet is slow. You can just show your presentation and speak.
Shanta, madam?
Yeah, sir. Now?
Yes, now it's coming.
Okay. Now visible?
Make it full screen.
Okay. So good afternoon to all. Myself Santa Chaudhary from Sri Krishna Institute of Nursing, Babar, Gujarat State. Here I am presenting my research.
But
My statement was
it is not
Sorry,
visible.
Shanta, madam, sorry. Your PPT is not visible.
Yeah, it is not visible, your PPT.
Please share it.
not
आप share button दबाइए. First you press the share button.
now.
Yes, it is coming. Yes.
Now okay.
No, it has not come yet.
Is visible?
You double click it. See? Double click.
Not visible.
Madam, it's very Oh, it is coming.
Hope your internet is not very slow.
शांता मैडम आपका बाद में
Okay. So your internet connectivity is good.
शांता मैडम आप थोड़ी देर बाद में कर लीजिए.
So next person can first present. She can
Manisha
come
madam,
after that.
Manisha madam, are you ready?
Manisha is
Yes,
is
sir.
13. Manisha is 13.
Yes, madam. She has lost some connection. Now she has rejoined.
Manisha is 9 or Manisha is 9 number.
9 number.
Manisha is
9 number.
9.
Yes.
Okay.
शांता मैडम आपका क्लोज कर दो. मनीषा मैडम अभी आप चालू करिए.
Yeah, okay, sir. It is visible, sir.
Yes, it is coming.
Okay.
Now make it full screen.
Yeah, sir. Yes, sir.
Slide show.
Yes, sir. Yes, sir.
Madam, down to 7. Okay.
आ रहा है ना सर?
Okay, you can start.
Okay. Good afternoon, everyone. Good afternoon, jury member. I, Manisha Ravade from Bombay Hospital College of Nursing, would like to do my paper presentation on effect of structured teaching program on knowledge regarding organ donation among staff nurses of selected hospital of metropolitan city. My number is 19. Okay, so it is just one quote. Don't take your organs to heaven with you. Heaven knows we need them here. I will be, in my slides, I will be dealing with the introduction, problem statement, objective, operational definition, hypothesis, conceptual framework, review of literature, methodology, analysis and interpretation, recommended, and references. So just to begin with, organ donation and transplant is an important aspect of treatment of chronic organ failure in today's era of medicine. But availability of organ donation is still a major problem all over the world. India's organ donation rate is only 0.30% per million population when compared with organ donation rate of other countries like Spain, whose rate is 36 per million of population. I mean, almost all of the world, the rate is below the 36. That's why I've taken the Spain is having the highest rate of 36. So that's why I've taken only of the 36. To be frank, all of the countries are having less organ donation rate. As a health team member, nurses also has a major role to encourage people for organ donation, provided they are having adequate knowledge regarding organ donation and brain death. As found in previous studies, hospital staff are having average knowledge regarding organ donation and poor knowledge about brain death. So to begin with the problem stated, effect of structured teaching program on knowledge regarding organ donation among staff nurses of select hospital of metropolitan city. My objective was to assess the knowledge of the staff nurses regarding organ donation before and after teaching program, to compare the effectiveness of teaching program on knowledge regarding organ donation among the staff nurses. So operational definition, I actually had operationalized, only have written the operational definition of the teaching program. So in this study, it refers to the program which is important, which impart the knowledge regarding organ donation, which include meaning of organ donation, purpose of organ donation, the eligible criteria for organ donor, differentiate between deceased donor and the live donor, donor maintenance and its importance, the retrieval process, legal and ethical issues related to organ donation, details of brain death and psychological aspect, that is grief counseling of relative, the delimitation of study. The study was limited to response given by samples and study was limited to the sample from selected hospitals. So hypothesis, null hypothesis, there will be no significant change in knowledge score regarding organ donation among staff nurses after teaching program. And the research hypothesis stated there will be a significant change in knowledge score regarding organ donation among the staff nurses after teaching program. The conceptual framework, I have my conceptual framework based on the Pavlov's theory. So along with other 4 paradigms, the concept of Pavlov theory was perception, identification, communication, orientation, exploitation, and the resolution. So it goes like that. So research, being a researcher, has feel that the nurses, staff nurses who are working in the clinical area, they are having average knowledge or regarding the organ donation. Even the staff nurses regarding, they are having a poor knowledge regarding the organ donation. So orientation, so researcher will think about getting oriented with the what are the problems for the poor knowledge among the staff nurses. They will communicate the staff nurses regarding the poor knowledge. Then we have the identification, request for structured teaching regarding organ donation. Then exploitation, together we will be having knowledge with the help of teaching program regarding organ donation. Then the self registration by the nurses. And the resolution will be at the end, the staff nurses will have had a received knowledge, it's still having doubt, not sure, or will decide herself. So positive will be they will be having adequate knowledge, and in that also we had kept the form for the organ to be filled as the organ donor. If they are coming forward to be a donor, then we have to fill that form. If negative, then feedback, again go back and percept and identifying what are the problems are there. So review of literature, mostly the review of literature was done, studies related to knowledge regarding organ donation, effectiveness of teaching or program on the knowledge about the organ donation. So methodology, research approach was done on the descriptive evaluatory approach. Research design was one group, pre-test, post-test design. That is 001 stands for pre-test, extra plan teaching, 002 is post-test. The population was staff nurses. The sample was 100 staff nurses from my own hospital. The sampling technique was non-probability purposive sampling. The technique and tool was TEL-administered semi-structured questionnaire. Then the data collection procedure was done. Written consent were taken from the participants. Data collection was carried out from 15 January 2020 to 25th January 2020. Analysis and interpretation, and only few things which was related and important to be over here I had included in that. So regarding the sample size, we all know we have GNM, BSc and MSc working at the clinical. So accordingly, in among the 100, there were 62 samples were there who had completed their GNM nursing and working at the clinical side. The 34 samples were who had completed their BSc and 4 samples were MSc. So in a demographic data, I have also other questionnaire like whether anyone was having organ donation or history of organ donation in the family, anyone had donated organ in the family, and along with the other demographic like gender and all. The one more important thing was their distribution of samples as per plan for organ donation in future. So in conceptual framework, I said that we wanted to see that whether they are coming forward to be a donor in future. For that reason, we have this particular demographic data was there. So in that we had whether future plan, yes, no, not sure, not yet decided. The 70% said yes, they may would like to donate organ in future. 8 said no. 8 was not sure, and 14 said they not yet decided. So assessment of overall knowledge level. So poor knowledge range was given 6 to 10, good was 10 to 15, and excellent was 16 to 20. So there was 20 question in my questionnaire, and regarding that, so the classification was made. So pre-test 8% has a poor knowledge, 56% was good, and 36% was excellent. So post-test 36% was good, and the excellent was the 64%. The significance between pre-test and post-test knowledge score among the staff nurses regarding organ donation. So the mean pre-test was 13.37, the post-test was 16.90, SDU value 2.301, and in post-test it was 1.518, and the T value was 29.13 at the 0.05 level. So table value for T at degree from degree of freedom 99 at 0.05 level is 1.960, and calculated for it is 29 for 13, which is more than the table value. So therefore H0, we said that there will be no significant difference in knowledge scores of staff nurses after receiving teaching regarding organ donation was rejected, and H1 is accepted. The teaching given on organ donation was effective for changing the knowledge of staff nurses. So there was a significant, just to discuss the thing, there was significant difference between pre-test and post-test of mean and T value about knowledge regarding organ donation among the staff nurses. So same study was carried out, that is Indian study by Vipin Kaushal, Atul Kumari and Dipanjan Bhattacharya, to evaluate the knowledge regarding organ donation in nursing professional, and they also found the same. Then even the abroad study was carried out by Vinisa Vargas and Miriam Sanchez regarding perception of nurse in the process of donation of organs and fabrics of transplantation. So future scope, the nurses has major role to play in organ donation and transplantation. Nurses are involved in organ procurement unit as they are more close to the patient and the family. The nurse's role is also important in maintaining the viability of all vital organs in case of a potential donors by providing complex care to the recipient in intensive care unit. As the movement of organ donation is growing in country, so the nurses needs to keep their knowledge about organ donation to match with it. Recommendation: similar study can be carried out for a large number of staff nurses. Regular in-service programs should be carried out for the staff nurses. These are the references. Before I end, I have not written anything about the acknowledgement. I am acknowledging the team which have helped me for the structure teaching. They were the nephrologists, urologists, and the organ donation coordinator who helped me for the structure teaching. So now I am acknowledge them for their help in the structure teaching. Thank you very much.
Please stop sharing your screen.
Yes, ma'am.
Your area is an excellent area, which even Government of India is giving importance. By my, I would like to know what were your components regarding knowledge. What all things you have tested out?
Ma'am, actually in operational definition I said regarding the meaning, how I mean the organ, what is meant by organ donation.
Yeah, she has given detail.
Okay. Okay. Sorry, I
no, I'll repeat, ma'am. There is no issue.
Repeat.
Yeah.
Okay, ma'am. There is a what is meant by organ donation. How is the procurement of organ donation has to be done. Then, especially legal aspects nowadays, because more and more people are worried about the fraud and scam.
That's enough.
And ma'am,
my question was related to my main concern is nurses are never involved in the district and state level decision-making committees for the organ transplantation, organ and rather I should say, you should say organ and tissue transplantation, rather than only organ transplantation.
Okay.
They are never being a part of a state or a district level committees in the policy making. That is my biggest issue. There is a lots of corruption and malpractices are going on in the organ transplant. Just giving them the knowledge, I don't know how much it will be effective. When they are not policy makers, when they are not doing anything in the hospital, in the planning or the policy making, only they are taking care of the whatever they may be posted in that when it is being procured, or they may be in the OT, or maybe somewhere they may be posted. They are not being actually involved in any of the policy making issues, nowhere. So that is my concern. Second thing is, why only knowledge you have taken? Why not the attitude? In this type of studies, attitude is much more important rather than the knowledge. If they have a positive attitude, then only they will able to donate it. See, when you have to donate it, there are family issues, there are religion issues, there are social issues. So many, if suppose someone has filled the form also, there are families which after their death do not want to donate the parts. And that is why organ donation, tissue donation is the biggest issue all over the world. Even body donation for the forensic department in our medical colleges is a big issue. So these are the concerns which will come not only with the knowledge, but change in the attitude of the person and their family and the community as a large. That is my concern. Then have you added the Transplantation Human Organ Act knowledge in your tool?
Sorry, ma'am?
Have you added the components of Transplantation of Human Organ Act in your knowledge test?
No, or Human Organ H.
Act of India.
Yes, ma'am. Yes, ma'am. Act was there. That THO Act was there, ma'am.
Because there are many issues, nurses should not only know about their knowledge, but they should know if there is any helpline. What is the system of getting registered? It is offline or online, whom to approach in the hospital if someone wants to do. They have, the person who donates have to take a pledge. What is a pledge? So have your nurses taken the pledge in case they, how many nurses after your knowledge test have actually filled up the form? Have you done that?
70. So yeah, I had given the
taken the pledge? Have they taken the pledge?
Pledge is not taken.
Yes, that is important. So all these things, when you do these type of studies, you should know what are the basic components and you fulfill those components.
Okay.
When they have filled up the form, have they taken the consent of their families?
Actually, ma'am, in few of them had taken the consent of their family, because in that column is there about the consent of the family. I mean, not only because they are adult enough. It is
no. See, it is not a question of adult enough. This, when the organ donation is done, when person is no more.
Yes, ma'am.
So, what then the role of family comes?
Yes, ma'am.
That is very important. It is not a question of adult or not.
Ma'am, we have an organ procurement center in Bombay Hospital, and we have the MSW person who is counseling and all. So 35, I am not sure, 30% at least have taken the consent, but rest all are not taken the consent of their family.
Yeah, the India issue is many people fill up the consent, but after their death, the family members do not do that. Okay.
Yes, ma'am. Yes,
ma'am. That is my concern. So
yes,
that attitude needs to be changed.
Yes, ma'am.
Okay.
Actually, ma'am, 1 second, I can talk.
Yeah.
Ma'am, actually, I was thinking about the attitude also.
Yeah.
But I have done the study for the patients relative who are on dialysis. Okay, for them I have taken the attitude. So whatever question I had included in that attitude scale was very commonly similar to the knowledge-wise things. That's why I'm not included in
attitude will become different. Attitude is you have to change. It is altogether a different thing.
Yes, ma'am. Yes, ma'am. So I thought there will be not much.
I will leave to the other part. Only my last question is structured teaching validity. How you have done?
Ma'am, actually, the structure teaching, my nephrologist, urologist, it was not only a 30-minute session or something. We had a 20-minute session for the 4 people had conducted that. Okay, the structure teaching, actual structure teaching was conducted 20 minute session, like how we develop the staff development program. So that way we have arranged. The main idea of having the staff nurses included in, I mean, to have a this type of teaching is when I was doing for the dialysis patient, I had come across doctors telling that nurses also having poor knowledge. So I was very reluctant to do for them. But when I have done pre-pilot study like thing, I have found that they were not aware about the law, the authority committee, the brain death certification, where we are working in ICU. Plus the counselor also said that when he go for the counseling of brain death, he finding is very difficult because he is the new person to the relative of that particular patient. But if the staff nurses are doing it regularly, it will be a benefit. So
Okay,
little bit of
yeah. It's one thing more I would like to say. Please involve the nurse administrators also in these type of studies. All the studies we do on staff nurses, they are not at all decision makers in anything.
Ma'am, that MSc, ma'am, that we
one thing, listen to me. It is your study today. You have trained them, but they can further make they can take you can say they can educate the patients and their families also, no?
Yes,
Afterwards.
Yes, ma'am.
But
Yes,
at the hospital level, if someone has to take decision on anything, it is very important. You cannot say all the nursing superintendents, all the doctors, everyone is aware of the this one organ transplant. Only staff nurses are not aware of. So this is very important thing that we should take care of the administration also. What is their knowledge? What is their
I said the four MSc person was there now. Among them was one was a matron also.
So
okay, we have the categories like assistant, matron. So the MSc person was there.
Have the power to take decision. Then my question will be this: how many attendants have the power to make decisions? So you should have decision makers also in your study.
Yes,
That's all. I will finish up here. Yeah.
Okay, ma'am. Thank you.
Manisha, I have one question.
Yes,
you have mentioned in your need of the study that there is poor knowledge of staff nurses on organ donation.
Yes, ma'am.
One statement is there. You can check later on.
Okay.
So, is there any reference like that? Because now you are telling that when I saw the doctors and these people, they don't know anything about this organ donation. So, this statement need of the study that poor knowledge of staff nurses on organ donation. So always put a reference.
Okay, ma'am. Okay, ma'am.
It becomes subjective. It becomes subjective, and people may not like.
Yes.
Okay. Always write that in a particular study it was found, like that. If you write reference, people will not say anything.
Okay, ma'am.
But you cannot make a generalized statement. Okay.
Okay, ma'am.
That is what I want. And you did in the same hospital where you are working.
Yes, ma'am.
Okay. That is it, but it is actually much required topic for in today's scenario. Okay, that is what was my query, and other madam has already asked to you, and include everyone as she has said. I agree with her. Even the administrator, those who have power to make decisions. Okay.
Actually,
collaborative also we can do. Collaborative we can do because there are all team members are involved in this, no, organ donation. Starting if the surgeons are there, a neurologist is there, everybody is involved, isn't it?
Yes, ma'am. Yeah, yes, ma'am.
Legal fraternity is there. So if you do a collaborative study, everybody will help because they know their name will come in this study. Okay, and they will be given due credit for this study. So whenever you do a study, you involve more people.
Yes, ma'am.
Okay, 5 people, 6 people. So you can write their name also, and at the same time, they get credit and they will cooperate also.
Yes, ma'am. Yes, ma'am.
And you have to make them aware about the non-ethical issues. Means the malpractices which are being. You must have heard about the Apollo Hospital in the newspaper 2 years
we
back.
Also have in Mumbai. In Mumbai also we have Hiranandani Hospital.
And all that.
Yes, ma'am.
Yeah, it is very important to educate them, even the public. You have to educate all these things.
Yes, ma'am.
Maya madam, Vasanta. Vasanta ma'am.
I'm not able to see her.
Yeah, I'm not able to see, but Maya madam.
She is also, I
Maybe
think.
ma'am, technical problem.
Yeah,
They are.
they were in between.
Okay,
they
maybe. So then we shall proceed further then.
Ma'am, whether we can go for 10 minutes break or we can proceed further also?
It is up to you as an
After that, we
organizer.
can have a break.
After this, okay,
Yeah,
ma'am.
yes.
We can have one.
I'm there, madam. By my, I had a prayer, but now I'm in the mobile. Madam, I just wanted to ask her only one thing. Why she has gone for, why Manisha madam, why you have gone for, madam? Madam, are you?
No, you are not audible, Vasanta. Vasanta is speaking.
Your voice is breaking.
Yeah, your voice is breaking. No, some disturbance is there. Some disturbance is there.
Put off your video, then you ask. Put off your video if network issue is there. Put off your video.
Yeah, I'm there, madam. I'm there. I just came. I'm in mobile, madam. Are you able to get it?
Yeah, little bit clear it is. You can ask if she can understand your question.
Yes.
Yeah, you can ask her. She's there.
Manisha, can you listen? Hear me?
Yeah, my disturbance is there,
Manisha?
but I can. Yes, ma'am, I can.
Manisha, madam?
Yes, ma'am, I can.
With some issues.
Or you can write in the chat box. You can write in the chat box. You can read the question.
Okay, madam. Madam, are you able to listen to me?
Yes, ma'am.
My voice is
Yes,
there?
yes. Please ask your question.
Yes, we are able to, but some disturbance is there.
Okay. Manisha, okay, take your time. And it was a good presentation. I think the inputs are already given by madam, both the madam.
Yes, ma'am.
Okay, ma'am. Ma'am, I'll just ask her. What is you just tell me why you've done on one group. Only one question I need. Because one group pre-test and post is design one group, pre-experimental. Why you have done on that?
I mean, you were asking that I should have a control group.
I'm just coming again. Yes.
Hello?
Yes, Manisha, you can answer it because already and you
Ma'am, you are
clarified, no issues. You can proceed.
Yeah, ma'am, you are expecting that I should have a control group.
Yes, that's what I'm asking. Why you didn't take a control group?
Actually, ma'am, because our hospital is having transplant center and all, means I was not very sure whether the whatever teaching or whatever things will do what I'm doing, because they are and I have selected those staff nurses who are working in dialysis unit, who are working in ICU, and who are working into the operation theaters. So I have selected that. We still have this thing that we will continue, but because of lockdown we were not able to continue the teaching program. We wanted to do the maximum number to be carried out. So maybe I can think later on to select between the private hospital or to the government hospital, ma'am.
Okay. Thank you. That's enough. Thank you. You have given. You spoke.
Okay.
Thank you so much.
Okay, ma'am. Can I do, ma'am?
Okay.
Thank you so much. Thank you.
Yeah,
Okay,
thank you.
Thank you for your suggestion, ma'am. Thank you.
Thank you, Manisha ma'am. Thank you, jury members. Next, Dr. Sahanatul Misriya. Please proceed your presentation.
Yes, sir. I'm here.
Madam,
What
first
is the
slide.
sequence? What is our sequence, Binu?
Madam, this is like
Our sequence is?
Madam, let me check. I will. Madam, 14, 1-4.
Okay.
It's given me 24. Am I wrong?
A code number is AP24, serial
Yeah.
number is 14, 1-4.
Okay, sir. Okay. Shall I start?
Yes.
Okay. Really, I'm feeling very great that it's great privilege for me to present in front of all these eminent persons and eminent distinguished researchers. In front of jury members, I would like to present my topic today regarding the Blackboard Collaborative Ultra as an effective learning tool in nursing education. Actually, I'm currently working in nursing department of College of Applied Medical Science from King Faisal University, Saudi Arabia. The background of the study is the education strategy changed in this current scenario due to this COVID-19 pandemic. And there are various virtual learning methods which were utilized by these students. Among those, this Blackboard Collaborative Ultra is one of the best method, which is going to be using the internet technology, and it is going to provide a best platform for teaching and learning, also which will be secured by the password.
जाके फिर से कनेक्ट हुआ मैडम, मैं डर गई इधर।
Anything?
आप बैठिए जब तक, बैठे वो दरवाजा अटका देना, बाहर का पहले अटका।
Blackboard has been designed as a user-friendly for both students and also educators, and it does not require any information technology expertise. So as per our current scenario, anyone nowadays, everybody is using the virtual platform, so anyone can use it in a simple way. And it allows for synchronous as well as the real-time activities such as chat rooms, files, screen sharing, and also we can make asynchronous such as discussion board, and we can have recordings and we can communicate. I mean, we can share these recordings to the students. Anytime they can use and reuse it. And also this will be giving the digital drop boxes, and that can be used very well with any kind of document transfer, even videos or PowerPoint or whatever teaching resources. So this study actually aims to compare the effect of the Blackboard Collaborative Ultra and the traditional teaching strategy in nursing education. The review of literature, as per the author Kazakuri and Asir, Blackboard Collaborative Ultra is one of the most popular course management system for classroom and online educational assistance. So this was stated in the year 2014 according to their research. And also another researcher who's Algebra in 2012 who stated that the Blackboard Collaborative Ultra is a distance learning management system serving as a medium through which the students can attend live classes, and they can also participate in those classes by using the whiteboard, real-time quizzes, recording and playback capabilities, and also they can use the application sharing. So here, this research had a research arised out of the research questions. What is the effect of teaching through Blackboard Collaborative Ultra among the nursing students? And also another question raised, which method is the more effective? And that is what the idea to come up to compare this Blackboard Collaborative Ultra or a traditional method in enhancing the students' learning achievement. So based upon that questions, the objectives were made that to examine the effect of Blackboard Collaborative Ultra and traditional method among the nursing students. So hypothesis made was there is a difference between Blackboard Collaborative Ultra and the traditional method among nursing students. So in the methodology, we used the quantitative method. In the quantitative method, the quasi-experimental design was used, in which the post-test only design used. So here the participants were selected randomly using the random sampling technique. So for both groups, like for one group is for BPCU and another group is for traditional, which is selected randomly. And this study was conducted in Nursing Department of College of Applied Medical Science in King Faisal University. So the students, the participants are the students of the baccalaureate program, that is BSN program. So we were studying the third year, second semester level. And here I told you already that the sample size, which consists of 44 in each group, which was selected by randomly, and for which the formula used with the 95% confidence interval and 80% of the power of the study. The inclusion criteria were BSN third year students first semester level, and they are studying in the nursing department in the King Faisal University, and the students who were willing to participate in the study. And the students who were irregular to the classes were excluded, and even they were irregular for the online program. So the data collection procedure, the post-test knowledge was assessed by using the structured multiple questionnaires, which consist of 50 items for both the groups after interventions. So totally, actually 3 chapters of community health nursing course was delivered for both groups in 2 different methods. So the different methodology was used for the 2 different groups using 9 credits, which means 3 weeks the program was, the teaching was continued. And the individual feedback also obtained from all the participants using 5-point scale on the teaching strategy and at the end of the teaching. And this tool was the questionnaire was moderated by the expert of the nursing panel, and also it is validated and it is reliability of the tool was tested by test retest method. The statistical method used in the descriptive statistics, mean and standard deviation was used, and under the inferential statistics, student t-test was used. So ethical consideration, before starting the study, the ethical clearance was obtained from the institutional review board of this university, and also the permission obtained from the head of the department as well as from the research committee coordinators to conduct the research. And then the informed consent was obtained from all the students who were participated in the study, and with the signature and with the witness. And the study method was explained clearly to the students, especially to prevent the dilution of the result. And also the confidentiality was assured, and voluntary participation and authorization were assured before starting the study, and withdrawal authorization were given, and which was clearly explained that the students will not be compensated for this research anyway. And also the professionalism was followed throughout the study. And the results obtained from the study is the mean value obtained from the Blackboard Collaborative Ultra is 9.27. Actually, there were 50 questions, and which was the score was made into 10. So the mean score was 9.27 for BBCU, and for the traditional method 7.83 with a standard deviation of 1.01. And the t-test value shows that 8.21, and which is very significant, that is less than 0.0001. And the finding of the study now, it's proved that it is more beneficial and effective than the face-to-face traditional learning method. And also the feedback from the students were showing that on this teaching strategy. So this is also, majority of them liked this BBCU than the traditional method. And it makes it very clear that the adoption of this method is very fruitful for the students. The discussion, also the findings of the present study supported by the similar study, which is conducted by Anna Carvalho in the year 2012, which was evidenced that the online courses were on par with the real classroom lessons, and also it had a similar impact on the learning process. So I would like to say some of the advantages of this Blackboard Collaborative Ultra based on instruction, because though there were many virtual platforms, so here, what are the main advantages? The both teachers and learners can benefit from this Blackboard instruction at any time and anywhere. So the teachers and learners to communicate synchronously as well as asynchronously. Teachers and students can use the audio and video panel to speak, chat, and see each other. So in addition, they can raise their virtual hands and they can send their feedback with emotions and respond using the polling tool. You know, it will be more interesting for the students when they are attending the answers through polling. And also the participants can communicate in other ways, like exchanging their objects, moving in shared spaces. The whiteboard also can be used in this platform. And also this will allow the collaborative and interactive learning, including announcement, chat rooms, emails, discussions, and even we can have a group discussions and all kind of virtual classrooms we can have it with the help of this. And also we can be able to conduct the examination. And by the way, we can make the test with the help of the moderator. We can allow the any moderators as a guest, and also we can conduct. Ask the students to submit the assignment. It's really going to be easy because we are making a rubrics in that itself. So once we upload the rubrics, automatically it is going to be graded with the help of rubrics. So the grading center is available and moderation is also available in this. Actually, many more advantages are there. I would like to mention some of the important things here. So this I can show you how we were using from our university. Actually, this Blackboard was utilized being since many years, and so this is what I wanted to show. This I had an I took it as an opportunity to discuss this with our people who are in our students, nursing students, to be benefited if all the kind of universities can use this platform. And at most, this is going to be useful at this present scenario because everybody is in the virtual platform. And recommendations, so the teachers should be encouraged to adopt Blackboard-based instruction in their teaching method of the courses. And also they can empower the students by creating a learner-centered environment in which they are actively and safely engaged in the teaching process via this Blackboard Collaborative Ultra. And these students also should have a clear idea of why they use this Blackboard Collaborate, and also what is the what they use it and for and how they use it. So the teachers should encourage all type of online feedback, oral and written, and immediate as well as a delayed method. We can use it. So limitations of this study is here we used only third-year students involved because. As a researcher wanted to have conduct this program and do the research, and here as we have only female students, so only girls are participated, skills were not assessed, and this is part of the course only was evaluated. It's not going to be considered as a summative evaluation, only formative. And the conclusion, the Blackboard Collaborative Ultra Learning helped the nursing students to increase the performance in comparison with the traditional method. So these are the references I would like to make it here. And thank you so much for all the members.
You can stop sharing your screen. Yeah, yes. Thank you.
Thank you.
It was a very good study. Actually, I remember my own study, what I did during the lockdown period, but my platform was different. Like you have used a Blackboard, I have used a Google Classroom. Only my concern is the first sentence, what you told was students were irregular in regular classes, were irregular for online classes. But my experience with my students were altogether different. Students who were not, few students who were not coming, rather they were coming for the online classes. They submitted all their assignments regularly and they were participating on the group activities. So what was your experience to share that? I would like to know that. And second thing, what I would like to know is, as per Indian ethical issues by ICMR, compensation is to be given, but you said you will not give any compensation to the students who are part of this study. Maybe you may be having your own reason. And last part is the recommendation, what you told. I would like to say, like in Indian scenario, if we do this study, I would like to add the training of teachers is very important in our Indian scenario. And regulatory bodies, what is their attitude in where you are working at present? Because in India, it is for the theory, they have given permission. for a certain percentage of theory classes, but for the practical skills and the other aspects, they are still reluctant. So these are the questions I would like you to answer. Otherwise, it was a very good study if you see the scenario of the pandemic and the future scenario.
Thank you, ma'am. Thank you so much, ma'am. Actually, when I worked in India, we have used like some kind of web-based instructional modules, like Moodle, something we have used.
Yeah.
But when I come to here, when I used this Blackboard, I feel that it's very easy to handle. So this is what I would like to share this information by this way, so our people will get the idea. Maybe in future, our Indian university may have this kind of software actually.
And your students who are irregular in regular classes, irregular on online, I would like to know the reason why you said this.
Sometimes, here, sometimes the students will be, here I will say one thing. Here pregnancy is allowed while doing the nursing program. So when they become pregnant, they will not come to the college. Sometimes they will not attend. So this is
okay. That is due to medical reason or the health reasons.
Yes.
Okay. Thank you so much. Thank you.
Thank you.
I have a question to you, Sabanatul.
Yes,
that what was the duration of your study?
3 weeks, ma'am. Actually, 9 credits I have used. So 3 weeks I have conducted the study.
Okay, and the feedback was taken from the students?
Yes, ma'am.
You did a comparative, no? Like general, common Blackboard, additional Blackboard, and this one.
Yes, I have mentioned it there. It's in the slide.
Yeah. So 3 weeks time you have taken for that evaluation. Yeah. That is one question. Second, is it possible to use this from the remote areas where the internet connections and those things?
Yes, this is actually excellent question, ma'am. When you see nowadays, I am feeling that now everybody is using the internet and the mobile phone. Suppose if anyone is not able to use it, so this will be eye opener for our higher level to make it available. I mean, make it easier, because now some I can hear from the news. Some of the students really they have a problem facing for attending the virtual classes because it's a lockdown period. Not go to the college.
We are facing that problem in the rural areas from now in the lockdown.
This will make eye opener for the people. This is my concern also.
Yeah, because if there is no connectivity, you cannot conduct the class, isn't it?
Yes, of course.
Yeah.
We needed internet connection, definitely.
Yeah, I had this only question.
But one thing I can assure here, ma'am, I would like to say here, we can have the recorded lecture. So suppose if they cannot avail at that moment, they can use it. So this is another advantage.
Yeah. That is, I think, in most of the platforms nowadays, like even on the Google Classroom, Zoom, YouTube, all this can be done.
But it is little bit, I'm feeling it's easy and more secured.
Yeah, it depends actually what is visible in your institution. It depends. Yeah.
Okay.
Vasanta ma'am, Maya ma'am.
Maya ma'am is there.
Vasanta ma'am.
Ma'am, I'm ready. Maya ma'am. Maya ma'am, you're unmute. Please, madam. Maya ma'am, I think you need to unmute. Not able to listen. Maya ma'am.
Sorry. Actually, my internet was not working and I recharge and all. So sorry today. This part, God bless you was.
Okay. Sabanatul, actually, I have a lot of questions on this because this lockdown period, I have undergone a lot of training on digi skills. So basic and advanced. So I have been trained on GCR, Moodle, Testmos, EduMart. So all that I got trained. But only thing, even I have got the training. I think in Ethiopia, I think it's somewhat like Saudi only. We also go for a lot of technology only here because people like PPTs only. No blackboards are used by any teachers here. But I always prefer chalk and talk. So I always go with the chalk. I'm the only teacher who will be with the chalk in Ethiopia along with the PPT, because without a blackboard, I cannot do it, because I think blackboard only can give a lot of interaction with the students. So the blended learning. So instead of going with a traditional, I think we have to blend both a traditional as well as a blackboard. That only will have more effectiveness. That's what I say. And India also, I think many have started using, and engineering colleges all, EduMart is very common because parents also can come under the control and students also can come into that. And I was very happy with the Bharati madam's thing, because she was telling in remote areas how it is possible, but you have supported telling that synchronous and non-synchronous, non-synchronous method could be used. So where you can go, even the students, you can upload the contents and students can do it little later on. But it's a very good study for this time, lockdown period, because now only I think that it has become an eye-opener for GCRL. I'm so happy, Neeraja madam. So this age, madam is like technology, she is selling lots, because people doesn't know even to handle many things. I think she is really because madam, I need to appreciate you only, madam, because you are such a source of good inspiration and motivation for all of us, madam. And I think this should be continued. This not only lockdown, I think anytime any situation can arise, blended learning should be introduced to all the students. I think we should take it as a challenge, and I think I will do it in Ethiopia also. Thank you.
And now
Sabanatul, best wishes.
Indian national education policy is emphasizing on blended learning.
Yeah, ma'am. Yes, ma'am.
For
Yeah,
Dr.
now-
Vasantha ma'am, I would like to say one few words, like same feeling, because the same inner feeling I also have, like the chalk and talk. That's what, when I use the blackboard, I will take the whiteboard sharing and I will write. As like, our feeling will be fulfilled in that way. Really, I like it.
Otherwise, no, nothing, no comments, best wishes.
Thank you, ma'am. Thank you, ma'am.
Thank you, Savanatul.
Yes, thank you. Thank you
Yeah,
all. Thank you so much for your great effort.
Thank you. Thank you, jury members. Next, ma'am, what is your decision? We should take a rest or
Yeah,
down?
we can have break for 5-7 minutes.
5. Okay.
Yeah,
So
small
for a
break we can have.
small break, 7 minutes, we will take the break, and we will start after the 7 minutes. Okay, thank you so much.
I need a break. Out of it.
What name do they see in life? What name do they very observed interested, get measurements affected patterns and abnormality of
उसको लगने दो कि आप उसका परमिशन से सब कर रहे हैं।
Welcome back, ma'am.
Thank you. Thank you.
So Shanta ma'am, are you ready?
Yes, sir, I am ready.
Okay, please check your you are able to share your presentation.
Yeah.
शांता मैडम आप रेडी हो ना? शांता मैडम रेडी हो ना?
हाँ सर।
अभी बस आपका बस रख
Sir,
दो
it is
स्लाइड।
visible? Yes, sir.
सब चेक कर लो, यू कैन चेक योर एवरीथिंग इज ओके।
Okay, sir, slide is visible?
नॉट विजिबल।
Not visible.
शांता मैडम कोई दिक्कत हो रही है? हाँ अभी आ रही है।
Yes. Sir, visible?
हाँ अभी विजिबल है, थोड़ा सा विजिबल है।
Okay.
फुल स्क्रीन करो।
Sir, now?
फुल स्क्रीन करो मैडम। हाँ अभी सही है।
Full screen. Okay.
हाँ बस ओके ओके।
Okay. Okay, sir. Okay, so myself, Shanta Chaudhary. I am working as an assistant professor.
Madam, wait.
Ma'am, 1 second, 1 second. Wait for 2 minutes, ma'am.
इसका सीक्वेंस क्या है बिनो? बिनो हर सीक्वेंस?
सीरियल नंबर 11 AP21.
Okay.
Serial number 11 AP25. 21.
Okay.
21.
Ma'am, shall we start, ma'am?
Yeah, you can start.
Yes, Shanta ma'am,
Okay,
start
thank
the
you, ma'am. Okay. Myself, Santa Chaudhary. I am working as an assistant professor at Sri Krishna Institute of Nursing, Babar, Gujarat State. I am here presenting my study. Statement was a study to assess the effectiveness of plant teaching program on prevention and management of suicide in terms of knowledge and attitude among staff nurses working in Hospital for Mental Health of Gujarat State. Introduction. It is a time-proven fact that all the living organisms on this earth fight for survival and existence. What then makes the man to risk his own life? The tragedy of self-inflicted death has always attracted the attention of the medical as well as the legal fraternity. According to WHO, suicide is the third leading cause of death for teens and second leading cause of death in college. According to WHO 2011 data, annual estimates approximately 1 million people die from suicide and for every 10 to 20 minutes, more people attempt to suicide worldwide. This represents 1 death for every 40 seconds and 1 attempt for every 3 seconds on average. According to National Crime Bureau report, in 2010, each in every 3 suicide victims was a youth, age group 15 to 29 years. Then according to WHO data 2018, close to 80,000 people die due to suicide every year, which is 1 person every 40 seconds. Suicide is the second leading cause of death among 15 to 29-year-olds globally. 79% of global suicide occur in low and middle income countries. Ingestion of pesticides, hanging, and firearms are among the most common methods of suicide globally. So, nurse have to knowledge. A nurse can play greater role in suicide prevention at various levels. Nurse can identify, educate, and prevent suicide among adolescents and older. She can teach and train people to identify suicide so that one can avert such effort by early intervention. Study objective was, first objective is to assess the knowledge of staff nurses before and after implementation of plant teaching program on prevention and management of suicide. Then second objective was to assess the attitude of staff nurses before and after implementation of plant teaching program on prevention and management of suicide. Then third objective was to find out the association between the knowledge and attitude on prevention and management of suicide with their selected demographic variables. Then hypothesis. The null hypothesis was there will be a no significant effectiveness of plant teaching program on prevention and management of suicide among staff nurses working in Hospital for Mental Health of Gujarat State. Then a research hypothesis is, first, the mean post-test knowledge score of staff nurses on prevention and management of suicide will be significantly higher than their mean pre-test knowledge score. Then second hypothesis, the mean post-test attitude score of the staff nurses on prevention and management of suicide will be significantly higher than their mean pre-test attitude score. Then third hypothesis was, there will be a significant association between knowledge score and attitude score with their selected demographic variables. In study, I used system model 1 Burtonby 1965 model. In that, I use input, process, and output. Then methodology of the study. In that quasi-experimental research design I used. Then one group pre-test, post-test design I selected. Then population. Staff nurses who are working in Hospital for Mental Health of Gujarat State. From that, 2 hospitals I selected, Hospital for Mental Health Ahmedabad and Hospital for Mental Health Baroda, From 2 hospital, 20 samples I selected. So sample size was 40. Then sampling technique, convenient sampling technique I used. Then tools, structure, questionnaire, it consists section 1, demographic variable, section 2, knowledge questionnaire, and section 3, Likert attitude scale. During the data collection, first pre-test conducted, then plant teaching program given and post-test conducted. Data analysis, demographic variables in terms of frequency and percentage, and association between the knowledge and attitude with selected demographic variables in terms of chi-square. Description of the tool for data collection. In that section 1 consists of personal data of age, gender, professional qualification, duration of experience in psychiatric setup, and training attended on prevention and management of suicide. Then section 2 consists structured knowledge questionnaire regarding knowledge among staff nurses. Total item was 30 and each item carry 1 mark. Each wrong answer carry 0 marks. Maximum score of the questionnaire is 30. The subjects were classified into 3 groups. 1 to 10 score indicate poor knowledge, 11 to 20 score indicate average knowledge, and 21 to 30 score indicate good knowledge. Then section 3 was consist Likert scale regarding attitude among staff nurses. The 5-point Likert scale consists ranking from 1 to 5. Positive statement on the basis of strongly agree indicate 5, agree indicate 4, uncertain indicate 3, disagree indicate 2, and strongly agree indicate 1. And the ranking system of negative system statement on the basis of strongly agree indicate 1, agree indicate 2, uncertain indicate 3, disagree indicate 4, and strongly disagree indicate 5. The tool consists 20 questions regarding attitude on prevention and management of suicide. The minimum score is 20 and maximum score is 100. The subjects were classified into 2 groups based on their score. 20 to 60 score indicate unfavorable attitude and 61 to 100 score indicate favorable attitude. Reliability of the structure knowledge tool was done by Carl Pearson formula, that is 0.76, and Likert attitude tool was done by Kronberg alpha, that was 0.86. The validity of the tool is done through 11 experts. Out of 11, 3 from psychiatric department, there are psychiatrists, and 8 from nursing field. Then data analysis and interpretation. Description and inferential statistics were used to analyze the data. Out of 40 samples, majority of samples, 22 belongs to age group 31 to 40 years, that is 55%. Then 32 were females, that is 80%. Then 24 were having GNM qualification, that is 60% having GNM qualification. Then 33 were having 1 to 5 year experience, that is 82.5%. And 37 samples were not attended any type of training, that is 92%. So overall graph, frequency wise distribution of sample according to demographic variable. In that 22 samples were 20 to 30 years old, then 5 samples were 31 to 40 year old, then 8 samples were 41 to 50 year old, then 5 samples were above 50. Then in gender, 8 were male and 32 are female. In professional qualification, 4 samples were GNM qualification, 14 samples were BSc qualification, then none of is PG diploma, and 2 samples were MSc psychiatric. In working experience in psychiatric setup, 33 samples were 1 to 5 year experience, 3 samples having 6 to 10 year experience, then 3 samples have 11 to 15 year experience, and 1 sample have more than 50 year experience. In training attended about the suicide prevention and management, 3 samples were attended training and 30 7 samples not attended any type of training. According to the area-wide distribution of the knowledge questionnaire, in that after post-test in introduction area, samples are improved knowledge, and in prevention and management area also they improved knowledge. Then bar graph showing frequency-wise distribution of pre-test and post-test knowledge score of the sample. During the pre-test, 4 samples were have poor knowledge, 29 samples were have average knowledge, and 7 samples were have good knowledge. And after post-test, 4 samples were have average knowledge and 36 samples were have good knowledge. None of them are under poor knowledge. Then pie graph showing mean score of pre-test and post-test knowledge score of the sample. Pre-test mean was 16.87 and post-test mean score is 24.9. The mean difference and standard deviation and error are: the post-test mean score was 24.9 is higher than pre-test mean score, that is 16.87. So mean difference is 8.03 and calculated table value is 13.56. Then attitude score. Bar graph showing frequency-wise distribution of the sample based on pre-test and post-test attitude score. During pre-test, 6 samples were having unfavorable attitude and 34 samples were favorable attitude. But after post-test, all samples have favorable attitudes. Then pie graph showing mean score of attitude according to pre-test and post-test attitude of the samples. So pre-test mean score was 72.9 and post-test mean score was 86.27. Then mean difference and standard deviation of data. Post-test attitude score was 86.27 is higher than pre-test score, that is 72.9. Mean difference was 13.37 and calculated t-value was 4.62. So at last conclusion, in this study 40 samples participated. In relation to finding of the study, it was revealed that majority of sample had good knowledge and favorable attitude after implementation of plant teaching program on prevention and management of suicide. The mean post-test knowledge score was higher than mean pre-test knowledge score with the mean difference of 8.03. Mean post-test attitude score was higher than mean pre-test attitude score with the mean difference of 13.37. The association of the selected demographic variable with the knowledge and pre-test attitude score was computed using chi-square test, and it showed that there is significant association found with post-test knowledge score and age group of the sample. There is significant association between the age group and the pre-test attitude score. So data was found that significant increase in knowledge and attitude on prevention and management of suicide after implementation of plant teaching program. Okay, ma'am. Thank you.
Shanta?
Yeah, ma'am.
Yes, can you hear me?
Yeah, ma'am.
Shanta, the plant teaching program was of how much duration?
Ma'am, 45 minutes.
What was the duration of plant teaching program?
Ma'am, 45 minute duration I taken for plant teaching.
And single session?
Ma'am, for 20.
Only one session?
Ma'am, for one hospital, one session, and second hospital, one session. Ma'am, two hospitals.
Means for each participant, only one session, huh? Only
Yeah,
one
ma'am.
session, huh?
Yeah,
and
ma'am.
in that your attitude change is not digestible little bit. because you see knowledge comes easily, then skill and attitude takes lot of time to get changed, you know. That is the last
ma'am.
which comes
Okay, ma'am.
after the knowledge, skill, and then attitude. So that is something your study and data which is telling no favorable attitude
Yeah,
in
ma'am.
one single teaching, because I belong to mental health, and I
ma'am.
know that it is very difficult even if people are working for 15 years, 20 years, but change of attitude takes lot of time, dear.
Yeah.
So that is one query with me, that one.
I
And
to agree with.
your tools were standard tool or you made it?
Ma'am, I made it and I taken expert guidance.
You validated it.
Yeah, ma'am. Ma'am,
It was
during
in
my
Gujarati
master,
or English?
ma'am, in English completely. Ma'am, during
It
my
was completely in English.
yeah, ma'am. This is my PG master
No,
study,
no,
ma'am.
no. I mean to say, see, some of the staff nurses are not well versed with the English language. I understand.
Yes, I
So when
agree.
you are giving this, so whether you got it translated?
Yeah, ma'am. If they are not understood, then I explain.
No, it means there was a need for translation, because many
Yeah.
of the staff nurses, those who are working, may not be able to understand, and your explanation and their interpretation can differ.
Yeah.
It can always differ what you are saying and what she is interpreting. So that's why we do the pilot study, no? When
Yeah,
we are
ma'am.
making a tool, we do a pilot study to understand that is there any difficulty with the samples and the subjects, those who are included in your study, about the language or not able to understand. So that is one thing you need to take care of. Then your
Okay, ma'am.
samples were 40 only.
Yeah, ma'am.
So that also the area which I feel that should be taken care of. And review of literature, did you show or I missed it?
No, ma'am, I didn't so on, but I taken ma'am 2 or 3 related to nurses study. One study
No,
according.
but I'm telling you now, with the lockdown
Yeah.
and a national day for suicide prevention.
Yeah, 10th of September.
Yeah, there is lot many activities which we do for the people to avoid deliberate self-harm.
Yeah.
For silly reasons, okay?
Yeah.
But it is very difficult to convince when they decide, right?
Yeah.
So
Yeah,
it's a
ma'am.
very, very sensitive issue, and it cannot be resolved or made understood to anybody in one session or 2 sessions. That is one thing which I wanted to say. So attitude comes very late, but it cannot come so early. That was my question. And what other things you did to convince them? And what was the content of your structured teaching program?
Ma'am, in that I introduction, a method.
What was the content of your structured teaching program?
Ma'am, introduction, risk factor, method of suicide, then sign and symptoms, assessment, and prevention and management of suicide. Ma'am, more
What
focus
about
on
the
prevention and
cues?
management of suicide.
Now, what about the cues which they give before committing suicide? Many a times they give
Yeah.
you cues.
Yeah, they give
That
verbal
I'm,
cues.
yeah, and they may say. So, what are those that
What are-
need to be included?
Yeah, many times they are saying that my bank account will be closed. Then many times they are, I am not useful to words. Then many times they are silently sitting alone.
Yeah, yeah. Those cues should be included in that. Okay.
Yeah, ma'am. One question is there
And there
about
is
that.
one important thing which need to be included.
Yeah.
One important thing which need to be included in suicide prevention is there should be a help diary.
Yeah.
What this help diary is, whenever a thought of suicide comes, I should
Yeah.
have something which can divert me from that.
Yeah.
And that includes your old memories.
Yeah.
Good memories, good songs. You want to watch some movies
Yeah.
which can elevate your mood and take you away from this important decision of yours to take your own life. So that a box is there in which they have to keep all these things ready, that whenever this thought comes, then I have to immediately listen to this song. I have to immediately talk to somebody. So this
Yeah.
number should be there. So that must be included in your teaching, which is lacking.
Okay.
Okay. So this help diary should be there with them, that if I have that thought, to whom I will call. If that number is not responding, who is the next person? Or which will the things which will divert me or give me a good feeling, that I can see some album. So those photos should be there. Most loving person who he likes their photos. So all these things are important thing which can divert, because it takes a minute to drink a pesticide or to hang oneself. Okay, so those things must be included in your teaching plan. That's it. Now, madam, will add to it.
Yeah, that
And
is a
others are
very actually a need-based, and if you see after Sushant Singh, it is a suicide or whatever it was. People have become so conscious about this. Even the young people are feeling so bad why he has done this. So the awareness about this, the how to handle the stress, crisis. If you see today's world, especially the young children who are working in the multinational companies and the private sector, they face lots of pressure. Rather, I should say, because you have taken only 40 staff nurses, it should be a pilot study for you. And what you can do is you can do a comparative study, one taking the health professionals, especially if you see the cases from the medical colleges, also so many suicide cases from engineering colleges.
Yeah, ma'am.
You can do a
27%.
comparative study, nurses, doctors, engineers.
Yeah.
The young children who are working in the multinational companies, that will be a best sample for you, these 3-4, and you can do a good comparative study. And like madam has told you, you can add the component in teaching. One is your supportive and the counseling services from where they can get. That is very important. Any helpline number.
Helpline numbers, yeah.
Okay. So these things are very important for you. And after how many days you have given a post test?
Ma'am, 7th day.
But still you should have more gap, because post test you can actually, if 7 days, then you can have 2-3 post test, okay, in sequence. Maybe after 1 month or 3 months, because 7 days is a very less time period. Retention will be there. Okay.
Yeah.
So, and same way, I would also agree with the madam. Attitude change is very difficult. Very difficult.
Yeah,
Even if you see knowledge, if you see, I think you must have also read the Bloom's taxonomy. If
Yes.
How the
Bloom's
knowledge,
taxonomy,
first they remember, then they understand, then they apply, then they analyze. So many stages even in the knowledge are there.
Yeah.
So it is very, first of all, change in knowledge is not so easy. Even suppose someone tells me to change my attitude, I will take years to change my attitude. It's not so easy to change. So these were some of my suggestions for you. But this area is a very good area, and
very
it is
sensitive area.
It is the need of the day. And you should understand the underlying causes of these, especially of the not of staff nurses. If you will take students, you will get a good study. Students are more prone for suicides, you know. You see the trend, even medical colleges, engineering colleges. Then you can take two groups of students and two groups of people, young people who are working in various settings. Like I told you, nurses and the multinational group. The suicide rate is very high in these groups.
Yes.
So that is just my suggestion. Thank you so much.
One thing I would like to add, ma'am, one thing, a de-escalation technique need to be taught.
Yeah.
If you find someone who is who has decided that, no, now I don't want to leave, how to de-escalate him to bring him to the ground level is a technique of talking with the person and all. So that need to be learned by the healthcare professional to de-escalate his temperament, to bring him down to the ground level and change his decision.
Yeah, because this is a 1 minute decision. 1 minute decision this is. Yeah. Hand over to Vasanta.
Thank you.
Thank you, madam. Thank you. And I think expert Bharti madam is there, mental health nursing expert, and she has given a very good thing. And madam also, ma'am. I wanted to ask you one thing, because I feel students, nurses, as madam told, they're more prone But nurses, I don't know, because I've never seen statistics of nurses suicide. Because I feel nurses are very strong. They are very strong. Okay, and we never go for suicides. So I think it's better you can teach the nurses to gone for a study where they can identify whether the suicidal, like the ideations are found in the individual, a patient. And you could have tried such type of study, and what services nurses can do for them to prevent the suicidal thoughts and ideation. And I think that would have been better rather than doing it for the nurses. So that is one concern. And another one is quasi-experimental approach, one group pretest post-test design. What is that? It is an evaluative approach or quantitative approach. No, quasi-experimental approach is wrong. It is an evaluative or quantitative approach, and it is a one group one. You are done only on 40, only one group. So it is only pre-experimental. It's not quasi. It's pre-experimental design. And also, as Madam told, no, you don't. Pre-experimental is always a weak design. Never go for that. You even attempt to take a control group. You could have taken even another setting. Go for another setting. You take a control from the and like one person has done, one madam has done, no, like she has done mental health, like she has taken a different 6 groups. Like that, you can also choose many groups and we can find out. And like Teja madam has told, students, that will be more good compared to doing for nurses. You can try it little later on this. Okay, thank you.
Thank you, ma'am.
I also like to congratulate, very good study, no doubt. But as Santa madam said, nurses are strong and a very less suicidal tendency in the working women, nurses.
But I seen one or two study in that from Punjab, one study in that 27% nurses are doing suicide.
We make some family affair. Okay.
Then they can treat to patient also. So I focus on prevention and management only.
Okay. But
include myths about suicide. Shanta, Shanta, include myths about suicide.
Yeah, ma'am.
In your teaching, there should be myths about suicide, myths and misconceptions about suicide. One thing, and talk to them. People say don't talk about suicide, but you need to talk to know what method he is going to adopt.
Yeah.
If you know the method what he is going to adopt, you can keep him away from that. If he says, okay, you have a thought of suicide, how you would like to do that, execute it, then he may say, I want to drink pesticide. So you know he is going to do that way. Or he say, I would like to throw myself in front of a running vehicle. So these are the things which will give you a small things to save his life. Okay.
Yeah.
So these all need to be included in your study.
Yeah. Okay, madam.
Thank you so much. Yes, so
Thank
all
you,
the
ma'am.
best. All the best.
Thank you, ma'am. Thank you so much.
Binu, shall we go for next?
Next, yes, madam. Jennifer, madam, be ready.
15 number, no? Jennifer is 15, I think.
Good evening, ma'am. AP 25.
Good evening, all the judges.
Good
I would
evening,
like
good-
to ask,
good
ma'am,
evening.
is my screen visible?
Yes, you can.
Yes, now it is.
Thank you, ma'am. Can I start?
Yes, please.
Myself, Jennifer Singh. The topic of my paper presentation is a study to assess the prevalence of cognitive impairment and depression among elderly people living in rural areas of Moradabad, Uttar Pradesh. The background of my study clearly says that as aging is a normal and inescapable change, which will take regardless of whether you had best nutrition and healthcare. It is a change that happens all throughout our life. The old population is vulnerable age having various health issues which include cognitive disability and depression. The need of my study is as society ages, so the age-related diseases are also increasing at both personal and public health concern. Late life sadness happening in patients above 65 is a genuine ailment and may prompt weakened physical capacity, expanded mortality, and outlashing utilization of human services asset. Freshness, that is depression, is more established, grown-up stays underanalyzed. The statement of my problem is a study to assess the prevalence of cognitive impairment and depression among elderly people living in rural areas of Moradabad,
Madhya Pradesh. The main purpose of my study was to assess the prevalence of cognitive impairment and depression, and the findings would help the elderly and their family members to recognize the factors which can lead to depression and cognitive impairment. The objectives of my studies were to assess the prevalence of cognitive impairment among elderly people, to assess the prevalence of depression among elderly people, to determine the relationship between cognitive impairment and depression among elderly people, to find the association between the level of cognitive impairment with the selected demographic variable, and the last objective was to find the association between level of depression with their selected demographic variable. The hypothesis of my study was, which was being tested at 0.05 level of significance, there is a significant relationship between cognitive impairment and depression among elderly people. There is a significant association between level of cognitive impairment with their selected demographic variable. And the third hypothesis is, there is a significant association between level of depression with their selected demographic variable. The delimitation for my study was, the study was limited to only elderly of selected rural areas of Muradabad. The assumption for my study was, cognitive impairment can lead to depression and elderly people may have high level of depression. The variables of my study were research variable, cognitive impairment and depression, while the demographic variables were age, gender, religion, level of education, occupation, marital status, type of family, ability to carry daily activities, any medical and psychiatric disorder in the family. Operational definitions. Elderly, in this elderly people refers to men and women who were aged above 60 years. Cognitive impairment, according to my study, it is the point at which an individual has issues in recollecting, learning new things, thinking and settling on choices that influence their regular day-to-day existence. Depression, according to my study, was elderly people who are having low mood, poor activity and poor concentration along with attention. Rural population, in my study, it means elderly who are living in lower population area outside towns and cities. I have divided my review of literature in 5 sessions. First section, consider reviews literature related to prevalence of depression. Second was literature related to prevalence of cognitive impairment. Third was literature related to relationship between cognitive impairment and depression. Fourth was literature related to prevalence of cognitive impairment with associated factors. And the last was literature related to prevalence of depression with associated factors. My research methodology was research approach quantitative study, design cross-sectional descriptive study. Research setting was rural areas of Muradabad, village Fiazpur, Muradabad. Accessible population was elderly with age 60 years and above. Samples were elderly with age group 60 years and above. Sample size was 230 elderly people. Sampling technique was convenience sampling technique. My inclusion and exclusion criteria was, inclusion was elderly people with age 60 years and above and the elderly people who are living in rural areas of Muradabad. While the exclusion criteria was elderly who do not have interest to participate in the study and elderly people who are having any communication difficulty. Selection and development of study instrument. I have collected all the reviews related to my study and then demographic tool was being prepared. I have used 2 standardized tools for cognitive impairment and depression. Both the standardized tools were present in for public domain. Although I have taken the permission from both the authors through mail, tools were being given to 7 experts for validation along with Hindu tool, as I have added demographic tool, so that thing needs to be validated. Modification was done in the demographic tool. Content validity index and scale validity index was calculated, which was 1, and then tool was being administered to all the elderlies. Scoring criteria, as I have said, I have used 2 standardized tools. MOCA, that is Monitorial Cognitive Assessment. This was for cognitive impairment. The normal score was considered 26 and above, and less than 26 was mild cognitive impairment. For depression, I have used geriatric depression scale, and the scoring was normal 0 to 9, mild depressive 10 to 19, and severe depressive 20 to 30. This was the tool for MOCA. This tool is already present in Hindi language also. And the second tool was Geriatric Depression Scale. In that scale, there are 30 questions, and that scale is also present in Hindi language. Pilot study. For pilot study, I have chosen Mohammadpur village, Muradabad, and formal permission was taken from the village Pradhan. The samples were being made aware about the nature and purpose of the study, and this written consent was being obtained. For pilot study, I have taken 20 samples. And for the main study, I have taken village Fiazpur, Muradabad, and the total samples were 230 samples. And the sampling technique was convenience sampling technique. Samples were made aware about the nature and the purpose of the study. First section was description of the socio-demographic variable. Here, while I was doing the analyzation, I saw that most of the people belong to 60 to 65 years. And for gender, most of the elderly were female. From religion, most of the people were from Hindu religion. And education, most of the people were illiterate. For education, most of the people were housewife. Marital status, most of the people were married. Type of the family, most of the people belong to joint family. And ability to carry daily activities, most of the people, that is 66.1%, were able to carry their daily activities. Medical illness, yes, 80.43 people were having some or the other medical illness. And for psychiatric illness, yes, 86 to 86.9 people were having psychiatric illness in their family. My section 2 was description of prevalence of cognitive impairment among elderly people, which was being calculated as 51.30. Section 3 was prevalence of depression among elderly people, which was 74.78%. My next section was description of relationship between cognitive impairment and depression. So the correlation was 0.20, that is non-significant, which shows, this is the diagram, which clearly shows that there is no correlation between cognitive impairment and depression among elderly. Hence, the status hypothesis H1, there was a significant relationship between cognitive impairment and depression among elderly, is rejected. Hence, null hypothesis failed to reject. My next section was association of cognitive impairment with demographic variable. And in this, all the demographic variables, that is age, gender, religion, education, marital status, occupation, type of family, daily activity, any psychiatric illness in the family, any medical illness in the family, was significant. An interpretation of the finding says that there is a significant association found between cognitive impairment with their socio-demographic variable. Hence, hypothesis H2, that is, there is a significant association between level of cognitive impairment with their selected demographic variable, is accepted. Hence, null hypothesis is rejected. My next section was association of depression with demographic variable. Here also, all my demographic variables were significant. Interpretation of the findings clearly says that, hence hypothesis H3, that is, there is a significant association between the level of depression with their selected demographic variable, is accepted. Hence, null hypothesis is rejected. Summary of my findings is majority of the people were 60% were from age group of 60 to 65 years, 120 were female, 196 were Hindu, 110 were illiterate, 128 were housewife, 134 lives in joint family, 152 elderly were able to carry their daily activities, 199 elderly were having psychiatric illness in their family, and 185 elderly were having medical problems in their family. The prevalence rate for cognitive impairment was 51.30 and the depression rate was 74.78%. The correlation coefficient value was 0.20 by using Carr-Pearson correlation coefficient, which shows that there was a significant association between cognitive impairment and depression with selected demographic variable. The discussion of my study, I have taken one similar study to clearly shows the discussion. On the left side, there is my present study, which overall shows that cross-sectional study was conducted on 230 samples using convenience sampling technique, and data was collected using GDS and MOCA. One, I have taken the similar study to show the difference. and et al. Conducted a cross-sectional descriptive study on 118 elderly people to evaluate cognitive function and depression and quality of life of elderly people living in nursing home by using MOCA and geriatric depression scale, standardized mini mental status examination and geriatric depression scale. The samples were selected using simple random sampling technique. In my study, the prevalence rate for cognitive impairment was 51.30 and for depression it was 74.78, while in the review of literature, the cognitive impairment prevalence was 22.07% and for depression it was 34.6%. And the research shows that there is no correlation between cognitive impairment and depression. So in my study also, it clearly shows that there was no correlation between cognitive impairment and depression among elderly people. Implications of the study, I have divided into 3 criteria, that is nursing education, nursing administration and nursing research. Nursing education, if the nursing student are being told about the driving forces which can prompt towards depression and cognitive impairment, then definitely it can reduce the cases of depression and cognitive impairment in our elderly population. Nursing administration can generate supervisory work environment. The nurse administrator can initiate appropriate plans and policies focusing on personality and behavior of their subordinate. And for nursing researchers, nursing students need to take part in various aspects of research, which will help to recognize early cases of cognitive impairment and depression among elderly. My study's limitation, the study was limited to only 60 years and above elderly. Setting of the study was limited due to research feasibility and time bound. The further recommendation which I would like to give is that a comparative study can be done between rural and urban elderly regarding cognitive impairment and depression. And these are my references. Thank you, ma'am. Ma'am, can I stop sharing the screen?
Yes, yes.
Yeah, you need to stop.
Thank you, ma'am.
Again, we have the same question. What was the purpose of this study?
Yes.
A geriatric person, you are giving 50, 60 questions. And what he is getting out of your study, he is at the fag end of his life, and you have gone and you have got so many things and you asked him. But in return, what he received, have you ever thought?
No practical implementation.
Right. Ma'am, but for geriatric depression scale, there were only 30 questions and it was considered only for yes, no.
But still, beta.
No, not that, beta. Not that. And we are not saying that you have, yes, no. But we are saying what your subject has received from you as a healthcare professional. Tell me.
What is the
if you are coming to me and asking me study, no? It should be socially useful. That is the first thing. Is it socially useful? You have collected the data. And second important thing is you are telling about the cognitive impairment and depression. It is well known. It is well known in the literature that this is going to happen. You have only used your money, material, and yourself to collect the data again for just telling that there is a cognitive impairment. But what your patients or your subjects have got, tell me.
Yes, ma'am. Practically, it is not feasible. Yes, ma'am.
Yeah. No. That's why. Always remember the finers. When you do a study, finers word one. You need to remember that. Okay?
Yes,
finers is one, whether it is feasible. Whether it is feasible, first question. Second, whether it is innovative and interesting. Whether something new coming out of it. And E, whether it is ethically right. And R, whether it is replicable. And S last is whether it is socially useful to the society. So these finers is one thing which you need to keep in your mind whenever you do any study, small, big, any study you want to do. Remember this specifically remember that these many criteria you need to follow and then you can do.
Okay,
So
ma'am.
tell me now, you have how much time you took to do this study?
Ma'am, for data collection, I have taken 3 weeks, and for complete study, it was my PG. It was my PG study. So, ma'am, 2 years.
Yeah,
I have
yeah,
taken.
that you have done. And one thing you need to improve in your pronunciation, it is rural.
Okay.
And this not only you, I find with many of the medical people that they call it ruler. It is not ruler, but it is rural. Rural. You twist your tongue and say many a times. Okay.
Okay, ma'am. Yes,
So
ma'am.
it is rural. Okay, it is rural. So many a times that has come. One thing you tell me, you had standardized tools. Then why you went for pilot study?
Ma'am, because there was one point in the tool MOCA that if the candidates or the participants are illiterate, then you should add 0.1 to the result. Ma'am, for to check that thing, I basically went for pilot study.
When they are instructing, there is no need, beta. We go for pilot study when we make our own tools and we see the feasibility of tool, isn't it?
Yes, ma'am.
So I think Nirja madam can also throw light
Yeah.
on this aspect. For
Otherwise, there was-
standardized tools, there is hardly any need, because it
ma'am.
is
And it
already
was-
tested on so many people. And then
And
only
she is saying
thousands
it
and
was
thousands
available
of
in
people
Hindi also.
cross-culturally they check, and then only they make it a standardized tool. So I think that was, and second thing, 230 samples. It's not a less people. You have
Yes, ma'am.
wasted so much of time and this thing, but you are not given anything to the subjects. So that thought must come in our mind as a researcher, that how can we be useful to the people when we are going for research. Okay. Now,
Okay, ma'am.
madam will throw light on the other
Yeah, no,
panelists.
most of the points I think Madam has covered. Mike, again, same, some of the points were same, but only one thing I would like to add. Even when you give recommendations, why you want to give everything for the curriculum and the nursing students? Nursing students will be there only for 1 year, 2 years, and that also for limited period, 15 days, 1 month in the community or the psychiatric area. You should give some good recommendation for the nursing practice, for the community health workers who are actually working in the community. You can, okay, your recommendation also should be feasible, which can be recommended, which can be implemented also. So these things you have to take care of. And it should have a social value. Okay. And
Yes, ma'am.
you can go through the national program of elderly of Government of India and see how you can integrate your
Yes,
study,
yes.
those
Correct.
guidelines and the strategies. So you people should know how to integrate the subjects. It is not that if you are working in psychiatry or medical, surgical or community, you have to integrate the things. Okay, that is important.
Yes,
Thank you.
ma'am.
Thank you.
Just a small thing, already it is discussed. In implementation, you
Yes,
have
ma'am.
written nursing implementation, you have written nursing research, nursing academic, and nursing administration. So add in that nursing practice also.
Okay, ma'am. Okay, ma'am.
Then don't give implications to others, my darling son, daughter. You yourself imply something in your research. Others will hardly do. Once you have left means it is gone. Then it comes in implication and on paper only. Okay.
Yes, ma'am.
Interventional studies will always have value.
Okay.
Do
Value,
something
correct.
and then Okay.
Okay, ma'am.
You can, when you are doing something in the practice area, you have to do it.
Okay, ma'am.
Jennifer, actually, they have told everything, but one thing I want to tell you,
Yes,
I
ma'am.
feel all the researches people have presented, all the research areas are very nice areas, but everything is incomplete, as you people are not gone for any intervention. That was the problem.
Yes, ma'am.
If you have taken 230 subjects, If you
Yes,
have
ma'am.
taken 230, you have found out there is impairment, you found a depression, you could have immediately gone for an intervention. So it would have made like a mixed methodology or something like that. And you could have done very nice study and output. I think geriatric training is given in almost all institutions. It's having a very good scope for our like our country. So in that case, because our country people, most of the geriatric people, they need a lot of services. You could have tried in that way. And
Okay,
but
ma'am.
that's why it has become very incomplete. The study is becoming little incomplete because nothing is being done. The scope is
Okay,
not,
ma'am.
it is not meeting the scope of the thing, what is required. The significance, the contribution of this study, we are not able to tell anything. No, it's not going to add to any contribution. We are just telling, okay, we all know very well. No, geriatric persons will have cognitive impairment. Geriatric persons will have a depression. It's all known. So what is the need to do it? You do some intervention.
Okay,
That
ma'am.
will have a lot. Okay, thank
Okay,
you,
ma'am.
thank you.
Thank you,
Best
ma'am.
wishes.
Thank
Future, I think you can all
All the
decide on
best.
this. Thank
Thank
you.
you,
The
ma'am.
best for your future studies.
Thank you, ma'am.
Thank you, ma'am. And next, Payal Sharma. Payal,
Yes,
ma'am.
sir, I'm ready. Ready, sir,
Yeah,
I'm
you are.
ready, sir.
Okay, okay. Thank you. Please
Thank you, sir.
proceed your
Can I?
presentation.
Payal Sharma sequence is 14 or something
Sir,
else?
22, ma'am.
Serial number 12, AP 22.
12. Okay.
AP 22.
12.
Discuss the effective use of teaching program regarding
No, not
selected
audible.
narcotic drug.
Payal madam, please.
Payal,
you sound-
not audible. You are not audible.
Ma'am, am I audible to you all, ma'am? Hello,
Yes,
ma'am.
now
Yes,
audible.
now.
Okay, good evening to all, ma'am.
Payal,
You have to go back to the
slideshow.
Yeah.
Okay, okay.
Can
You
you
can-
see my slides, ma'am? Excuse
Yes,
me.
you can continue.
Okay, ma'am. Can you see, ma'am?
Selected
Yeah.
narcotic drug.
Hello. A very good evening to everyone, panelists, and all the judges. Myself, Payal Sharma, ma'am. The title of my study is, ma'am, Effectiveness of the Structured Teaching Program regarding use of selected narcotic drugs among staff nurse working in a mental hospital. The problem statement is a study to assess the effectiveness of structured teaching program regarding the use of selected narcotic drugs among staff nurse working in a mental hospital at Indore. A background of my study is a narcotic drugs. It is very efficient and used for controlling the pain. As we all are know, the mania patient and the schizophrenic patients are having due to some neuroleptic reasons. They are some having pain something, and they are not able to say all these things. So the doctor recommended, and the nurses are have to see this prescription, and they have to give the medication to the patients. So the need of this study is, as the psychiatric nurses, the most of them are not aware that why they are giving this narcotic drugs. So this is my study to give a light on that. Why should they have to use the narcotic drug? They should have some knowledge regarding that. So I have chosen this topic, ma'am. The objective of my study was to assess the pre-test and the post-test knowledge score regarding the use of selected narcotic drugs among the staff nurse working in a selected hospital. My second objective was, ma'am, to evaluate the effectiveness of structured teaching program regarding the use of selected narcotic drugs among staff nurses. And the hypothesis of my study was there will be a significant difference between pre-test and the post-test knowledge score of the staff nurse regarding the selected narcotic drugs. The methodology, ma'am, that I have choose for this my study. The first approaches is the quantitative approaches I have used it, in which I use pre-experimental approach. And the research design I have used, ma'am, it was one group pre-test post-test research design. And the sample technique I have used is the purposes sampling technique. And the sample size was 50 staff nurse, and the setting was the mental hospital Indore. And my tools was validated and had got validated by the experts, and the reliability and the validity of tools was tested, and the permission also has taken by the ethical committees. The tools which I have used for the conducting the study is divided into the two sections. That is section A, a demographic variables of the staffness like age, religion, educational status, qualification, year of experience. And section B, in that I have used self-structured questionnaire, and then the data were collected and analyzed. The result of my study was, ma'am, in the pre-test, some staffness are having the 54% poor and 30% of average, and then 60% of good knowledge. And in the post-test, it has that poor knowledge was 12%, average was 12, and the good is of 76%. So so it says that is quite effective. And the mean score was pre-test, it was 10.9, and it goes to the post-test of 24.8. That is effective. That is significant, highly significant. And the demographic variables, age and educational qualification, and the year of experience has found it significant. So the pre-test mean in my study was 10.9, and this post-test was 24.98. It's a mini research, ma'am. It's a research project, and it is the graphical presentation of the post-test and the pre-test. And the conclusion of my study was the teaching which I have used to teach the staff nurses. It has found that it have some effectiveness that they can change the knowledge of the staff nurses. Thank you so much, ma'am. Thank you, ma'am.
Madam, you can close the slideshow.
Okay, sure.
Payal?
Yes,
was it a narcotic or you wanted to say psychotropic medication? What it was? Narcotic or psychotropic?
Ma'am, it was like
used in the mental health sector, no?
Yes,
so what you wanted to say?
Actually, I wanted to say, ma'am, that in this actually the psychotropic, everyone knows about in the psychiatric hospital about the psychotropic drugs, about the antidepressants, about the various classification of the this drugs, ma'am. But some actually what happened, this is my personal experience, ma'am. In Indore, we have went for this psychiatric posting, ma'am, and there the staff nurses are actually students. We have taken student there, ma'am, and students are asking the staff nurse there, why you are giving this morphine, why you are giving this tramadol to the patients. So some nurses, they are not those who are very having the year of experience, that is some old age or some 50 plus, or they are not actually having that point that why they are giving this, as they said that it's prescribed by the physicians, that's why I am giving this. So it is a I felt that, ma'am, it is a it is a need that I should have to clear my student that why in this psychiatric patients we have to use the narcotic drugs. So that's why, ma'am, I have chosen this topic, ma'am.
No, but do you have any reference about this? Because whenever in research we are talking, we need to have a reference that such studies have been done in which the staff nurses are lacking in their knowledge about the narcotic drug administration and all. Have you gone through any review in which the reference says
yes,
this?
ma'am. I have gone through 2 to 4, 5 researches, ma'am, in which actually, ma'am, what happened now, when actually this I have discussed about my demographic variables in the GNM, that staff, those who have done the GNMs, they are having some lack knowledge about this narcotic drugs, ma'am. So I have also searched, ma'am, about this, and how I have found some review, ma'am, about this.
So you put it in reference that the GNM staffs have less knowledge about administration of.
Ma'am, that
this must come.
The variable, ma'am. In demographic variable, I have. Okay, ma'am. I will put into it.
No, demographic variable. In demographic variable, it may not come. Okay, so then what was the content of your standard teaching program? Structured teaching program.
Ma'am, in the content I had, ma'am, 2 drugs I have specially taken, ma'am. morphine and tramadol, ma'am, because in that hospital, these two drugs are using frequently, ma'am. That's why I have taken two. In that, I have given the side effects and contraindication, actions, and adverse effect of that drugs, ma'am, and the nurse's
Okay.
responsibilities.
Okay. So this was only for staff nurses you conducted?
Yes, ma'am. For the staff nurse, I have conducted those who are working in that present hospital,
Only
ma'am.
for no, I must have missed your slide about demographic and what were the age group in which
Yes, sure,
the
sure,
knowledge
ma'am.
was lacking?
Ma'am, I have
What
not
was the
mentioned in
age
the
group?
slide. Madam, I
Ah.
have not mentioned in the slide, but I can tell you, ma'am.
Yes, you tell me.
Ma'am, the age group of above 40, ma'am. I have found significant that the nurses are not.
They don't have updated knowledge about how to
Yes,
administer
ma'am.
a
Because of lack
narcotic.
of the staff development program, and because of they were studied very previously, and because they are having 30 years, 35 years of experience, that is 20 years, 25 years of experiences, ma'am. So they have some lack of knowledge about narcotic drugs.
So you mentioned in references you got this?
Yes, ma'am.
In references you got this? That you
Ma'am,
need
not
to mention
exactly
always,
age.
okay? We cannot make.
Yeah,
Yes.
sure, ma'am. I will mention, ma'am. I will mention, ma'am, that.
And what was the duration of structured teaching program?
Ma'am, duration was 45 minutes, ma'am.
And session?
By PPT I have taken. Yes, ma'am.
No, only one session?
Yes, ma'am. Only one session. I have no, ma'am. Actually, in that they are having I am having the sample size of 50. So I did not have that all the 50 together. So I have taken 10 groups, and then I have gave them that presentation.
Yeah, but for each individual, only one session, no? Only one session, no?
Yes, ma'am. Yes, ma'am. Yes,
yeah. So in 45 minutes, you taught them that. So
Yes,
did you include the act of using these drugs?
Yes, ma'am. Actually, I have mentioned some point that the dosage of all these drugs and what are all the nurses what are all the.
Is there any existing act which need to be taught to them about use of narcotic drugs?
Ma'am, and NDPS Act I have, but I didn't mention to them, ma'am.
Need to mention because they need to know that how serious it is. Okay. Narcotic and Psychotropic Substance Act. Okay. 1985 and then revised one, you need to tell them because if you don't tell, they will not understand that there are legal implications of these also. Okay. Because morphine and all are the drugs which can cause serious issues with the mentally ill patients, especially when they are not eating for few days.
Yes, ma'am.
Okay. There can be sudden drop of blood pressure and they can collapse also. Okay. So we don't do like that. So these things should be included in your study.
Yes, ma'am.
Okay.
Okay, ma'am.
Madam, Nirja madam is there? Nirja ma'am is there?
I think this.
She will come, I think.
Vasanta, you can.
Yeah.
Vasanta,
Yes, madam.
You can add on.
Yes, ma'am. Thank you, madam. And actually, as madam told, you could have not stopped with narcotics. You could have even included psychotropic drugs because as you have gone for updation, where you are going to update the knowledge of the nurses, in that case, I think this would have also been included. So that because these people are going to be there to provide this drugs for administer the drugs for the patient.
Yes.
So they should be updated with the knowledge. And also regarding that, what is the recommendation? What was the scope of your study? Can you tell me? What was the
Yes,
scope of
sure,
your
ma'am.
study?
The recommendation of my study is that, ma'am, we can conduct the staff development program to to the various states or the cities of these mental hospitals because as I have already told that because there is not staff development program because in the clinical area it is a less research in the psychiatric area. So it is a recommendation that by giving them education, by giving the training that of drugs, we can update the knowledge of the staff nurses.
Why could have you would have done a poster? No, have you done any poster and you could have handed over to them? They can That would have been useful for them because no, as the aging, you told no, they are getting aged, they are getting aged, that's why they are forgetting. So this updation would have been good in the ward and on the ward where they're working. If you're going to put the poster all with all the side effects and action and all the dosages, it would have been very much better. Okay, that would serve the purpose also. That is my view. Okay, thank you so much. Thank you.
Thank you so much, ma'am. Thank you, ma'am.
All the best. All the best.
Thank you so much, ma'am. Thank you for all suggestions, and I will keep it in my mind, ma'am. Thank you so much, ma'am.
Thank
you.
Next, Reena ma'am.
What is the sequence?
Hello.
Farooq?
Yes, sir.
Madam, next
Farooq, what is the sequence?
serial number 16.
16, okay.
AP 26.
Is it visible, sir?
Madam, you can continue.
Yes, yes.
My voice is audible?
Yes.
Good afternoon, good evening to all. Myself, Mrs. Reena Thakur from Index Nursing College, AP 26-2020. So for patient, we don't have to delegate your survival completely to the doctors and hope for the best, but you have to participate in your own cure and you have to fight. This is for the patient of the cancer patients who are fighting for themselves. The title of my study is Effectiveness of Structured Interventional Program on Knowledge Regarding Post-Effect of Parenteral Chemotherapy and its Management Among Cancer Patients. So in introduction, we all know about cancer. Cancer is a Greek language word that means crab, and it is increasing rapidly day by day in worldwide and especially in India also. So with the global burden of global burden of the statistics, which is estimated approximately 14.1 million new cancer cases in 2012, and 48% of these cases, including 54% of deaths, which are occurred in Asia. And in international data, the International Agency for Research of Cancer, that is Globicon Project, they have predicted that there will be double cases in the next 20 years of the cancer in India from 1.7 million cases, that is to the 2035. These projections will indicate that the absolute number of the cancer death will also rise to the 1.2 million in the same period. In Indian study, there was a study done by Sunil Rajpal. He was conducted a nationally representative household survey to examine the overall prevalence and economic burden of cancer in India. And according to them, estimatedly every 97 person in 1 lakh person will having the greater prevalence of cancer in the urban areas. In that cancer, the chemotherapy is a kind of treatment which uses the drugs to attack the cancer cells and to kill the cancer cells. It is a systemic treatment since the drug entering through the bloodstream and travels throughout the body and kills the cancer cells at their sites. So in the most of the cases, the intention is to destroy these cells wherever they may exist in the body. The chemotherapeutic drugs are chemically designed to target the cells which are dividing and rapidly growing cells. So once they reach the cancer cells, they will act to retard their growth and eventually resulting in their destruction. Then why I have selected this study in that chemotherapies. Is my voice audible?
Yeah, very much.
Yes, ma'am. Then chemotherapy is the most commonly used method or the treatment which is used for the cancer patient. In that, I have selected the references. In 2014, the Dipti Chopra and her fellow members conducted a study which was mainly aimed to determine the prevalence of adverse event in patients who are treated with the chemotherapy. And they have continued their study for the period of 2 years from 2011 to 2013. Over this period of 2 years, they have selected the 591 cases who have received the chemotherapy and they have found out that the 58% of adverse reactions mostly occurred in the age group of 41 to 51 years of patient, that is 27%, and patient who are treated, especially treated for with the breast cancer, 39%, they have reported the highest incidence of the high adverse drug reactions. And in 5, the patients mostly they are getting the medicines. These are cisplatin medicine which they are receiving, and these are the there are most common adverse reactions which are reported was nausea and vomiting, 23%, and the gastrointestinal system disorders, or we can say symptoms. And about 50% of the adverse drug reactions required the treatment, and 12% were considered serious. So in that study, actually pharmacovigilance of these drugs need to be explored, and the use of preventive measures need to be enhanced in order to reduce the incidences and severity of adverse drug reactions. In the same way, in 2017, the Leishram and the Wellenk, they have conducted a hospital-based prospective observational study for analyzing the pattern of adverse drug reactions. They have totally taken the 119 cancer patients. In those patients, they have found out a total of 106 patients were having the adverse drug reactions. And common drugs which are used were the cisplatin, cyclophosphamide, paclitaxel, and the 5-fluorouracil. Those were the common drugs which are used for the chemotherapy. In that, they have found the 87% of we can say cases having a probable score and severity drug reactions they have shown. In this way, they have also recommended that the observed adverse drug reactions were preventable, and they need the immediate or timely management for the better recovery of the patient. Another study was in 2016, that was descriptive study, which was to assess the knowledge regarding ill effect of chemotherapy drugs and its home management among cancer patients. In Uttarakhand, they have conducted that study, and they have took the 60 cancer patients who were undergoing chemotherapy, and they were selected by the consecutive sampling technique. In that, pre-test and post-test was taken, and they have found out that the pre-test knowledge score of the cancer patient was 9.41, and the 54% percentage was the pre-test mean, and 25% was the lowest mean percentage. In that, finding of the studies were also concluded that the cancer patients were having less knowledge regarding ill effect of chemotherapy drugs, so that the awareness programs regarding the ill effect of chemotherapy drugs should be organized for the cancer patients. In this way, and with my clinical experiences, I have selected that study for the to provide the sufficient information regarding the post effect of chemotherapy, and to manage them for the cancer patients. Statement of the problem is a study to evaluate the effectiveness of structured interventional program on knowledge regarding post effect of parenteral chemotherapy and its management among patients admitted in the oncology units of selected hospitals of Madhya Pradesh. Objective of the studies were to evaluate the knowledge regarding effect of parenteral chemotherapy and its management among patients admitted in oncology units. Second objective was to compare the knowledge regarding post effect of parenteral chemotherapy and its management before and after the administration of a structured interventional program among patients. Then third objective was to evaluate the effectiveness of structured interventional program on knowledge regarding post effect of parenteral chemotherapy and its management among patients admitted in oncology units. The hypothesis of my study was there will be significant difference between the mean pre-test and post-test knowledge score regarding post-effect of parenteral chemotherapy and its management among patients admitted in oncology units at the less than 0.05 level. Delimitations of my study were, the study was limited to the patients who were admitted to oncology units and undergoing the chemotherapy in selected hospitals only, and assessment of knowledge only once before and after the administration of structured interventional program. In methodology, the quantitative research approach was used for the study, and research design was the pre-test, pre-experimental, one group pre-test and post-test design was selected for the study. And the conceptual framework was the King's Imogen goal attainment theory was selected for the study. The variables of the study were independent variable was the structured interventional program on knowledge regarding post-effective chemotherapy and its management is the independent variable. Dependent variable was the knowledge of patients admitted in oncology units. Extraneous variables well included in my study were age, gender, marital status, educational status, occupational area, residence, that is urban and rural, history of cancer in family, history of recurrent infections, habits, number of chemotherapy cycles, receiving, and body system affected with the cancer, and previous information about parenteral chemotherapy post-effect and its management. The sampling technique setting was selected for my study was Index Medical Hospital and Research Center in Indore. Population was the patients who are admitted in the Index Medical Hospital and Research Center. 30 samples of subjects were selected for the study. Sampling technique was selected, that was convenient sampling technique. In my tool, I have selected, tool was divided into two sections. Section A, that was demographic variables. In that, I've included age, gender, marital status, educational status, occupation area, residence, history of cancer in family, history of recurrent infection, habits, number of chemotherapy cycles receiving, body system affected with the cancer, and previous information about parenteral chemotherapy post-effects and its management. Section B have consisted of 36 multiple choice questions that was about parenteral chemotherapy post-effect and its management. Sample selection criteria, and that inclusion criteria of my study was both male and female cancer patients who are receiving parenteral chemotherapy were selected, who are receiving parenteral chemotherapy weekly, and who can read and write the Hindi or English, who are willing to participate in my study, and who are available at the time of data collection. Sample selection criteria, in that exclusion criteria was patients who are critically ill, patients who are receiving more than 3 chemotherapy cycles, and who are professionals from the medical or nursing field or any other professional field, medical field. Validity and reliability, in that validity was established from the 5 nursing experts and the other 4 the physicians, doctors. I have taken the validity, and reliability was also done of the test tool. Then ethical permission was obtained from the institutional review committee, and also permission was taken from the medical superintendent of the hospital for conducting research. In analysis, the section 1, that was effectiveness of structured interventional program on knowledge regarding post-effect of parenteral chemotherapy and its management among patients admitted in oncology units. In that, comparison of the mean pre-test and post-test knowledge score was the mean score was 9.7, pre-test mean, and post-test mean was the 22.73. Standard was that 5.54, degree of freedom was 29, and t-value was 12.79. That was the significant at the level of 0.05 level. That was the comparison of the mean pre-test and post-test. That was 9.7 and the 22. In implication, in nursing, the nurses can include the this management of chemotherapy post-effect as a part of their routine care to improve the effect of chemotherapy. The nurses can develop the models or the posters and charts for managing the chemotherapy post-effects at home for the cancer patients, insisting the patients to follow the activities to cope up with chemotherapy post-effects and preventing the severe complications. In nursing education, nursing educator, they have to emphasize the importance of management of chemotherapy post-effect. They can organize the seminars, workshop, and symposium on chemotherapy post-effect and their management. They select and organize the learning experiences for the student, wherein the knowledge will be enhanced about the management of the chemotherapy post-effects and their management. They can motivate the students to have more discussions on the management of chemotherapy post-effect. In nursing research, the study lays a foundation to appraise the management of chemotherapy post-effect. They can create, or some we can say medical profession can create the website where the information of the chemotherapy post-effect on the patient and their management can be disseminated. The study finding can be utilized for secondary analysis and meta-analysis of the studies. Then participating nurses and postgraduate students may utilize these findings for validating the need for interventions and for managing the chemotherapy post effects. In recommendation, chemotherapy post effect and its management booklet that I have prepared for my study that may be utilized in the cancer clinic to improve the knowledge and practice of the patient receiving chemotherapy. These booklets can be given to patients at our investigator parent hospital, and it will be recommended to other affiliated healthcare institutions. Then comparative studies can be done to assess the effectiveness of structured interventional program on knowledge and practice may be undertaken. Qualitative studies can be done to assess the lived experience as a chemotherapy of the chemotherapy receiving patients. Another comparative study can be done among the rural and urban patients. Individual focused nursing intervention can be covered and tested for the their effectiveness among the patients, and a family focused nursing strategies to improve knowledge and practice on chemotherapy post effect can be carried out. Limitation of my study were the study was limited to the patient of the selected hospital that was selected by me for my study, and sample size was limited, that is 30 only, and the study was limited to those who can read and write in Hindi or English. These are the references of my study. Thank you, ma'am. Can I stop sharing, ma'am?
Yeah.
Good evening, ma'am.
Hello, good evening. Arena, I have few questions.
Yes, ma'am.
The management which you have included in your management or your teaching program, intervention program, that was what was the content of that? From where you have taken the content?
Ma'am, content actually I have taken from different certain booklets are also available, or certain materials by known we can say organizations like Tata Memorial and all. They have also they have also prepared some small booklets or small pamphlet like structures for giving the knowledge regarding management of these chemotherapy side effects. So from that and from book also I have taken the content of my booklet or intervention.
Okay, but it was ready-made available with in the site of Government of India's non-communicable disease site, Ministry of Health and all that you
Ma'am,
have checked?
complete material is not available. They have given in some parts, like some have given regarding anemia. If they have a low HB because of the that chemotherapy side effect, what they have to do. And some have included the only alopecia, anemia and fatigue. Means they have included some part or 2 to 3 complications. Yeah, we can say post effects. So I have concluded the 15 in that. The systemic these complications are also a post effect, and the some depression hai, and or we can say social effect hai, social self image jo hai unka, that all I have also included. So I have selected some 15 points that post effects that they can manage at their home. Not the we can say I did not included in that the medical treatment, or we can say the medicines and all. I have just included the general management they can that they can use at their home, and it will be helpful for them at home how they can maintain their health, and they can reduce these side effects or post
Who
effects.
all were included in this?
Yes, ma'am.
Who all were included in this?
Cancer patients, ma'am, who are receiving sample, ma'am, or
Yeah.
post effect samples. Sample, ma'am,
No.
actually cancer patients जो chemotherapy जिनको receive हो रहा था weekly. Actually, some doses are given in monthly and all, but I have included weekly because I have to given the post test also. So pre-test on the day when they come, and after 7 days they are also come for that weekly chemotherapy. So on that day I will taken the post test, so that I have chosen the patients who are receiving the weekly chemotherapy.
Okay. The second question is there any caregivers was involved in your study?
No, ma'am.
Because
Caregivers are
most of
not.
the cancer patients are so much,
Yes, ma'am.
they are drained after chemotherapy and all that.
Yes.
So many times they need help from the caregivers. So any family member was involved?
Ma'am, actually, they was there at the time of education, but in my study, I have to give an education to patient only, and they are patients. Actually, they are. I have taken patient only from first to 3 chemotherapy cycle. At that time, they are not that much actually aware regarding the post effect, because after that 4, 5, and 6 cycle they have also received. At that time, they are very much aware regarding the post effects, how much they will be affected, and how much the post effects will be we can say occurring to them. So family members were there, but mostly I have to give attention to the patients.
No, because the cancer therapy goes in a long way,
Yes,
isn't it?
ma'am.
It is not a
Yes,
matter
ma'am.
of a day or so.
Yes, ma'am.
Like, so it is always better to include some support system so that your system, whatever you have taught, does not fail.
Yes,
right?
Yes, ma'am.
Means
Yes,
even
ma'am.
one caregiver they come na with the caregiver because the patient is not that
Ma'am, they
well.
were there. Yes, ma'am. They were there.
They
But
should,
yes,
should be
ma'am.
included.
They were there all the time.
And you have given booklet to them or you have taught?
Yes, ma'am. I have given booklet to them because they can take it home and they can read it afterwards only, because in my that 40 minutes they are not that much we can say attentive, especially patients, because they are very much anxiety regarding the treatment also. So
That
at
is
that
what I'm
time,
asking because
yes,
yeah.
ma'am. Yes, ma'am.
So
That's why I have given
caregivers
them
must
the
be
booklet.
included. Huh? Caregivers must be included.
Yes, ma'am. Yes, ma'am. Actually,
Because
ma'am, I have got.
that makes your study full. One.
Yes,
Second is your sample size.
30. Yes,
Your
ma'am.
sample size is very less, which will
Ma'am,
not
actually,
make any generalization and all.
yes, ma'am.
It is just a
This
pilot
is
study, like, so you can
yes,
expand
ma'am.
your
This is
study.
a pilot study. Yes, ma'am.
So you can make more, you can include more patients and with caregivers.
Yes.
So your
Yes,
number
ma'am.
will be more.
Okay, ma'am.
One patient and one caregiver who is
One
very
caregiver.
close to him and stay with him in the family for most of the time. Okay. So
Yes,
those
ma'am.
things has to be done in your study. Okay. Chalo, all the best. Madam, Vasanta madam, Maya
Thank you,
madam.
ma'am. Thank you. Maya ma'am.
मैम आपको अनम्यूट करना पड़ेगा. मैडम पाटिया मैडम, आपको अनम्यूट करना पड़ेगा खुद का. हाँ जी, बोलिए.
Reena, I like to know, after giving this education, were patient happy to get that knowledge?
Yes, ma'am. Patients
Was
were
it
happy.
effective? Was it effective?
Yes. Ma'am, yes, it was
How
effective.
How you have come to know?
Yes, ma'am. By the statistical analysis, I have come to know that the teaching was effective, because after 8 days I have taken the post test and all the data I have statistically analyzed, and after that I have come to know that data was significant, and because of that I've come to know, and also the patient's knowledge level was increased after the booklet or the intervention.
No, give me one example. For example, that drug was introduced inside. Okay. So how he could take care कि future में उसको complication नहीं होगा, something like this.
मैम एक्चुअली मोस्ट ऑफ द पेशेंट्स वैसे saying कि उन्होंने कहा कि हमको ये कॉम्प्लिकेशन हो रहा है तो अभी कभी ठीक नहीं होगा, बट मोस्ट ऑफ द जो पोस्ट इफेक्ट होते हैं मैम, दे आर आफ्टर द कीमोथेरेपी कंप्लीटेड दे विल बी ऑटोमेटिकली डिक्री, और वी कैन से नहीं होते हैं उनको, बट दे थिंक कि दैट विल बी लाइफ लॉन्ग. तो आई हैव टू मेक देम अंडरस्टैंड कि ये जो कॉम्प्लिकेशन है ये तभी तक है जब तक कि आपका ट्रीटमेंट चलेगा, एंड आफ्टर दैट ये जो है कॉम्प्लिकेशंस वो खत्म हो जाएंगे, और अगर आप इसका टाइमली ट्रीटमेंट या होम मैनेजमेंट करेंगे तो ये सीवियर नहीं होंगे, सो दैट आपको बार बार हॉस्पिटल नहीं आना पड़ेगा इन बिटवीन इन कॉम्प्लिकेशंस या पोस्ट इफेक्ट्स के लिए.
और आपकी जो कंटेंट वैलिडेशन में कौन कौन लोग थे?
मैम कैन आई टेल द नेम्स?
No, not the names, but you can tell their post and area of work.
Okay,
No
ma'am,
need to
one
tell name,
ma'am
but
from
their area
Jabalpur.
of work.
Ma'am, one
Their
ma'am.
area of work.
Ma'am, hospital also, ma'am. Some doctors I have taken from government hospital, and from my index hospital also. From those are treating the cancer patient, जो कि chemotherapy patients को introduce administer करते हैं, and also nursing field के जो experts हैं, जो we can say PhD level के हैं, or in different places like Gwalior and Jabalpur also. I have taken those validators
उनका
as a
consent form
validator.
किसने भरा? Consent form?
Yes, ma'am.
Patient का consent form किसने sign किया?
Ma'am, patient से ही करवाया है, from patient only.
Okay.
Yes, ma'am.
Chalo, you expand your sample size has to increase, huh?
Yes,
And you
ma'am.
just see whether the booklets are ready-made available, so you don't have to work much
Yes,
on
ma'am.
that.
Actually,
Okay.
I have made a booklet like this. This was prepared in Hindi and English also. So if the patient who are able to understand Hindi, so for them, I have mainly the Hindi patients are there. In our hospital also, they like to understand in Hindi only and read Hindi. So मुझे हिंदी का ही booklets मैंने ज़्यादा prepare किया, but I have also prepared the English booklet also.
You have taken help of anybody or you did individually?
Individually, ma'am, but ma'am, I have a guide also.
Okay.
Who completely all throughout the study helped me.
Okay.
I cannot take name if they permit.
Sure.
I can take name otherwise.
No, not required. Okay, it's all right.
Okay.
Chalo,
Reena, thank you. Ma'am, shall I continue, ma'am? Shall I continue?
Yeah, surely. Mine is over.
Reena, a very nice study, Reena, because it's a cancer patients and really appreciable one. You prepared a booklet.
Thank you,
So
ma'am.
which is a very good intervention. My concern is, like Madam also was telling, 30 sample size. Extraneous variable, I think I've showed many. So in that, to control the extraneous variable, it's very important that you need to have many number of subjects. Also for generalization, that is more because as a, because you have to make it as evidence based. This has to go for evidence based practice. Your research last output should go for an evidence which should be practiced by everybody. In that case, you better increase the size. Also, another thing is homogeneity of subjects. I don't know how much you would have maintained the homogeneity, because what about their education level? All are educated?
Ma'am, all are educated. They are not too much educated. Actually, the rural area is there. So primary and
No, because
secondary
you have given
level.
a booklet. You have given a
Yes,
booklet.
ma'am.
Whether they are able to read, whether they
Yes,
are able
ma'am.
to read.
Secondary and primary level education, they can read Hindi easily. They can understand, and I have selected pictures also in that booklet, included pictures, so that by the help of pictures they can understand better.
Okay, and also other thing is the type of cancer and the dosage of the chemotherapy varies from one patient to another. So in that case, what about the complications? Whether you have included everything,
Maximum. Yes, ma'am. Maximum complication I have included commonly, because certain drugs, there are different drugs, and different drugs have common side effects, different. So now with the availability, I have included common post effects जो कि common drugs से होते हैं, chemotherapeutic drugs जो commonly हमारे hospitals में देते हैं. With the 4 to 5 drugs हैं commonly, मैम, जो cisplatin है, carboplatin and 5-fluorouracil है. So these common drugs are given in our hospital, and with these जो drugs है, इन्हीं के मैंने complications देखे, मैम, and those I have included commonly.
Okay. Another one of my suggestion is because it's cancer patients, they are going for a long-term therapy. They'll be going for the long-term cycle, and this will continue for some time. So in that case, better I think the knowledge could you want to get a very good output. You make it as a time series design. When you're going to go for a large sample size, go for a time series where you are introducing your teaching, and also 1 week you can introduce teaching plus booklet. So you can add something else. So 3 times post test is better. That will help the person because it will expand their knowledge more and they will not forget. And that will be good for them to continue with the intervention. They will be compliance. So that's very important that they are going with the compliance of your educational teaching. Okay. Thank you.
Yes, ma'am. Thank you, ma'am. Yeah. I will implement it into my study. Thank you, ma'am.
Sorry, I had some urgent work. I could not attend the presentation. Sorry for that.
It's okay, ma'am. It's okay, ma'am. No issues.
Okay, ma'am. Can I leave, ma'am?
Okay, Reena, then we will. Yeah, surely.
Okay. Thank you, ma'am. Thank you all.
Thank you. Next, Anu V, madam, please be ready.
Our sequence number is, Binu?
Serial number 10. Serial number 10.
Okay.
Anu madam, are you there? Anu Nair.
Good evening. Is my voice audible?
Yes. Anu, start sharing your slide. Anu madam. Anu madam, are you there?
Good evening. Is my voice audible to you all?
Yes,
Now
yes,
it is
audible.
audible.
Hello?
Yes, proceed.
क्या करो इसमें कैसे शेयर होगा?
प्रेजेंटेशन पे जाना तेरे पास है ना इसमें
Is my screen shared to you all? Hello?
Yes.
Good evening. I'm having technical problem. Can you please hear my voice?
Your voice is audible. Okay. Share the content.
Good evening to you. Good evening to one and all respected judges, delegates, and all. It's my highly privileged situation to present my paper presentation in front of you all. Myself, Ms. Anuvi Kumar from Index Nursing College. Today, the background of my study. All human life on this planet is born of woman. A woman is an important
Share your
person.
slide. Share your slide.
My slides are not sharing.
Yeah. Share your slide.
Ma'am, one sec.
To share the slides, organizers
Ma'am,
can help you to
ma'am,
share the...
Please click the share button first.
Ma'am, just a second, ma'am.
Anu madam, are you there? Anu madam.
Anu ma'am, are you there?
Yes, sir. Sir, is my screen visible?
No.
No, ma'am.
Please click the share button, the middle button. Share, you click it.
Yes, sir.
You
Sir,
are
I'm
sharing.
clicking that. Yes, ma'am. So then,
You are sharing by the phone or by the
sir, by the
laptop?
phone. Sir, by the phone.
By the phone.
Otherwise, let us start a presentation, introduction and all. Side by side, you try if you can show us the methodology, at least tell us the background and the objectives you can read out.
Ma'am, actually, in my Wi-Fi, because of that, I'm unable to share it by the laptop and I have to use the phone. Very sorry for the inconvenience, ma'am.
You have not sent the PPT also. Otherwise, we could have
Send to
shared.
the organizers the PPT, na? They can share for you.
Sir, 1 second, sir. I'm sharing this.
Yes. you do one thing. You share your you mail that PPT as soon as possible. You mail.
Yes, sir. So to you, shall I mail?
Yes, mail.
Mail or WhatsApp, which is convenient for you, you can do.
Sir, I have mailed that to you.
Your mail is not yet received.
Sir, I have received. I am sharing.
Okay, thank you, sir. Chia. Good evening to one and all present over here. Again, very sorry for the inconvenience because the Wi-Fi has not been working because of the internet connection. So, shall I start with my abstract presentation, ma'am?
Please start.
Okay, thank you, ma'am. Background of my study: all human life on this planet is born of woman. A woman is an important person in the family. She nourishes her fetus and gives birth to the child. Health of the mother is tender and wanted component of total care and cannot be neglected because of the fact that if mother is healthy, the child will be healthy, which in turn affect the nation's health. So next slide, please. Cancer is the second most common disease in India that is responsible for the maximum mortality, with about 0.3 million deaths per year. This is owing to the poor availability of the prevention, diagnosis, treatment of the disease. All types of cancers have been reported in Indian population, including the cancer of skin, lungs, breast, rectum, stomach, prostate, liver, cervix, esophagus, bladder, mouth, etc. So next slide. Globally, cervical cancer is the fourth most common cancer in women, with an estimated 560,505 new cases and around 284,000. Globally, cervical cancer is the fourth most common cancer in the woman, with an estimated of about 560,505 new cases and 284,923 deaths in 2015. Vast majority, approx 85% of cervical cancer cases and 87% of cervical cancer deaths occur in the less developed regions. So the cervical cancer records for roughly 12% of the female cancer and 10% of the females cancer death of poor to screening and treatment service. It is the second most common cancer and the most common causes of cancer death among women in less developed regions. In India, cervical cancer is the second most common cancer, with an estimate of about 132,314 new cases and 73,337 deaths in the year 2015. Cancer of cervix is largely preventable. The risk can be minimized by promotion of sexual risk reduction behavior, genital hygiene. Further prevention can be achieved by screening using visual inspection with acetic acid VIA or pap smear test, which can detect precancerous lesions early so as to prevent progress towards invasive cancer by timely treatment. Need for the study. There are 6,40,867 villages in India. According to 2011 census, the population of rural women who are literate are about 58.8% by census 2011. According to the 2007 revision of world urbanization prospects by the United Nations, India would continue to have the largest rural population in the world until 2050. Ashwati ET on cervical disease screening program in Kerala was conducted a study that announced that proper information of cervical cancer growth was a basic component in deciding if women would experience a Pap test or not. In spite of the fact that the 3/4 of the rural population in South India realized that carcinoma cervix could be recognized right on time by a screening test, just 2.2% had the Pap test done. The statement of my study is a study to assess the effectiveness of video-assisted teaching or knowledge regarding early detection and prevention of cervical cancer among women from selected community areas of Indore, MP. Here, the community area that I am taking is rural area. The objective of my study is to assess the knowledge regarding early detection and prevention of cervical cancer among women from selected community areas of Madhya Pradesh before and after the administration of video-assisted teaching, to determine the effectiveness of video-assisted teaching program regarding early detection and prevention of cervical cancer. Third, to find the association between the pre-test knowledge scores regarding early detection and prevention of cervical cancer with the selected demographic variables. H1, there will be significant difference between the mean pre-test and post-test knowledge score regarding early detection and prevention by the P is 0.05, and H2, there will be significant association of the mean pre-test knowledge scores regarding early detection and prevention of cervical cancer among women from selected rural areas of Indore, MP with their selected demographic variable. The material and method, the research approach was quantitative evaluative research approach. The research design that used in the study was one group pre-test, post-test, research design test was adopted. Research variables, independent variable. It is the intervention or treatment that the researcher performs to see the change in resulting change on the dependent variable. In the study, independent variable is video-assisted teaching on cervical cancer, whereas the dependent variable were the females residing in the rural areas. The sample in the study consisted of women from the rural community areas, that's Buran Khedi, that's from Indore, MP. The sample size was 30 women. The sampling technique used in the sample was purposive sampling technique, which because of the limited amount and time availability of the sampling criteria. Inclusion criteria of my study was women, those who are willing to participate in the study, women who are available at the time of data collection, who are able to read or write Hindi. The exclusion criteria was who will not be willing to participate in the study and those who cannot read and write Hindi. The tools used in the study were structured questionnaire to collect socio-demographic data, structured questionnaire for arising knowledge regarding early detection and prevention of cervical cancer. Video-assisted teaching program was being prepared by me regarding the cervical cancer, its detection and prevention, where everything was described clearly to the people. The reliability of the tool was established by using split half technique. The demographic data used in my study consisted of 11 items like age, religion, marital status of the woman, age of the woman at her marriage, number of times she has conceived, method of contraception used, educational status of the woman, occupation, any kind of addiction she is used to, family income, history of cancer in the family, history of recurrent infections, previous information about cervical cancer, and have she ever done Pap test before. The structured questionnaire consisted of 32 questions covering early detection and prevention of cervical cancers. The items were of 32 multiple choice type with one correct answer, which covered entirely all the process regarding the cancer, the types of cancer, what all the causes, how it can be detected, and what all are the prevention and treatment. Prevention, till prevention. Now, ethical consideration was being taken. The investigator considered and followed the ethical principles preceding the investigation. Approval was received from the ethical committee. Permission was taken from the Sarpanch of the village. Content validity was received from the various experts in the field of medical, nursing, and cancer. Method of our data collection. The investigator has obtained formal consent from Sarpanch of Begum Khedi, Indore. The purpose of the study and confidentiality was explained to the patient. Firstly, they were hesitant, but I assured them, some of them were having problem regarding answering personal questions, but then they answered it. The investigator selected 30 female women as per the inclusion criteria. They were selected by purposive sampling techniques. Group was assessed for the knowledge for early detection and prevention of cervical cancer by performing the pre-test. The video-assisted teaching program was implemented and the post-test was done on the 7th day. The analysis revealed that the overall pre-test mean was 6.8 and post-test mean was 17.73. The t-value was found to be 14, which was statistically significant. In the knowledge questionnaire consisted of 32 multiple choice questions with 1 correct answer. The marks were further graded as poor knowledge for 0 to 8 marks, fair knowledge 9 to 16 marks, good knowledge was 17 to 24 marks, and excellent knowledge was 25 to 32 marks. In the post-test, 12%, that is 40% females had obtained poor knowledge score. 3 women had obtained fair knowledge, 12% of women has obtained good, and 3 of them has obtained excellent knowledge score. This was a comparison of the pre-test and post-test knowledge score. The comparison of the mean test and post-test knowledge score. Next slide. The pre-test, the knowledge was mean score with standard deviation was 6.8, and in the post-test it was 17.73, and the t-value was 14.10, which shows there's a significant increase. The comparison of the mean post-test knowledge score of the pre-test as well as the post-test. The above table shows the comparison of the pre-test and post-test knowledge score. The pre-test knowledge score was 6.8, while the post-test knowledge score was 17.73, and the computed t-value was found to be 14. The difference was found to be statistically significant, showing a significant higher post-test in comparison to the pre-test knowledge score. Thus, the video-assisted teaching program was helpful in improving the knowledge score of women from the community area. To support my study, Ornell J. and H.O.K. Jackson in 2016 developed and evaluate educational videos to promote cervical cancer screening among Karen, Burmese, and Nepali Bhutanese refugees. Through video informations were provided to them, their knowledge about cervical cancer and screening also improved significantly. In the above mentioned study, there was significant increase in the knowledge after watching the video. Hence, this study supports my study. In my study, there was significant association was found between the religion of the woman, number of times she has conceived, method of contraception used, educational status of the woman, previous knowledge about cervical cancer, and whether she has done Pap test or not. Similar study was conducted by Karam Butlu 2013 in Turkey. The number of women participating in the study increased with the age, duration of marriage, number of births, knowledge about the Pap smear, perception of cervical cancer was significantly associated. The study concluded that the importance of Pap smear test needs to be explained to Turkish women by health staff, and this study supports my study, and hypothesis 2 is accepted. Between the pre-test score with the demographic variable. The nursing education for the study that can be used is knowledge can be imparted to the young girls so that they can be timely vaccinated to the disease condition. Planned education program could be organized in wards, outpatients, departments, and the community. Nurse educator have to emphasize the importance of screening methods and Pap smears. The study finding can be used for the nurses and midwives for updating the knowledge of the counseling of the woman regarding the prevention of cervical cancer in their reproductive age. Nurses can educate the woman regarding the administration of vaccination for cervical cancer to the girls at their correct age. Through nursing practice, the study finding can be used as an improvised knowledge for the community nurses for imparting health awareness to the women from community area. The industrial nursing fraternity can use the findings and the video teaching in different corporate and technological sectors for the health campaigning during the yearly health checkups in these enterprises. For the nursing research, the study findings can be utilized for secondary analysis and meta-analysis of the study about the management of cervical cancer and regarding the surgeries for the same. Practicing nurses and postgraduate students may utilize the findings to validating the need for intervention for managing cervical cancer and its vaccination. It is essential to identify the level of knowledge for girls regarding cervical cancer and its vaccination. My recommendation for the study findings shows the effectiveness of video-assisted teaching or knowledge regarding early detection and prevention of cervical cancer among women, and therefore recommends the following. Comparative study can be done to assess the effectiveness of structured teaching intervention program. Comparative study to assess the effectiveness of video-assisted teaching of cervical cancer among rural and urban patients can be carried on. Structured intervention programs of cervical cancer vaccination and its effectiveness can be studied in large settings. The limitations of my study was during the study, the women were hesitated in the initial period to participate in the study, and the study was limited to only one community area of Indore, so it cannot be generalized. The references of my studies are as follows. Thank you, ma'am, for patient listening.
How, what was the difference between there are so many studies regarding cervical cancer and the vaccination, if you see the literature. What was your extra contribution towards the, maybe for the society or for the profession with your study?
Ma'am, actually, the women who are living in the rural community areas, they are very much outdated and are not treated equally with the men. Since I have seen that because the women were confined only to the home, or either they were maids, they were doing the home care works and etc. So when I was dealing with a female, I was able to understand the things that many of the females were not properly interacting also, but after repeatedly saying they were interacting, and they were saying many of them were having irregular menstrual cycles also, white discharges also, but they were not that frequent, they were not going to the hospitals, and they were not saying, मतलब कहीं ना कहीं उनके अंदर वो हिचक थी जिसकी वजह से वो सारी चीजें क्लियर नहीं कर पा रही थी.
Common in urban areas also, if you see.
Yeah. Ma'am, urban area.
In urban areas also, and women are not going for why? What is the reason of increase in incidence of breast and the cervical cancer? This is the basic, because the women are not reaching to the hospitals for their primary preventive checkups. That is a common problem in urban or a rural area. That's what is your contribution separately? Why you have done this study? Why so much of efforts you have done?
Ma'am, because urban females are still working. Some of them are working, some of them are having knowledge, but the women in the rural areas, they are not that much educated. They are not that much privileged to go. Still, Ghungat Pratha is there in the village where I was there. Females were under the Ghungat. They were always behind their husbands. So they were not that open up. In females, those who are residing in the urban areas, they are still far better condition for the female, those who are residing in urban areas, rather than the women who were in the rural areas. And when I was doing the study, I felt much happiness in my heart that yes, I was able to help these females to get some knowledge to them.
Is knowledge enough for
no, ma'am, the importance,
practice,
the importance,
yeah.
Importance and practice.
See, you are not understanding the dynamics of the families in the village. Who takes the decision on the behalf of women?
Male,
then
madam.
It is important to actually change the attitude of the people who take decision for the health utilization of the women in the villages. Even this is very common in urban areas. How many women have the freedom to take decision about their health? That is
many of
just giving information to women is not enough. And never underestimate the women. Some of the women are excellent if they are living in the rural areas. They know the things, but how to that change in the attitude of the family members and the community, that is important. That is my concern. Rest I will leave to the other panelists.
Anu, how many after you have shown the video assisted teaching, how many of them have gone for their regular checkup?
Ma'am, they were saying
after
that they
you
will
have
go for
shown
the
you got my question?
Yes, ma'am. Ma'am, after showing my videos, many of the females, they were saying to administer the vaccination to the female girls also. And they were saying that, yes, they will go for the pap test also. And some of the females also are having white discharges and all. They were saying that, yes, they have to go to the hospital for their checkup also. So statistically, they were saying.
Did you confirm? Did you confirm that they have gone after your video assisted teaching and they got themselves checked?
Ma'am, actually, I am working in Index Medical College. So I said to them that whenever you will come, you will be getting preference. So you just come. So they were saying that, yes, surely they will come. And after that lockdown and all these cases all happened, and I was not able to identify that whether they all went to or not.
How far is your hospital? How far is your hospital from that rural area?
Ma'am, it is far, but yes, my
See,
hospital
you
is
have to
providing.
consider when you give all these things, health, education and the facilities to the women, you have to think how they will come, who will bring them, can
Ma'am,
they
my
afford all, no, please see, you should read all
Yes,
these
ma'am.
studies. Or you should read all these studies why women are not utilizing these services. It is not that they do not know or they don't want to utilize. These are some of the reasons. What is the importance of women in the society? Do people think that women needs a health checkup? So these are the some issues you should bring in your studies. This will increase the validity of your findings. Otherwise, the studies have very less value. Okay, that is the concern. Most of the things you should.
Yeah. Anu, if you would have done a follow up, no, after this video
Yes, ma'am.
assisted teaching, maybe
Yes, ma'am.
after 15 days or 1 month, or you would have taken the contact number of the family member and asked whether you are gone or not, and the service points are to be identified and told to them that in this particular PSC near your village, you don't have to come to Indore. Near your village there is a
Yes,
PSC
ma'am.
and there these facilities are available. That, see, what is our role? Our role is to take them to the treatment part, isn't it? So
Yes,
that
ma'am.
we could have ensured by follow up studies.
Yes, ma'am.
Isn't
Surely,
it?
ma'am.
Knowledge they forget.
Yes,
As
ma'am.
soon as you leave, your laptop is closed, they will forget
Yes,
about
ma'am.
it and they will be busy with their own work. So how many of them have reached to the nearby health center and got the help or got themselves checked up would have been more important and relevant to your to support your study.
Sure, ma'am. I'll
That is
keep
what
this.
I feel.
Yes,
Vasanta
ma'am.
ma'am, and sample size is very less, huh,
Yeah.
Anu?
Yes, ma'am.
Very
Actually,
less. Sample
this is
size
my
is just
ongoing.
30.
Yes, ma'am. This is my pilot study, and I'll be doing this main study also, and I'll be taking this point of yours.
Yeah, and one.
Yeah, always try to do something for them.
Yeah.
Then only.
Yes, ma'am.
Then
Yes,
only
ma'am. Sure,
our
ma'am.
nursing we can justify the nursing profession. Otherwise, we cannot.
And
Yes,
lip
ma'am.
services, lip services remain for very less time.
Yes,
If you
ma'am.
just talk, no, nothing will happen. But if you do, then they will always be with you and they will always listen to you. Okay?
Sure, ma'am. In my main study, I'll follow all your
Yeah,
points.
and one
Thank
thing
you.
more you should remember, these are the rural women's, and still you yourself are saying there is a Parda system.
Yes, ma'am.
Most of the families would not like to send their women to a male doctor.
Yes.
Okay, so these issues, the cultural practices, issues, values, you should take into consideration. Okay, that is
Sure, ma'am. Sure, ma'am. Yes, ma'am.
And increase your sample size.
Yes, ma'am. I'll do that. This is my pilot study, ma'am, and I'll increase the sample
And
size.
provide them with the service points and see that how they can reach
ma'am.
there. Okay.
Okay, ma'am.
Okay, all the very
Thank
best.
you, ma'am.
All the very best.
Thank you, ma'am, for your valuable suggestions. I'll keep it in mind, and I will do it in the further of my
Vasanta ma'am,
studies.
no, Vasanta ma'am,
Yes,
Vasanta
madam.
ma'am.
Yes, ma'am. I'm asking. I'm there, madam. I'm asked. I'll be asking. Thank you so much, ma'am. Anu, actually, madam was telling about the partner involvement. You have to take
Yes,
it into
ma'am.
consideration. So that is very
Yes, ma'am.
important in your area. Also, I think you can approach the village head and you can seek the cooperation and coordination of them, and you can arrange for a pap smear camp. Because even if they are not able to come, you can make that camp, because you have mentioned nursing implication, nursing education. It has to insist that the nurses should be like you have to give them education regarding pap smear. I think now nurses are trained to do pap smear by themselves.
Yes, ma'am.
Most of the nurses are trained, so you can also get the training and you can also go, because you can arrange for a camp and you can do that, and then you can identify what is the better screening than just giving them the knowledge that is not going to serve any purpose, I suppose. So you have to enter, you have to go down to work with them, and after identification, after getting the result, then you can go further. You can do a follow-up and just make them to go to the hospital for the further services. I think that will be better, Anu. And please go with the partner involvement, as Neeraja madam has told. Partner involvement is very important, because then
Yes,
only
ma'am.
they will abide by it. They'll listen to them only. Okay. And arranging a
Sure,
camp, I think that will, because they will not even come, because transport, conveyance, and spending the time and coming from the home on all that they will take care. They will not be able to do it. So you go to the head, village head, you speak and you just arrange for a camp. Okay.
Sure, ma'am.
That will be.
Sure, ma'am.
Thank you.
Thank you, ma'am. Thank you, ma'am.
Maya madam, Maya madam.
Neeraja ma'am is
most of teacher asked.
Mic.
So,
Neeraja ma'am's mic.
No, I let Maya madam say.
I also agree what Basanta madam and Madam Bharti also said, that there should be involvement of follow-up programs, and this only such kind of contribution study to strengthen, and it will be exposed to other studies. They will get encouraged by seeing your report. Yes, we can also do something for our India. Thank you.
Sure, ma'am. Yes, ma'am. Sure, ma'am.
And there are district cancer societies.
Yes.
You should actually collaborate with your state health mission and the district health missions. If you will not collaborate, if you will do these type of interventions independently, you will not be allowed to do, first of all. Second thing, you have to take into consideration the ASHA can help you, because ASHA is given so much of responsibility. She knows each and every person in the village. The way she can influence the family, you cannot influence the family in that way. So you should collaborate with them.
Oh, sure, ma'am. I'll surely take this into my
And there are
next week.
NGOs also, Anu. There are
Yes, ma'am.
NGOs,
yes, ma'am.
those who exclusively work for the cancer detection amongst the female members of the society. So they also can be helpful to you. Okay.
Ji, ma'am. Sure, ma'am. Thank you, ma'am, for your valuable suggestions.
Okay, all the best.
Thank you so much, ma'am. Thank you.
Best of luck. Yeah.
Thank you, ma'am.
Thank you, Anu madam. Farooq sir.
Yeah, thank you.
Who is next? Who is next?
Now, madam, we have finished everything.
Oh my God. Binu, that is such a respite for us, huh? Binu?
Thank you.
I think one student is not there. Shakuntala.
Yeah, Shakuntala, we tried her also, but she's not picking our phone.
No.
I think we are not able
You can
to connect.
contact her once. Once you can ring and or message. Otherwise, we will leave her. No?
We both have put a message. I think she's busy. That's why.
We can leave now. It is if she is not responding.
Yeah, if she's
It is
not
the
responding, then we can.
because it is the interest of the candidate. We cannot go on waiting.
First
Yeah,
we do
yes.
from morning, we will do it afternoon, but then also we both, I and Farooq, contacted her, but now she's not responding to both of us.
Okay. So shall we conclude then, Binu?
Farooq sir?
Yes, sir. It was very huge time has been taken, ma'am. We are supposing that it will be concluded 3 p.m. only. And we were discussing, me and Binu sir also was discussing regarding this.
Actually, we 10 is the ideal number for one day.
Yes, really, ma'am. Really.
We will keep note of this.
I
madam.
think more people have registered. More people have registered then after 25.
Yes, ma'am. More than 35 or 50, 35 has been registered, but ma'am, we have not included. We have included only 27 only.
Is it? Okay.
Because somehow we have seen their abstract. They were not completed their abstract also.
Okay.
Actually,
Out of this also, out of these also many you could have excluded.
Yeah.
Farooq.
Next time,
Yes.
what
Now you know now.
next time you can actually review the abstract first, then you can.
Yes, madam.
And the repeat studies, same studies and repetitions also can be excluded. Because if there is nothing like, then they get demoralized when they come. That is not nice. So you can always give importance, Farooq, to interventional studies, those who are coming.
Sure, ma'am. Sure.
So this platform will be having its own standard of accepting the papers. Not anybody can come. You just now increase your this thing and see that interventional studies. Always put, we will give weightage to interventional studies.
Sure, ma'am. Sure. This thing we were discussing regarding this matter only. I was telling to Binu sir that we have also excluded some more this article, this abstract, because some more abstract we have seen here only, ma'am. some
Okay.
some abstract suddenly we have included in okay, you can go for presentation like this, and some call also we have received, no sir, please accept this person to present for presentation. So
Okay, anyway, some obligations are there, so we
Madam.
cannot refuse some of the people. Anyway, that's
Yes.
not an issue, but next time we will keep our criteria as little more stringent so that better studies will come, okay?
Even
Sure,
for
sure,
the
ma'am.
poster, what you are planning, you can review in advance the posters.
Yes, ma'am. Actually, ma'am,
Madam, I
poster.
told them, Nirja madam, I told them that you yourself at your point, you see that these posters are not according to the standards given, you just refuse them. And you only give to the judges those posters which fulfill all the criteria, means we don't have to check. I send a message to Farooq in the beginning itself that you can do at your level.
Because
But it is a great effort, Farooq.
Yes, thank you,
Great
ma'am.
effort, a big platform for people, especially those who are doing their PhDs, MScs and all. They got a
Thank you.
platform to interact, okay? And
Thank you
I
so
know
much.
organizers will always have a sleepless night because small things are there in the mind, and many of them have not sent their PPT also. Like in spite of
Many
telling,
have
so
not
that organizer and coordinators have a great responsibility, I know. So then shall we
And,
conclude, Binu?
Otherwise, also it is a
Madam.
big learning for everyone.
Yes,
And
yes.
we have also taken more time for discussion because
Yeah.
there was a need
Yeah.
to discuss the issues.
If
Issues,
discussion was
yeah.
there, that's why the presenters has gave a special suggestion that it was very nice. We learned also because when we were doing
Yeah.
pilot,
Yes.
when they are
Yes,
present,
really
they
we have got the responses from so many persons have given this response. Then nowhere we have we have presented somewhere also, but nowhere we have got this type of critics and this type of suggestion we have not received somewhere.
Yeah,
Like
this is the actually drawback, Farooq. In our nursing big conferences also, they take hundreds of paper, but no one discuss, and the students go back with
Exactly.
the wrong conceptions.
from the
Yeah,
end,
mine was nice. No questions asked. Yeah, really.
mine and Farooq's that was paining. We rejected some of the candidates because we had to reject.
Yeah.
But it was really a painful decision.
No, it should not be painful. If you want to bring quality, you have to.
Yeah. You are done justice. You are done justice.
Yeah.
Yes. And
really appreciate
Farooq, the comments, no, people have sent like this, that you can put in your Nursing Teachers Association India's website also, no? People will read what are the comments given by the people, presenters.
Yes, sure.
Then